Ya, buenos días. Bienvenidos al primer simposio Soporte Digital Extracorpóreo, organizado por la SOCHIMI en colaboración con la Universidad de Finisterra y docentes de la Clínica Mayo, Alfred Health y Helios. Para comenzar, le voy a dar la palabra aquí al doctor Pablo Afún, vicepresidente de SOCHIMI.
Buen día. Antes de comenzar, por favor tome nota de algunas indicaciones que son importantes. Las dos salidas de emergencia se encuentran en la parte posterior del teatro, ¿sí? Una a cada costado. Y los baños también a la salida del teatro por esta puerta. Les recordamos que no está permitido ingresar alimentos ni bebidas al teatro. Y en caso de cualquier emergencia, les pedimos mantener la calma, permanecer en sus lugares y esperar las instrucciones del personal del teatro. Y ahora sí, en nombre de la Sociedad Chilena de Medicina Intensiva, les doy la más cordial bienvenida a este primer simposio de soporte vital extracorpóreo. Es un privilegio para nosotros organizar este evento en conjunto con el equipo del doctor Rodrigo Díaz, del Hospital San Juan de Dios y la Clínica Red Salud, y los equipos encabezados por Suraj Yalamuri desde la Clínica Mayo en los Estados Unidos, Julia Cole y Brooke Riley desde el Alfred Health de Australia y Stefan Vive desde Helios en Alemania, y cuya generosidad y entrega han sido fundamentales para hacer realidad esta instancia de aprendizaje y colaboración. Le extendemos un genuino agradecimiento a todos nuestros invitados internacionales. Su presencia y la oportunidad de compartir su experiencia enriquecen enormemente esta instancia y con seguridad nos inspirarán a seguir avanzando en la medicina intensiva y en las terapias de soporte vital extracorpóreo. Este simposio no sería posible sin el invaluable apoyo de la Universidad Finisterra y su decano de la Facultad de Medicina, el doctor Ernesto Vega, quien no dudó en facilitar las instalaciones de la universidad para que este encuentro pueda suceder. Muchas gracias a Ernesto, quien nos hablará a continuación, y muchas gracias a la universidad. Extendemos también nuestro agradecimiento a las empresas auspiciadoras que hicieron posible este evento, y de manera muy especial a Night Therapeutics por su apoyo a SOCHIMI y su compromiso constante con la educación médica continua. Un especial agradecimiento también a los equipos de apoyo de la SOCHIMI que trabajan tras bambalinas para que las cosas fluyan. Soledad González, que está arriba en acreditación, el equipo de Progital, el equipo de Origen, nuestros intérpretes, el equipo de becados de medicina intensiva de la UFT, quienes nos apoyan logísticamente hoy, y Lolo y el resto del personal de este hermoso teatro que nos recibe hoy. Finalmente, y por encima de todo, agradecemos la presencia de cada uno de ustedes que están acá. Sin su interés y apoyo, este evento no tendría razón de ser. Esperamos que este encuentro sea un espacio fructífero para el intercambio de conocimientos, el debate y el fortalecimiento de lazos profesionales. Bienvenidos, welcome, willkommen, y que disfruten todos del simposio. Muchas gracias. Voy a ceder el micrófono ahora al doctor Ernesto Vega, el decano de la Facultad de Medicina de la Universidad de Finisterra. Ernesto, bienvenido.
Hola, ¿cómo están? Buenos días. Voy a ser breve porque van a haber muchas bienvenidas hoy día. Para nosotros es un acto absolutamente natural apoyar toda iniciativa académica que realce la calidad del desarrollo de la medicina en Chile. Particularmente nuestro desarrollo en el área de medicina intensiva es muy fuerte, probablemente porque nuestro decano natural de este proyecto de facultad, que es el doctor Alberto Duñac, es intensivista y generó un nivel de desarrollo muy importante en la década pasada para que nosotros pudiéramos desde el año 2019 tener proyectos de formación de intensivistas. Tenemos proyectos de formación de intensivistas como subespecialidad de 2 años desde el año 2019, ya con 8 egresados intensivistas que están funcionando a lo largo de Chile gracias a ese proyecto. Tenemos 3 becas primarias de medicina intensiva que van desde la medicina interna 4 años, anestesia 4 años y medicina de urgencia en 4 años para formar intensivistas. y con eso ya tenemos un grupo más o menos de 20 intensivistas y que ahora salen las primeras generaciones de esas becas este año y el próximo. Uno de nuestros campos clínicos centrales para la medicina agudo es la posta central y la urgencia, donde tenemos una beca de urgencia con muchos becados de urgencia. Por lo tanto, la medicina agudo, la medicina intensiva, para esta facultad de medicina, en donde también kinesiología tiene sus proyectos de medicina intensiva, enfermería tiene sus proyectos de medicina intensiva, es muy clave y es una de las áreas prioritarias de desarrollo académico que hemos definido como prioritaria. Entonces, ¿cómo no decirle que sí a Pablo a la hora de solicitarnos las instalaciones para poder desarrollar este tipo de eventos? Esperamos que estén muy cómodos hoy día y que sea una gran jornada de aprendizaje antes de Fiestas Patrias para no dejar todo después del 18. Así que bienvenidos y gracias por estar acá.
Voy a hablar en castellano y en inglés para nuestro International Faculty, pero primero que nada, gracias por estar acá. Ustedes van a ver que esto va a que te contra vale la pena el uso de su tiempo. Digamos. Todos tenemos poco tiempo, pero créanme que esto es un regalo, y un regalo que recibimos de muy buena manera y que espero que disfruten en estas 48 horas. Quiero agradecer al doctor Vega y a la Universidad de Finisterre por darnos la facilidad de usar este tremendo anfiteatro. La verdad es que es un lujo. Y a Xochimilco por recibir la idea y asociarnos con ellos para poder... Bueno, yo también soy Xochimilco, así que... Pero toqué la puerta a Xochimilco y ellos aceptaron ayudarnos con el proceso del simposio, y entre eso ayudarnos también con la universidad, lo cual se agradece mucho. For international faculty, I just want to say thank you. The difference between interest and commitment, you know, it's like the breakfast. Chicken are interested in the eggs and ham breakfast, but the porks are committed to it. We're a little bit more like the porks, because you especially, because you fly over 8,000 miles. You came over here today morning and are here right now. So thank you very much for that commitment that usually ECMO people is very committed to crazy things like this. I mean, not just to the patients, but to education efforts too. So really, really, we appreciate your effort and your commitment. Thank you.
Hello, now we're going to see how good the translation service is working. Sorry for not speaking Spanish, but this is also a bit directed to the international faculty who might not have got everything that's just been said, a little housekeeping, and a little bit of the background of Suraj and myself. Thanks to everyone for coming here. Thanks for all the faculty who came like from all over the world to be here today. Thanks to our sponsors, particularly Soporte, who's our main sponsor tonight, and without whom all of this wouldn't have been possible. We had a bit of a journey, so just so you know how we came from. We started at some point an education program for ECMO, mainly to establish an education governance program in New Zealand. That's about 5 years ago. Just a small, like for one hospital, that became an international symposium pretty quickly, and now we've been on pretty much all continents all over the world with that. It's the first time that we're in South America, and we're very grateful for that. Thank you for the organizers, for Xochimilco, for having us here. Really looking forward. Yesterday worked quite well already with the practical skills that we have. There are a couple of really small changes, as always, on the program. It's mainly tomorrow. One of the faculty members unfortunately couldn't make it, so there will be a bit of a swap, but it's just like 2 talks. Will be a bit of surprises for you guys. And yeah, I think we just have like the housekeeping things that just been said. We just have to repeat something for the faculty who maybe did not get all of that.
Also, thanks to Brooke and Julia for partnering with us and coming on board this year, and especially to South America. Thank you. just in terms of what we'll do, we'll try to keep all the questions till the very end of each of the blocks. So each blocks have about 3 to 5 speakers. So we'll just take the questions from the audience at the end of the block. So I'm just asking if the faculty members, after you finish your talk, stick around, have a seat on the couch, and then we'll have the questions right afterwards, and then we'll just kind of finish that block of talks. We'll try to stay on time still for 20 minutes, as best as we can. And we have excellent registrars and fellows who are going to help you out by giving you clues of how much time you have left with hand signals. You'll have 5 and 2 minutes. The stick that you have in your hand will also buzz when you have 5 minutes left. And of course, you all know what will happen if you go over time limit for those that have been in New Zealand. So we'll implement those same rules here. And then in terms of the talks, just give them to me. I'll have the USB drive. Just come find me, text me. I'll get them from you, and then we'll load them up on the computer. We'll keep it easy that way. Enjoy, everybody, and then we'll have Dr. Shears come up as our first speaker. He is from the United States, works at Mayo Clinic in Rochester. He's a pediatric intensivist and anesthesiologist. And Greg and I have partnered on a few of the conferences down in Florida, and he gives an excellent talk when it comes to all things related to ECMO. And he's going to be speaking on new indications for pediatrics.
Just one second, sorry, Greg, I'm stealing more of your time. One thing we've been made aware of, and again, it's more for the international people, some housekeeping things that we're not used to maybe in most other countries where we've been so far. And this is generally honest. If there would be an earthquake, please just stay still and quiet and calm, and then we can just walk out here very slowly. It's just something we don't say every day and all the opening on a conference.
Thank you, everybody.
Thanks.
¿Qué tal? Buenos días. Bueno, empezamos damos inicio al simposio. Tenemos 2 módulos hoy día, ya bloque AM de ECMO y soporte circulatorio mecánico en pediatría, y el módulo de la tarde más que nada enfocado en shock cardiogénico, y separados a las 2:15 por un box lunch, ya que están todos más que invitados, invitadísimos, ya con una presentación de isavuconazol en ECMO por el doctor Alexander Matus del Instituto Nacional del Tórax. Ya, entonces vamos con el primer módulo, es ECMO y soporte circulatorio mecánico en pediatría. Modera la doctora Sonia Rebeco, jefa de la UCI pediátrica del Hospital San Juan de Dios. Le doy el paso ahí.
Muy buenos días. Tengo el gusto de estar acá con ustedes y presentarles excelentes expositores. Vamos a partir con el primer expositor, el doctor Gregory Cheers. Es un destacado anestesiólogo e intensivista pediátrico de la Clínica Mayo. El doctor Cheers es experto en el tema de cuidado y dar el óptimo manejo en el paciente crítico, sobre todo en el grupo neonatal y pediátrico. Muy destacable su ser propulsor en el uso de ultrasonido en el acceso vascular. Él nos va a presentar nuevas evidencias sobre indicaciones neonatales y pediátricas en ECMO. Démosle una calurosa bienvenida al doctor Cheers.
First slide. Sweet. Buen dia. Morning, everyone. I'd like to thank the organizers of the meeting for this opportunity. It's great. I'm loving being in Santiago and getting to learn about Chile. So I was given this topic, new evidence in neonatal and pediatric ECMO, particularly related to indications. Truth be told, I'm going to tell you up front, there aren't any particularly interesting things that are new in recent years, but nonetheless, I'm going to touch upon a couple things. One thing of note under my disclosures, I'm a co-founder of ECLS Virtual Advisors. Heidi Dalton and I have put this together to help programs to get up to speed more quickly, particularly when they're starting or if they're having issues. So we work all over the world to try to help programs to do a little bit better. Traditional indications in pediatric ECMO for neonates, those of us that are old dogs, we lived and breathed meconium aspiration. Guaranteed you could put a baby on with that diagnosis. Within 3 or 4 days, they'd be coming off with a very high rate of survival. It was wonderful. Unfortunately for us, most of those have gone away. Technology's come along, we've improved our patient care, and we've gone to much harder versions. Also, other indications that persistent pulmonary hypertension, congenital diaphragmatic hernia are things that we contend with. And then other traditional indications for peds include ARDS, sepsis, and postcardiotomy. So that's like traditional. Everything that we do now, it's really just extensions of those same things. One thing that I will comment that a paper that has come out just this year, some extension of our old barriers, let's say, of how young we'll put a patient on. I'll talk about that in just a moment. Refractory air leaks, severe metabolic acidosis, hemodynamic failure, regardless of whether it's congenital or not, and then even more recently, bridge to heart transplant or ECPR. These are all now relatively common neonatal criteria for going on. This is the paper I was talking to you about, and this was a little bit interesting because programs typically will use 34 weeks gestation or 2 kilos as absolute barriers, and many will not go beyond that. But this group, they did a review of the literature from 2009 to 2019 and saw that not everybody was actually following those guidelines from ELSO and peeling that back a little bit, and these are some of their results. No surprise probably to anyone is that the majority of the complications were related to bleeding, whether it's intracranial of various forms or bleeding through at cannulation site. There is a near linear relationship between gestational age and mortality, getting as high as about 75% or so around 31 weeks. I don't quite understand what was going on here because the 28 and 29 weeker, there were 8 total patients, and they had a relatively low mortality rate and did well with few complications. So I don't quite get that, but interestingly, the rest of the gestational age range pretty much followed what one might expect. And then similarly, with regard to birth weight, there was pretty much a linear relationship between the weight of the baby and the probability of mortality. So is it acceptable for a less than 2 kilo child to have the risk of 70% mortality? It's in the eyes of the beholder. A 30% survival in somebody that would otherwise die, maybe that's legitimate. And many of us reach for even harder patients than that. So it seems like as long as they can have meaningful lives and good quality of life, maybe that's justified. Expanded pediatric criteria include more severe forms of respiratory failure with prolonged ECMO runs. Sepsis with distributive shock, that has been, again, historically, something that was frowned upon for obvious reasons, but now, particularly with any evidence of myocardial dysfunction, those patients are more apt to go on. And then cardiac indications probably is one of the bigger growth areas for pediatrics with longer runs related to myocarditis. For some programs use ECMO preferentially instead of Berlin hearts, use it preferentially to support prior to heart transplant. And then, of course, failure to wean from bypass, and lastly, ECPR. So In medicine, the most formidable obstacle to our advancement is conventional wisdom. And we all get into this mindset of what one can or can't do. And it's up to us to use the lens that we have based on our experience, our knowledge from reading, talking, coming to conferences like this, and then whatever our risk tolerance is, both ourself and our program, and resources available to try to apply them and look for opportunities. And for me, one of the most fulfilling things in life has been having those opportunities presented to me and to our group, and then trying to work through to see if we could get that patient on the other side. Consequently, by doing that multiple times now, you develop great memories of successes. Of course, there's failures along the way as well, but these amazing successes where you would never in a million years believe that that patient would normally have survived. But through teamwork and whatnot, you've been able to defy conventional wisdom. This is an early example for me. I was a junior attending, and they always tell you, as a junior attending and you're going to a new program, do not do anything new. You don't want to stand out. You don't want to be struck down because of a choice that you make about doing something wrong with a patient. Well, we weren't the first, but we were nearly the first. The 7th patient recorded for ECPR. This is just one example of an interesting case. And John Thomas, a 10-month-old who had aspirated an M&M, sitting in a high chair in one October, way back when, he was on conventional mechanical support and transferred from an outlying children's hospital across the river to CHOP following parental dissatisfaction because of severe worsening air leak issues and other things. And so he arrived very poorly in barely compensated shock, poorly perfused, and air leak syndrome everywhere. It's a little bit hard to see in this light, but he was like a Rice Krispie treat. Skin very poppy. You can see the pneumopericardium. You can see the outline of the liver because of the tense abdomen from all the air. Within 30 minutes of arrival, he arrested. It was a Wednesday night. And I'll never forget, the cardiology fellow happened to be in-house as well, which was critical to the success of this. And I think I would have been justified in just letting the patient die at that point. It was, there wasn't any experience at CHOP at that time of doing ECPR. It was nighttime. Nobody was in-house that actually could do the cannulation. But something said we should go ahead. We iced his head, called in the surgeon to do cannulation, which took more than 60 minutes, and tried to do high-quality CPR. We had an A-line, which was a savior because we could do high-quality CPR and monitor our pulse pressure. So after that 75 minutes, we were able to go on, and then 2 hours later, there were profound ST segment changes on the EKG. It was like truly a square wave instead of a QRS complex. And we did a quick echo, and what ended up happening is we had tension hemopericardium, which I've never seen before. Apparently at the other hospital, as they were trying to drain the pneumopericardium, they must have hit a coronary or something. So when the patient was anticoagulated after going on ECMO, they bled and had a tension hemopericardium. So we placed a pericardial drain. He went into myocardial stun, and his heart did not contract for 4 days. 5 minutes? 10 minutes? Oh, okay. Awesome. So there's the pericardial drain I placed. Total whiteout, the typical post-recess. And you have to ask yourself, am I doing the right thing? Now remember, this is 1996. So old oxygenators, old tubing, too many connectors, propensity to have thrombosis and small cannula. Just a setup for a thrombus or other problems. We tightened the anticoagulation and persisted. And Miraculously, after 4 days, the heart started contracting again. The patient was on ECMO for a total of 10 days, ventilated another 5 days, and nasal cannula for 2 weeks. And he's a totally normal kid, again, miraculously. But things can come together in ways that are inexplicable and you would never expect. So as a pediatric resident in the old days, I used to feel very content about doing resuscitation. A child would come in, let's say what we used to call SIDS, would come in, we'd do our 20 minutes of CPR, we'd all walk away and we'd feel good because we felt we went through the process. We did the protocol. It's situations like this where you have to say, boy, I'm wondering how often I'm missing the boat here because I can't see beyond conventional wisdom. I cannot identify that thing that I need to do in order to get beyond where I'm at. Here's another example. I have dozens of cases like this. That's why I always hesitate to be certain about any given thing. This one, a 15-year-old girl who broke up with her boyfriend. And it's amazing. I don't know with you guys. When I'm on call, I cover the PICU commonly as well as the cardiac ICU at night. There isn't a night that we don't have at least one suicidal person coming in of some sort, usually a young man or young woman, and typically in the 13 to 16-year-old range. It's incredible. She was found by her brother hanging in the garage. She was bradycardic. She wasn't breathing. He grabbed her, cut her down, had the good sense to start CPR, and called 911. They arrived and continued with CPR and were able to establish some return of spontaneous circulation, not complete. She arrived to the emergency department. She had fixed and dilated pupils. Now, I have to admit, I would not have proceeded from here, but one of my colleagues got this case, and she was having gasping respirations. We've all seen those. You know, infrequent, not normal synchronized breathing, the kind of breathing when the brainstem's going. And he decided, she's still alive, I'm going to put her on ECMO. I know I would not have made that decision, especially with her eyes. So she went on ECMO. And she also had an aspiration pneumonitis. So we're dealing with suboptimal hemodynamics, soiled lungs, and blown pupils. So she was cannulated through the groin. And the arterial cannula was a little on the big side. And yes, I picked up the case and I was on for the subsequent week. So I did not worry about putting in a distal perfusion cannula because I thought we would be withdrawing support. It just didn't make sense to me. So yes, in fact, we did end up having problems with the right leg subsequently. Ultimately, something was done about that, and orthopedics got involved. She ended up having some muscle loss and some dead areas. But the remarkable thing here was that she was on VA ECMO for a total of 10 days and ventilated 5 more, and having this ongoing orthopedic work. But the blown pupils resolved. They reversed within, let's say, that 12-hour period. And she is studying geometry literally in bed while she was still recovering. And she got an A in her geometry exam that was coming up after discharge. So inexplicable. It's not unprecedented. There's a number of case reports related to fixed and dilated pupil as not being an absolute sign of irreversible brain injury. So it was a good learning opportunity for me. And how are we doing on time? Oh, still okay. So certainly if we don't reach past our present, we'll never be able to grab the future. And I think that it's very clear. ECMO provides incredible opportunities to impact physiology in ways that we normally cannot. And I think we're only still learning how we can use that power, that means of oxygen delivery to get our patients to a better place. So I'd like to thank you very much for your listening to my topic, and I'll take questions, I guess, later. Yes.
Vamos a tener 10 minutos de preguntas al final de nuestras exposiciones. El siguiente expositor es el doctor Tom Rosen. Él es pediatra intensivista. Él es jefe de la unidad de cuidado intensivo del Royal Children's Hospital, profesor asociado del Departamento de Pediatría de la Universidad del Melbourne en Australia. Su conferencia que nos va a aportar el día de hoy es Apoyo en paciente pediátrico en shock refractario en ECMO, cuándo sí, cuándo no y cómo. Démosle la bienvenida al doctor Rosen, por favor.
Hello, well, it's a pleasure to be here. I'm going to use my slides and also hopefully be able to see what I'm going to say. I don't have a disclosure page, but I suppose I do have a disclosure. I'm very fortunate to work at the Royal Children's Hospital in Melbourne. It's a very well-resourced centre with a really long history of using ECMO and very developed. And I'm actually in a state which is large, where we're the central referral centre for all severe paediatric illness. And we have two parallel systems of ECMO in adults and paediatrics that are very different. So I'm going to espouse some virtues of what we do, but I'm also very conscious that it really doesn't matter what system you do, as long as you do your system well. So please forgive me when I propose very specific things. And I've got meerkats up here. Yes, we do have meerkats in our outpatient department. They don't improve survival as far as I'm aware, but they definitely improve morale. For more than 2 decades, we've championed high-flow VA ECMO as a rescue strategy for septic shock. And this talk is going to be mostly about paediatrics, but I think it's probably applicable to adult practice too, just a challenge in the way the system works. Today I'm going to cover the big 3 questions. When should we use ECMO for septic shock, how we should do it, and when we shouldn't. Sepsis is still a major killer of children. Historically seen as a contraindication in septic shock because of poor adult outcomes, survival with less than 20%, but the paediatric data is very different. Infection is the leading cause of child mortality worldwide, but in high-income settings with vaccines and antibiotics, it's relatively unusual for a single episode of infection to be so severe as to cause death. In fact, large multi-centre data in large multi-centre data, only 8.5% of children admitted to ICU with sepsis die. But the important part is that half of those deaths occur in the first 24 hours. That's really critical. If we want to save lives, any therapy we use has to work really fast, potentially before antibiotics have started to work and supportive care has had time to turn things around. It's important for me to distinguish that I'm largely talking today about presumed bacterial infections causing shock rather than respiratory support ECMO or viral infections or fungal infections too, albeit most of the patients we see with severe sepsis and shock have had an antecedent viral infection, particularly influenza. In the paediatric literature, utilisation of ECMO in sepsis has grown, as demonstrated by an increasing number of publications before COVID, and outcomes vary across time and institution. The ECMO literature is messy, but we have really heterogeneous patients and a lot of retrospective case reports, registry analyses. The patient populations in these reports just isn't uniform. So it can sometimes be hard to have clear take-home messages, but I'll try. The common theme is that the sicker the child, the more likely ECMO will make a difference. In 2020, Ramanathan and colleagues published a systematic review and meta-analysis of published outcomes. Survival in children supported with VA ECMO for sepsis is around 65% in pooled analyses. That's not perfect, but compared to adult cohorts where survival is closer to 20 to 30%, children clearly do much better. So the question becomes, who are those children who actually benefit? This is our own local data from our hospital. And it shows that in our cohort, patients with toxic shock syndrome, essentially group A strep, do remarkably well with survival rates of 90%. Other organisms have lower survival, but still substantially better than historical cohorts. I'll point out too that a large proportion have had a cardiac arrest prior to going onto support. So that's not a function of waiting until they're sick enough to cannulate, but because we are proactive, but rather it reflects how quickly that population deteriorates en route to our ICU, sometimes from far away. Key lesson in this data with two different organisms and phenotypes is that the phenotype actually matters for outcomes. There are really three distinct phenotypes in kids, albeit it can vary across ages, and it isn't a hard and fast rule. Neonates will often behave differently because their pulmonary vascular resistance is still high and reactive, so RV failure will be a predominant feature often. Here, VA ECMO is decisive, and sometimes you can get away with support that isn't VA, maybe even VV. Toddlers and children get a predominantly LV septic cardiomyopathy, a cold shock phenotype. Here, LV function is poor, and the circulatory support is intuitive. It's in adults where it seems a bit strange. Adolescents tend to reflect adults with a more distributive warm shock. Here, ECMO may only work if you're able to deliver supernormal flows. I'll point out too that while I don't have any disclosures and all of my data is real, the pictures are from AI. None of the data is from AI. I tried to make a dial that went up to 11, but it didn't work, but I got there in the end with this. Importantly, phenotypes will evolve over time. You need to reassess physiology with echo as you go. Now, Lorenz Slapbash's 2019 study begins to give us a bit of a quantitative threshold of when it's particularly useful to use ECMO in septic shock. There seems to be a linear correlation with probability of death and use of ECMO. That's the line in the middle. But when you, that's the line in the middle. You get more death not using ECMO when the risk of death is 47% or above. You get less death if you don't use ECMO when your mortality is less than 47%. And that's because we add morbidity when we use our ECMO. So it's really important that we're not rolling this out early for well patients because you may worsen their prognosis. We need to wait until the trajectory is clearly life-threatening, but not beyond the point of futility. In his study, they used data from 80 children in VA ECMO for septic shock and using a 12-variable model predicted death with a area under the receiver operated curve of 0.88. Notably, there were 3 independent variables associated with better outcome. Low lactate pre-ECMO, absence of cardiac arrest pre-ECMO, and central cannulation. So how do we do it? At RCH, our default is central VA ECMO. That means right atrium drainage, ascending aorta return. And why? It's because flow is the treatment. If you can't deliver high flow, you won't rescue distributed physiology. Peripheral femoral cannulation in a teenager might give you a few litres a minute, but if the native cardiac output is around 7 litres or higher and the lactate is 15, it probably won't help, unless you can get really high flows. And that's hard. Central cannulation routinely allows you to achieve 150 to 200 mils per kilo per minute of flow. And that's what changes outcomes. So I'll show you a bit of data that shows you why it's so important. Several groups, including Totopalli and Oberender, have shown that high flow ECMO, at least 150 mils per kilo per minute, is independently associated with survival. And the time point that you have to get to that high flow is at least by 4 hours. So if you're waiting to see whether the flow that you get with peripheral ECMO is adequate and then adding more access or more return, you likely have missed the boat. At those higher flows, in a study by Oberender, mostly Australia, New Zealand data, survival was 82%. At lower flows, regardless of whether it was central or peripheral, the outcomes were no better than using conventional therapy. So it's not ECMO per se that saves lives. It's the ability to deliver enough flow early in the run to reverse shock physiology. That's why we're so dogmatic about central cannulation. Totopalli's paper also showed that when ECMO was central versus peripheral, more patients survived with an odds ratio of 1.6. And that was confirmed with further data that showed high flow had an even stronger association with survival with an odds ratio of 2.8. Other risk factors for death found on multivariable logistic regression analyses included pre-ECMO cardiac arrest, again, and neurological injury. Now, similar findings have been demonstrated in previous multi-centre studies, although this was bigger than most. Again, back to Oberender's study, which included the Australia, New Zealand, UK and Dutch paediatric ICUs. Odds of death was lowest with more than 150 mils per kilo per minute at 4 hours. And low flows really made no difference compared to conventional therapy, as in no ECMO. So it's not ECMO. I've said this already. There's a lot of English on the screen, I'm sorry. How do we do it? We have complete buy-in from our surgeons. The intensivist will initiate what we call a cardiac call-out, and the patient will go on. There's no debate at the time. We know what works, and we know that we don't always get it right, but we learn after the fact. No point delaying time at the time. As I said, at RCH, our default is central VA ECMO. That means we get the best flows, and flow is the treatment. If you can't deliver high flow, you won't rescue distributed physiology. In practice, we use a lactate of more than 4 as a distinguishing point that makes us concerned, or a rising lactate over an hour, rising inotropes, LV dysfunction, or if we're a little bit late, cardiac arrest, and we'd always prefer to go on prior if we can. We are careful about case selection with certain pathologies, particularly some viral, fungal and immunodeficiencies. Say it again, flow is the treatment. To make it work, we also will try to proactively vent the LV with a left atrial cannula. We'll ask our surgeons to place bilateral pleural drains and peritoneal drains to prevent effusions impairing venous return, impacting on flow. And we work hand in glove with our surgeons, who who accept that they'll be back in the first 24 to 48 hours to tidy the field. That's the culture that we've found that we need to have to be successful at central ECMO in sepsis. So when not? When shouldn't we use ECMO? There are several scenarios. There are some underlying pathogens with universally quite poor prognosis, and we would tend to decline. Disseminated HSV, adenovirus, or critical pertussis being particular viral etiologies, mostly in neonates. Some fungal infections, scedosporium being an example, would be something that we would consider universally fatal. If there was progressive multi-organ failure that was very severe and established beforehand, particularly if you happen to be in a system with limited ability for prolonged renal or rehab support, for us, not such a problem. We're a bit wary about adolescents or adult-sized patients. We're not sure that we're going to be able to achieve adequate flows, but we'll usually give it a go, and we wait to see whether it's proven. But sometimes even central ECMO can't deliver enough flow. We try not to put kids on who have low predicted mortality risk, below 45%, that 47% threshold, 50% threshold. And I think that we do that relatively well with our indications for when we go on. And a lot of our patients do have arrests before they go on. If part of their presentation has been a prolonged unwitnessed arrest, as with out-of-hospital cardiac arrest, we wouldn't put those on. Perfect timing. So here are my take-home points. Firstly, flow's the treatment. We aim for more than 150 mils per kilo per minute. Central VA ECMO is our default for septic shock, and we've tried sequentially increasing peripheral, and the time to achieve flow just isn't adequate in our system. ECMO helps only above a high mortality threshold, that 50%. So you can use a combination of inotrope score of more than 100, you can use lactate more than 4, you can think about cardiac arrest. Peripheral low-flow ECMO rarely changes outcome in distributed shock. ECMO, though, is always a trial of therapy. Reassess it daily for signs of futility versus benefit. And finally, the decision-making is never static. It evolves with physiology and the data in front of us, the team around the bed, and the wishes of the family. I suppose there's one last thing that I'll say, and that's that these patients are often very sick. We think that they have good outcomes because their neurological outcomes are good, but there's a large proportion of the kids that survive that are in hospital for a really long time. There are a large proportion that have tracheostomies. There are a large proportion that end up on renal replacement therapy for a long time. There are a large proportion that have amputations of parts of their distal limbs. And so it is an extremely resource-requiring intervention to do, and just something to be aware of if you're going into it. That's all from me.
Continúa con nosotros el doctor Nicolás Pavés. Él es intensivista de adulto, parte del equipo del Hospital Clínico Regional de Concepción, profesor asistente en el Departamento de Medicina Interna de la Facultad de Medicina de la Universidad de Concepción, y ha participado en múltiples publicaciones en relación a los riesgos y complicaciones en el cuidado del paciente críticamente enfermo. Hoy nos va a compartir la presentación ECMO en infecciones por hantavirus.
Hola, buenos días. Muchas gracias por la invitación. Espero no aburrir a los pediatras con un soporte de adultos. Vamos a hablar de ECMO y ANTA. Inicialmente vamos a hablar de ANTA para entender de qué se trata esta enfermedad y cuándo decidimos hacer terapias un poco más avanzadas. En general, esta patología tiene que ver con una infección por roedores, en la cual deposiciones y orinas generan aerosoles que se inhalan por las personas que trabajan cerca de sectores rurales, y esta infección viral produce una disregulación de la acción endotelial. Entonces, en realidad, lo que ocurre es que estos capilares se empiezan a separar y empieza a salir agua hacia afuera. En realidad, eso es lo que conocemos como leak capilar, y ese es uno de los primeros mecanismos de shock. Entonces, el setting central de la patogenia de la infección por hantavirus es el aumento de la permeabilidad vascular, y es lo primero que vamos a ver. En algunos aspectos clínicos nos vamos a dar cuenta de que este aumento de permeabilidad va a generar primero un estado de hipovolemia, porque se está perdiendo volumen, y por otra parte va a haber una agregación plaquetaria que va a tratar de alguna manera tapar estos hoyos. Entonces producimos una hipovolemia, como tenemos pérdida de agua libre, tenemos hemoconcentración, y como tenemos agregación plaquetaria, tenemos trombocitopenia. Y esos son los hallazgos clínicos clásicos, ¿cierto? Una infección respiratoria, inflamatoria, como una gripe formalmente, pero con trombocitopenia y hemoconcentración. Después, lo que podemos ver entonces es que esto tiene una cierta temporalidad. Inicialmente tenemos un cuadro clínico respiratorio clásico, generalmente tienen una segunda consulta, porque se maneja como si fuera un resfrío, pero a esta segunda consulta, cuando ya se le indaga un poco más sobre los aspectos epidemiológicos, podemos encontrar que este paciente se encontró en un sector rural, o estaba acampando en un sector no seguro, o generalmente lo que nosotros vemos es que tratan de hacer aseo en algunas zonas donde hay leña y se encuentran con deposiciones de roedores. Entonces, a la segunda consulta, ya el clínico que está más familiarizado con esta patología toma algunos exámenes, un test rápido que puede ser positivo, y en un recuento rápidamente podemos encontrar la trombocitopenia, la hemoconcentración y a veces algunos linfocitos. Así que podemos encontrar esta evolución de esta clínica bien clásica. Y el compromiso respiratorio, que pudiese ser el primero, está dado principalmente por un aumento de la permeabilidad capilar. Esto se trata de un edema pulmonar no cardiogénico, a pesar de que nosotros tenemos bien claro de que esto va a progresar probablemente a una falla cardíaca. Pero el primer edema pulmonar probablemente no es cardiogénico, se ven generalmente opacidades intersticiales, que son acompañadas o no de derrame pleural precozmente. Esta patología, a las 48 horas de tener este resfrío, empiezan con derrame pleural, que es bien característico. Son pocas las enfermedades que desarrollan derrame pleural tan precoz, y es por esto, por este aumento de la permeabilidad. Esto determina el desarrollo de una hipoxemia progresiva, el aumento de trabajo respiratorio y evidentemente la necesidad del soporte. Con respecto al compromiso hemodinámico, generalmente tiene tres componentes. Un primer componente es un componente distributivo, como cualquier shock séptico clásico, en el cual la respuesta inflamatoria produce vasodilatación, mediada por citoquina y mediadores proinflamatorios. El segundo componente, que es probablemente el más característico de esta enfermedad, está dada por este vaciamiento capilar, por este leak capilar. Hay una rápida fuga desde el intravascular hacia el intersticio, y eso es lo que vemos como manifestación clínica: el edema periférico, el edema pulmonar y la hipovolemia. Una hipovolemia que es bien difícil de manejar, se administran cargas de volumen, aumenta el volumen sistólico y rápidamente se pierden, como si ustedes tuvieran como un shock hipovolémico o un shock con la llave abierta. Y finalmente, este mismo compromiso edema intravascular sobre el corazón genera una falla en la contractilidad. Entonces nos enfrentamos a estos dos problemas. Tenemos un shock que es hipovolémico, pero con un corazón que está funcionando mal. Así que el manejo del síndrome cardiopulmonar por hantavirus es primero la monitorización hemodinámica, que es la que nos va a ir dando cuáles son las señales o en qué perfil de shock nos encontramos, en qué etapa de este perfil de shock. El manejo de fluido y las drogas vasoactivas, el soporte ventilatorio. Hay algunas terapias específicas, muchas en estudios, la mayoría con estudios en general negativos, como el corticoide, ribavirina, plasma inmune, la hemofiltración de alto volumen, algunos con más o menos evidencia y probablemente la mayoría con evidencia en contra. Y tenemos como el soporte más potente, que sería la circulación extracorpórea. Con respecto al soporte ventilatorio que vamos a hacer, inicialmente incluso nosotros podemos recibir un paciente en muy buenas condiciones, conversando, con una naricera, y podemos progresar a algunos de los tipos de soporte ventilatorio que nos parezca más prudente para cada paciente. Podemos iniciar con ventilación no invasiva o canula nasal de alto flujo. Si es que hay una insuficiencia respiratoria progresiva, podemos progresar a la ventilación invasiva, y cuando aparece esta disfunción circulatoria multifactorial es donde utilizamos el ECMO arterial también para suplir la parte de la oxigenación. En general, históricamente se ha enfocado la patología como una falla respiratoria, A nosotros nos parece que el principal condicionante es la mortalidad del compromiso cardíaco. ¿Por qué le hablo de esto? Nosotros tenemos probablemente dentro de la reanimación de los 90 y 2000, teníamos una reanimación probablemente riberiana en la cual nos reanimábamos según metas de reanimación y teníamos que reanimar a hartos volúmenes. Esos pacientes, si nosotros los reanimamos según metas de reanimación y administramos 12, 15, incluso algunos reportes hablan de hasta 20 litros de cargas de volumen, esos pacientes fallecían de falla respiratoria aguda. Y probablemente los que han leído sobre ANTA y ven cuáles son los manuales, el manual dice haga una reanimación restrictiva, prácticamente seca, porque el problema es la falla pulmonar. A nuestro parecer eso no es tan así. Probablemente esa reanimación seca es seca en comparado a la tipo de reanimación que hacíamos en los 90 y principios de los 2000. Hoy día que hacemos una reanimación mucho más reglada, generalmente nosotros recibimos pacientes que están, entre comillas, subreanimados, tratando de evitar la falla respiratoria, pero en realidad el mayor compromiso va a ser el compromiso de las disfunciones multiorgánicas mediadas por la hipoperfusión. Entonces yo creo que tenemos que cambiar ese sello de que el ANTA es una reanimación en seco, en realidad es en seco con respecto a los 90, pero probablemente está mucho más cercana a la reanimación que hacemos hoy en día. Y la falla, la disfunción es principalmente circulatoria. Así que por eso nosotros, en realidad, el 100% de los pacientes que entran a ECMO por antivirus es en ECMO veno arterial. ¿A qué pacientes, por qué y cuándo en realidad? Esto ya tiene como, este trabajo ya como que nos mostró de que el ANTA pues, podría ser tratado con un ECMO veno arterial. Estos fueron 50 pacientes, 100% de veno arterial y la mortalidad esperada era un 100% y la mortalidad bajó a 1 de cada 3. En este trabajo de Bernie, que es el clásico de estudio de Antavira en 4 esquinas, utilizaron unos criterios para el ECMO veno arterial que son bien potentes, si ustedes lo ven, PAFI bajo 60, lactato mayor a 4, uso de vasoactivos moderados a elevados, y el índice, o el criterio hemodinámico, que es el índice cardíaco bajo 2 litros. Ellos decidieron esos puntos de corte porque eran los puntos de corte que a los pacientes con antivirus tenían un 100% de mortalidad. Entonces era una patología que se iban a fallecer sí o sí, y cuando se realiza o se instaura el ECMO veno arterial en este grupo de pacientes, la mortalidad cae drásticamente a probablemente el 30%. Así que ese es como nuestro setting de pacientes y probablemente a partir de ese grupo de indicaciones, que como ustedes ven son principalmente hemodinámicas, es cuando se inicia el ECMO veno arterial. Esto es del 2018, esto no son tan bien comparables los grupos, pero fue antes de que entrara el ECMO en nuestra unidad, que fue el 2016, y post-ECMO, la mortalidad global es 40 versus 20%, entonces probablemente ya teníamos más conocimiento de cómo manejar estos pacientes. Y en el grupo con síndrome cardiopulmonar, la mortalidad bajó de 54 a 22%. Esto es mediado evidentemente por equipos de salud, por la temporalidad, pero probablemente también es porque tenemos un grado de soporte un poquito mejor. ¿Cuándo conectar a ECMO? Esto tiene que ser muy, muy precoz. La importancia es porque el antivirus, esta paciente que viene conversando con un poquito de fiebre, las manos medias heladitas, taquicárdico, con una naricera, que te cuenta lo que hizo, que estuvo limpiando, a la noche puede estar conectado a ECMO. Por lo tanto, nosotros, probablemente la indicación del Ministerio de Salud y acompañado por Sochimi, es la derivación inmediata de los pacientes a un centro con experiencia en ECMO veno arterial, porque la evolución es muy, muy rápida. Las recomendaciones ya casi clásicas antiguas del MinSal hablan de un índice bajo 2,5, lactato mayor a 4, y vean, shock refractario a la adrenalina mayor a 0,3 gamas kilómetros. Probablemente son bien excesivas, tal vez estamos entrando un poquito antes, pero en realidad cuando encontramos la disfunción miocárdica es el momento de entrar. Y las recomendaciones de la guía MinSal del 2013 ponen al final de la última pata, después de reanimar al paciente, que eso también es importante. No decir este paciente ANTA, hay que mandarlo al centro ECMO y lo dejamos de lado. Hay que reanimar al paciente y probablemente muchos de los pacientes que recibimos los logramos reanimar y tal vez no requieren el ECMO veno arterial. Pero si esas etapas se van cumpliendo y no se logran mejorar la perfusión, entramos a ECMO veno arterial. Y de hecho, en el protocolo Sochimi del 2015, que ya lleva 10 años, cuando se habla del protocolo de ECMO veno-venoso, ellos agregan una indicación excepcional que el paciente con diagnóstico de ANTA, con test serológico positivo, se traslada precozmente a un centro con capacidad de ECMO independiente de la condición clínica del paciente. Esto hasta el 2025 son nuestros ANTA ECMO, son 37 casos, mitad hombres, mitad mujeres, edad promedio, edad laboral, son personas que están trabajando o que están haciendo excursiones en el lindo sur de Chile. pero son ECMOs cortos, en tiempos de horas de conexión de 120 horas, en general una estadía relativamente corta. Recordemos que no es solo el ECMO lo que ocurre, sino que después vienen algunas complicaciones, pero en realidad son más o menos 16 días y tenemos esta sobrevida 70%, que probablemente es la acumulada. Al principio iba mejor, iba variando. Recibimos pacientes de todo el país y evidentemente a veces están más lejos, más cerca, o recibieron una mejor o una distinta reanimación, y eso puede variar un poco, pero en realidad la sobrevida en ECMO vena arterial todavía es sobre el 70%. Esto es del Congreso Europeo del 2019, que presentamos cómo entraban nuestros pacientes, y vemos que en realidad entran con una PAFI pericien, el lactato alrededor de 3, pero todos con nuestro índice cardíaco bajo 2. ¿Ya? Eso es como nuestro gatillo de conexión, y en general nos basamos en eso, en el índice cardíaco, con un monitoreo invasivo, más la ecografía o ecoscopía, así que está disponible. Así que entramos con ese índice, 1.95, con PAFI 110 y 100% contractilidad cardíaca reducida a la ecoscopía. Así que hay que considerar la logística de cada centro, evidentemente. Hay que darse cuenta de que este es una evolución muy dinámica, y las tomas de decisiones en equipo, y esas son más o menos las indicaciones que estamos viendo según qué es lo que se ha ido dando, ¿cierto? Cuando lo conectamos es cuando se decide, se conecta. Realmente tiene que ser muy rápido, no puede ser mañana. Se decidió en la mañana y ya el equipo está armando la canulación. Esto es un paciente con una ecoscopía de ingreso. Todas estas ecoscopías son las peores imágenes de eco que van a ver, porque son pacientes que están reanimando, uno le pone el transductor y aparece esa imagen, ¿cierto? Es un paciente que tiene que se ve probablemente vacío, una vena cava inferior 7 milímetros, colapsa un 100%, entonces tenemos este perfil de choque hipovolémico, ¿cierto? Inicialmente está vacío, está perdiendo agua, uno le pasa volumen, aumenta el volumen sistólico y probablemente tiene un tiempo para aguantar. Se ve evidentemente también una disfunción sistólica, una fracción estimada 40-45%, y no hay disfunción valvular. O sea, el corazón se empieza a dañar, pero a uno lo que le molesta más es que está relativamente vacío. Esto es en la mañana, paciente de frecuencia 97, saturando 97, presión 130-60, precozmente 70-40, y ya empieza a caer la presión. Y esta es nuestro antiguo monitor, que vemos el gasto cardíaco inicial y cómo va cayendo en el tiempo en cuestión de minutos. Rápidamente llegamos a un índice bajo 2.5 y se canula el paciente. Y esto pasa en un día. A las 18 horas de ingreso, esa ecoscopía que vimos está así. Así que ya, claro, le pasamos volumen, pero ya el problema no es el leak capilar, sino el corazón, que no se la puede. Y en ese momento es donde uno debiera plantear la canulación de ECMO vena arterial. Aquí vamos a mostrar una ficha clínica, no importa que se vean los números, pero es más o menos ver como el tiempo. Ingresa a las 4 de la mañana, en regulares condiciones, está lúcida, como les digo, cuenta su cuadro actual, taquipnea, taquicardia, hipovolemia, la ecoscopía, buena respuesta a volumen, sin vasoactivo, oxígeno por naricera. Estos pacientes, aunque se vean así, los hospitalizamos en UCI. El paciente más tranquilo a UCI, ¿cierto? Leyendo el diario, y estamos ahí todos. Y como que ella dice, ¿por qué me están mirando tanto? Es por eso, no se preocupen, los que andan bien, probablemente a las 24 horas van a andar bien, pero los que andan mal, estamos ahí encima para poder cuidarlos. Así que partimos con el soporte ventilatorio, se conecta ventilación mecánica ya a esta hora, más o menos a las 22, y ya al día siguiente, o sea, menos de 24 horas, está conectado a ECMO veno arterial. Entonces, un soporte inicial muy invasivo, porque queremos ir siguiendo rápidamente cómo va a caer. Nosotros ponemos un soporte invasivo una vez que parten los vasoactivos, porque a veces no requieren vasoactivos y con volumen pueden salir, dependiendo de la carga viral y de la exposición que tuvieron al virus. Pero si parten con vasoactivos, hacemos un soporte monitorización invasiva y no invasiva, y cuando cumple algunos criterios de disfunción de falla cardíaca y ecoscopía con contractilidad reducida, conectamos a ECMO. Esa es la conexión en ese momento, así se está canulando el paciente. No sé el número, pero la línea está media planita, ¿ya cierto? Ya sabemos que está mal. Esta es la movilización macromodinámica. A modo de ejemplo, pusimos días 1, 3 y 5. El día 1, como ustedes ven, todavía con un poco de vasoactivo. Es medio contraintuitivo el vasoactivo, un ECMO veno arterial, ¿cierto? Pero también hay un cierto perfil vasopléjico también. Recordemos que los perfiles de shock del antivirus se entrelazan, entonces por eso la monitorización tiene que estar bien encima. Un ECMO con un soporte estándar, y muy fáciles de ventilar. O sea, también nuevamente el mensaje, si hay una falla respiratoria, es fácil, se ventila muy fácil, como edema pulmonar agudo, con un poco de PIC se abre el pulmón. Rápidamente se bajan los vasoactivos al día 3 y ya al día 5 ya estamos probablemente de salida. Así que al día 5 ya vemos una contractilidad bastante mejor y ya hacemos test de salida de ECMO y podemos decanular. Se decanula a las 115 horas. Estas son fotos de la paciente. Ella habla a través de esta pizarra, se comunica con los familiares, vean que está con traqueostomía, tuvo algunas complicaciones cutáneas, pero ella nos quiso regalar estas fotos y evidentemente, bueno, ahí está paseando afuera del hospital, mirando el campalín de la Universidad de Concepción. Esa es la U, aquí está el hospital, aquí está ella que nos viene a ver, todavía ocupa bastón pero en esa foto, pero ya no, así que está bien la Vale. Así que algunas consideraciones especiales para ir cerrando: ECMO venoarterial, sobreveno-venoso. La anticoagulación es compleja porque tenemos trombocitopenia, así que hay que tratar de seguir cuál es el punto más puntual, de iniciar la anticoagulación. El tiempo de conexión es corto y ojo ante la mejoría de la función sistólica, porque el corazón va a empezar a eyectar sangre que viene desoxigenada del pulmón, entonces frecuentemente podemos ver algún síndrome de Arlequín en este grupo de pacientes. Y si existe la falla severa, podemos hacer salida a ECMO venovenoso o venoarteriovenoso, o de frontón decanulamos y pronamos cuando el pulmón todavía no se recupera por alguna cáncer. El traslado, como vimos, es muy importante. El paciente se diagnostica como ANTA y se traslada a un centro ECMO. Y finalmente hay un review que hicimos sobre el manejo de cuidado intensivo sobre antivirus, en el cual ponemos puras opiniones de expertos, así que nada de eso es verdad. La idea es seguir recopilando información nacional para poder tener un poquito mejor evidencia. Bien, ese es el equipo. Gracias por su tiempo.
Tengo el gusto de presentarles al doctor Rodrigo Díaz. Él es anestesiólogo cardiovascular, magíster en educación, jefe del programa ECMO tanto del Hospital San Juan de Dios como de la Clínica Red Salud y miembro consultivo estratégico de la ELSO y su comité de educación. Él nos va a presentar cuántos pacientes presentados a la Oficina Nacional de Asignación de Camas UCI se conectan finalmente a ECMO. Bienvenido.
Muchas gracias. Buenas. Acá. Primero que nada, esto que hablaba el doc hace un rato del doctor Nicolás de la estrategia de mover los pacientes con diagnóstico sospecha de ANTA hacia un centro con capacidad ECMO, nos costó un montón. O sea, no fue, digo nos porque varios centros tuvimos que insistir, en particular el JJ, la alemana con Jerónimo, yo desde Las Condes donde estaba en ese minuto, nos costó, yo diría que un par de años convencer al ministerio para que los pacientes con ANTA fueran trasladados a centros ECMO. Lo cual ha tenido, yo creo, un tremendo impacto. Desgraciadamente siguen habiendo pacientes que no se trasladan aún a tiempo, pero de nuevo, detrás de esto hay un esfuerzo conjunto que fue hecho en esa época, hace 10 años, a través de la Sociedad Chilena de Medicina Intensiva. Por lo tanto, el mensaje aquí va en que lo que ustedes están viendo como resultado hoy, lo que está pasando en Concepción, con la tremenda sobrevida que tienen, es también producto de las alianzas, digamos, de que distintos centros nos juntamos y fuimos a tocar la puerta del ministerio y fuimos a tocar varias veces, pero definitivamente valió la pena. Y un poco vamos a hablar de lo mismo, digamos. La medicina no siempre se trata del trabajo clínico, también consiste en política, en logística, en cosas que no nos agradan mucho a los clínicos, digamos. Pero que la verdad es que uno logra mucho más cuando comparte modelos mentales con el resto de la gente. Primero, contarles que en Chile tenemos 2 sistemas de salud. Esto sirve como información para la gente que nos está viendo desde afuera. La mayor parte de la gente tiene un seguro público, que es FONASA, el 82% para ser exacto, y un 14% tienen seguros privados o ISAPRES. La mayoría acá tendrá ISAPRES, no lo sé, a lo mismo. El punto es que, a diferencia de otros países, tenemos una cobertura prácticamente del 100% de algún tipo de seguro. Y la buena noticia es que en Chile FONASA considera al ECMO como un soporte que ellos financian. Importante mencionar que
Chile está ubicado en una zona intermedia de ingresos. Es un medium high income country. O sea, no estamos a nivel de un país, entre comillas, del primer mundo, pero estamos al medio y eso hace que tengamos algunas características con respecto al desarrollo del ECMO en esta región. Cuando ustedes piensan en Chile, se van a encontrar que hay centros que tienen pacientes con indicación de ECMO, pero no tienen ninguna facilidad para conectar. No tienen ECMO, no tienen cirugía cardíaca, no tienen nada. Hay otros que tienen cirugía cardíaca y no tienen ECMO, pero pueden llamar a alguien que se lo vaya a buscar, digamos, y eso está pasando actualmente. Después está el que tiene algo, podría conectar al paciente en ECMO, pero necesita que se lo rescaten. Es un muy buen puente para partir un programa de ECMO. Y el Tier 4, que es donde yo estoy en este minuto, por lo menos en mis dos centros, que es el San Juan de Dios y Clínica Red Salud Santiago. Yo no soy un centro hiperespecializado, pero nos hemos enfocado en transporte. Nosotros vamos a buscar pacientes desde el San Juan de Dios a hacer ECMO delivery particularmente, y desde Red Salud hacemos harto ECMO móvil primario. Vamos a buscar los pacientes y los traemos hacia nuestro centro. Y si es necesario, después le llevamos a un centro hiperespecializado, como por ejemplo podría ser el Hospital del Tórax, que va a ser el trasplante cardíaco pulmonar si el paciente lo llega a necesitar. Entonces, en Chile se está haciendo actualmente transporte primario, secundario y terciario. El primario es el paciente que uno va a buscar y lo lleva a su hospital. Típico caso que nos presentan a la clínica, yo hago la cama como sea, el director todavía me apoya, no sé hasta cuándo, y hacemos la cama y traemos al paciente. El secundario es cuando un paciente ya ha sido canulado, pero la ley de urgencia se le acabó y se va a trasladar a otro centro ECMO público, y eso pasa de vez en cuando. El terciario es lo que hicimos, hicimos en el San Juan de Dios el día domingo. Fuimos con el paciente a Calama y lo dejamos en el JJ. JJ no tiene ECMO hoy, pero nosotros ampliamos la capacidad de camas de ECMO gracias a este sistema de ECMO terciario. Aparece esa cama disponible del JJ para el paciente de Calama. Sin este modo de ECMO terciario no tendríamos esa cama disponible. Entonces en Chile funcionamos más que como un hub and spoke, que es el sistema de regionalización normal, habitual en muchos países. Nosotros funcionamos más bien como un punto a punto. Si hay una cama disponible en Talcahuano y el paciente está en Antofagasta, lo vamos a ir a buscar a Antofagasta y lo vamos a llevar a Talcahuano desde Santiago. Concepción hace lo mismo. Hacen harto terciario también. Ellos van a buscar pacientes, por ejemplo, a Puerto Montt y lo traen a Santiago y después se vuelven en el avión a Concepción. Esto es un ejemplo, digamos, un paciente ECMO móvil primario, donde vamos, lo canulamos y lo traemos a nuestro centro. Esta es una paciente también ECMO móvil primario, que es el típico paciente ya conectado a Wake ECMO, es nuestra práctica habitual, y caminando, ojalá, idealmente. Entonces, ¿dónde está Chile ubicado con respecto a otros países, digamos? ¿Cuánta incidencia de ECMO tenemos en el país? Y es bastante interesante mirar los números porque tenemos una incidencia que no ha cambiado mucho en los últimos 10 años. En este minuto, yo lo calculé el año 2024, es de 1.8 por 100.000 habitantes por año. Uno puede decir, eso no me dice mucho, comparémonos con otros países. Bueno, Corea, el 2024, con datos del 2023, tiene 6,5. Corea es un utilizador intenso de ECMO, así que hacemos un tercio de lo que hace Corea. Hacemos más que lo que hace Costa Rica, que es probablemente el que nos sigue en incidencia de ECMO en Latinoamérica. Pero para darles una idea, cuando nosotros estábamos haciendo 2,3 por 100.000 habitantes, más de 300 pacientes por año, el año 2021, en México se conectaron menos de 120 pacientes. México tiene 115 millones de habitantes. O sea, la incidencia es bajísima. Y ahí pasó, en México, que hubo una desconexión entre lo administrativo y lo clínico. Se conectaron pacientes, muchos pacientes COVID, pero lo que se hizo pagar a las aseguradoras hizo que las aseguradoras cerraran la puerta al ECMO. Y finalmente fue un disparo en la cabeza. El ECMO realmente está súper difícil en México. Y nosotros, ¿qué hicimos durante el COVID? Crecimos de 26 camas ECMO a 41. Y eso más o menos es lo que se ha mantenido durante el tiempo. Ha bajado un poquito. porque no necesitamos tantas camas como cuando estuvimos en pandemia. Y nosotros creamos esta comisión que ustedes bien conocen, que iba a tamizar a los enfermos para ver si era adecuado su conexión o no. Que teníamos tal cantidad de requerimientos que teníamos que, la verdad, hacer una especie de tamizaje o triage de los enfermos. Entonces, lo que hicimos durante esa época fue crear una comisión que iba a evaluar a los pacientes que requerían ECMO para conexión a COVID durante 24/7 y los íbamos a mover entre los distintos centros. Centros que existen desde Antofagasta hasta Temuco, que actualmente sigue siendo así. Pero nos dimos cuenta que entre más volumen tenían los centros, menor mortalidad. Entonces, lo mismo de repente donde los metíamos los pacientes. Y definitivamente dejamos algunos centros fuera por malos resultados, dado que recibían 1 o 2 pacientes por año. Eso todo en periodo de pandemia, que fueron 2 años. Y esta era la imagen típica. Y lo que hicimos muchos. La Católica, Concepción, CLC, en ese minuto cuando todavía existía. Entonces, ¿qué pasó con Chile el 2024? El 2024, quiero mostrarles qué pasa con la unidad de gestión de camas críticas del Ministerio y el traslado de pacientes. La unidad de gestión de camas, no es de gestión de camas críticas, es de gestión de pacientes críticos. Es un tremendo aporte para los pacientes que requieren un traslado de un centro que no es resolutivo a uno que es resolutivo. Y eso lo hacen desde un sector público al sector público primero, como primera línea, pero si no, al privado licitado, al privado no ranqueado. Y eso significa en la práctica que en Chile tenemos un acceso universal al ECMO. Si el paciente no llegó a ECMO es porque llamaron tarde o se les pasó, no sabían. Pero si usted está en el hospital de los Andes y tiene un SRA con indicación de ECMO, tiene que enviar un informe a GCC, se va a subir a GCC y la Comisión Nacional va a evaluar si el caso es pertinente o no. Si el paciente tiene indicación de ECMO BA, no va a pasar por comisión, pasa directo, la UGCC va a buscar un centro porque sabe que va muy en contra del tiempo. Y si es un ECMO pediátrico, ahí todavía se están poniendo de acuerdo cómo lo estamos haciendo. Entonces, de los 205 requerimientos que tuvimos el año pasado, yo me estoy subiendo el carro de UGCC, que tuvo GCC el año pasado, 135 pacientes llegaron a conectarse. Bastante, o sea, un muy buen porcentaje se llegó a conectar. ¿Y cómo me explico los 330 pacientes que se conectaron en el 2024? Bueno, son pacientes o que son de la red privada o que son generados en el mismo hospital. Y por lo tanto, la UGCC no intervino. Si yo tengo un paciente de choque cardiogénico y llegó al hospital del tórax y lo conecté en el tórax, no pasa por este sistema de requerimiento. Entonces, de los 205 requerimientos, la mayoría fueron de adultos, como pueden ver. Las conexiones finales tuvieron aún más hacia los adultos. Entonces, de los 205 requerimientos, 65% llegaron a ser conectados. Y esto es una tremenda pega que hace la gente que está 24/7 conectada a un teléfono, hablando con miles de gestores, donde los gestores demoran a veces horas en responder y no entienden que detrás de esto hay un enfermo que está gravemente enfermo y por eso está requiriendo ECMO. Y las principales razones de falla por la cual no se conectaron es porque el paciente se deterioró o porque se murió. Mucho menor porcentaje de que se estabilizaron, pero pasa también. Las tasas de sobrevida de los pacientes conectados que pasaron por GCC es 66% en adultos, 87% en pediátricos y 61% en neonatos. El ECMO móvil fue usado en casi un 20% de los pacientes que se decidió conectar a través de la UGCC. Y de los pacientes que no se movieron en ECMO móvil, la mayoría fueron trasladados por ambulancia y un cuarto por aire. Y esta encuesta que anonimizamos, digamos, por centros, pero van a ver que en Chile hay 21 centros con capacidad de ECMO, pero hay solo 4 que superan el umbral de los 30. ¿Es eso bueno o malo? La verdad es que uno no puede decir que uno no puede hacer ECMO porque hace 5 casos al año. Lo importante es que cuando uno hace menos volumen, tiene que tratar de aumentar su entrenamiento de la gente que está en contacto con los pacientes en ECMO en algún minuto. Pero Lo importante de esta diapositiva es que de los 330 casos, 21% fueron neonatales o pediátricos. 23% en total del país fueron ECMO móvil. Eso ha ido subiendo año a año. Antiguamente, hace 10 años, era menor al 10%. Y la conclusión final, perdón, pasé de keynotes a PowerPoint, pero la intención era que la gestión centralizada de los pacientes que requieren ECMO, por lo menos la experiencia chilena, que somos un país que tiene limitación de recursos, ha sido exitosa. Ha sido exitosa gracias al trabajo particularmente de Dijera, pero también de la gente que responde a él. Concepción ha hecho un tremendo trabajo y nosotros del San Juan hemos tratado de emularlos en el sentido de ir a buscar los pacientes y hacer móvil terciario. El punto es el siguiente. Ustedes ven los resultados y la sobrevida lograda, los resultados realmente hablan por sí solos y la verdad es que a pesar de que tenemos limitaciones de recursos, somos un país chico, hacemos harto en el tema de él. Muchas gracias.
Para terminar este excelente primer bloque, el doctor Rosen nos va a compartir la siguiente presentación. ECPR en pacientes pediátricos. ¿Hay alguna oportunidad para el paro cardíaco extrahospitalario?
Might get started while the slide's coming up. Hello again. It's been so long since I've seen you. Thanks for the opportunity to speak on this topic. My opinion on both of the topics that I speak on today, my feelings are very strong. Today I want to ask a question that matters deeply to all of us working with ECMO in kids. ECPR in paediatric out-of-hospital cardiac arrest. Is it time for a rethink? We've seen some extraordinary progress in out-of-hospitals ECPR in the adult world. But paediatric out-of-hospital cardiac arrest remains stubbornly difficult to treat. My aim is to walk you through the data, hopefully it'll come up soon, the physiology and the local and international experience so we can reflect honestly, we can reflect honestly on where ECPR belongs and where it may not. We're going with the slides. Let's begin with why this matters. An arrest in a child outside of hospital is pretty rare. The incidence is about 8 per 100,000 child years. But when it happens, it's catastrophic. Overall survival is usually about 10%, and survival with favourable neurological outcome is often only around 5%. That sets the stage for why extracorporeal approaches might be tempting, because conventional therapy so often fails. So what are we trying to achieve when we put a kid on ECMO? At its core, it's about enhancing systemic oxygen delivery. It's about reversing multi-organ failure. And when it comes to cardiac arrest, ECPR is defined by ELSO as ECMO initiated during ongoing CPR or after repeated arrests without sustaining ROSC for more than 20 minutes. It's a pretty audacious intervention, really, but the goals are clear. This is the ELSO data for the last few decades. Looking at registry data over time, we see that the volume of eCPR rises across neonatal, paediatric and adult groups, although the predominance is in the adult population. When we look at survival rates, adults average about 30%, they're in blue down the bottom. Neonates are about 43% and paediatrics about 41%. And obviously it bumps around with each year. But there hasn't been a substantial increase since the early 2010s. We have a bit of hope though. 40% survival is pretty remarkable in contexts where conventional CPR survival is in the single digits. It's not as good as cardiac or pulmonary support indications, but it's not terrible. Here comparing neonatal in orange, paediatric in green, adult in blue. In-hospital cardiac arrest in paediatrics is a bit of a success story. It's important to point out the distinction there is in that setting. Here, particularly for children with cardiac diagnoses, survival with good neurological recovery is consistently in the 40 to 45% range in most centres. It's no surprise that that tempts us to extend the approach to out-of-hospital cardiac arrest. But we need to pause and ask, does the same logic hold? These are patients that are rest in hospital with people that can do good CPR, and the time to going on ECMO is likely to be much quicker. But what are the factors that might improve outcome? It's going to be multifactorial, isn't it? The patient we select, the maturity of the ECLS program, how well it works, the location and the logistics of cannulation. Some places are harder to cannulate. I understand from Julia, cannulating on the floor is pretty hard. I've never seen our surgeons do that. And the timing, how long from collapse to support. All of these things will interact with the natural history of the underlying disease to shape the outcome. And in kids, it's the underlying disease that's the real kicker. In all of our eCPRs, we use the same neuroprotective bundle arbitrarily. We focused on the before cannulation to try to optimise flow in that period of time with good CPR. We focused on after cannulation to try to protect the brain. We do have very thoughtful patient selection. We do try to limit arrest to ECMO time to less than 45 minutes for out-of-hospital cardiac arrest. That's hard. Our surgeons aren't in-house, they come from outside, so we have to call them in if it's after hours. We don't have a mobile ECMO service that can go elsewhere and put a child on ECMO who is arrested, even in other hospitals, although we will go to other hospitals to cannulate. We prefer to move patients to RCH though. So we try to control the carbon dioxide and the oxygen at the time of cannulation and afterwards. We think that that's going to influence the brain perfusion. We always cool to 33 degrees for 72 hours and we use nitric oxide. Evidence is sketchy, but we think that it might be beneficial. And the nitric oxide, if you're wondering why, we put it in the circuit itself and we think that it might help with reperfusion injury. We target mean arterial pressures, often supporting with adrenaline and vasopressin if we need to, or we'll dilate if we need to. They're all structured attempts to give the brain the best possible chance. Here's the most important point. Out-of-hospital cardiac arrest in children is just not the same as it is in adults. In adults, you have a cardiac arrest and there's a good chance that it's going to be an arrhythmia. They've got a poor coronary substrate. If you defibrillate and you have rapid circulatory support, you can salvage an otherwise intact brain. In kids, arrests outside of hospital setting are predominantly asphyxial, respiratory in origin, and you start with a saturation of the blood that is exceedingly low. So even when you're doing CPR, you're not providing oxygenated blood to the brain. By the time the heart has stopped global hypoxia has already set in. So even when we restore circulation, the injury is generally already there. What do the paediatric guidelines say? They reflect this difference. They recommend considering ECPR for paediatric in-hospital arrests with cardiac diagnoses in ECMO-capable centres. But for out-of-hospital cardiac arrests or non-cardiac causes, they make no recommendation for or against. And that's the uncertainty we sit with. This is my local hospital data. We cannulate, we have about 60 or 70 runs per year. About a third of them are ECPRs. We had a real dip in the number of ECMO cases during COVID. Our overall survival in ECPR generally is at about the 63% range. We do pretty well compared to the registry data. And there doesn't seem to be a huge difference between arrests that happen in the paediatric ICU versus arrests that happen outside of the ICU. We will only cannulate in our hospital by bringing the patient into the paediatric ICU, or if they're already in a cardiac theatre, we don't cannulate in the emergency department or elsewhere. We move the patient, not the team. So the ECPR in blue accounts for about a third of the volume, about 20 runs a year. Where do our patients arrest when they're not in our ICU? Some of them arrest on the cardiac ward. Some of them arrest in the emergency department. Some of them arrest in the operating theatre. Some in MRI or CT. Some in our neonatal ICU. And here Cockatoo, which is actually our neurology ward. I don't know why that's on there. But they managed to get cannulated. And Piper is our retrieval service. Patients who arrest there are with an intensivist. They have much better outcomes. And this period is from 2010 to 2023, so it's a slightly longer period, but there are about 50 ECPRs there. These are all outside of paediatric ICU. We only cannulated 3 kids who had out-of-hospital cardiac arrest ECPRs. And I make that distinction, the distinction of ECPR, that's cannulating while they're still arrested or within 20 minutes. When we cannulate, we will generally select the patients that already have return of spontaneous circulation and some indication that they've got better outcomes. So of those 3, 2 out of 3 survived. Sounds pretty good, but the stories really matter. One of those progressed to brain death after a drowning. One of them was following stage 2 palliation cardiac surgery, and one with asthma, and both of those had severe neurological injuries. We're not keen on producing highly disabled survivors. It doesn't seem fair to them or their families. But what you can see with the differences is that the proportions of survival do vary a bit by location. That probably reflects what we all know, at least intuitively, that the location and timing and quality of resuscitation are all critical. Some of you may have seen that there was a recent paper published in Resuscitation looking at ELSO registry data over a 3-year period, or a bit more than 3-year period. Out of all of the ECMO that was performed in that period, there was a 30% survival in the reported ECPRs. But that number is really interesting to me. 23. There were 23 survivors from out-of-hospital cardiac arrest, ECPR, in the world. At the same period of time, there would have been about 14,000 paediatric and neonatal runs in about a 3-year period, and about 2,000 ECPR runs in total. Not many of us are putting these patients on. You can see the non-survivor numbers is also low, just 54. But it makes you think, like if 30% survive, maybe it's about the inclusion criteria. Maybe it's about how you select those patients. We're really very selective. No sign really predicts good or bad neurological outcomes with absolute certainty. We heard that fixed dilated pupils can sometimes be associated with better outcomes. And we've seen patients that have fixed dilated pupils from really high doses of adrenaline, and baclofen overdoses. But what we try to do is move to an inclusion criteria that are frankly very strict, because we want to satisfy all of these criteria before we consider cannulating a child after out-of-hospital cardiac arrest. We want them to have a witnessed cardiac arrest because immediate bystander CPR is really important. Sudden infant death syndrome, a baby that dies in a bed could have died a very long time ago. If they've got a shockable rhythm on their first monitoring, it just means that it's much more likely that they don't have a respiratory cause of their arrest. If there's been effective CPR during transport with end-tidal CO2s that have been above 15, so we've been able to demonstrate that we've got adequate circulation. And we want the time to be short. If it's more than 90 minutes, game's over. But we'll try to get it as quick as possible. And we hope to see pHs greater than 7 on arrival. This is a bit of a fuzzy one. We sometimes cannulate when they're in the 6.9 type of range. Ideally, we'd see pupils that are reactive or small, or spontaneous movement, one or the other. We think they're sensible criteria, and they reflect our painful experience. If we do receive an advance warning about a patient who might fulfill these criteria, we do some things to make the chances of having good outcomes more likely. We arrange for a direct admission to the paediatric ICU rather than going through the emergency department, because we're not going to cannulate down there. We issue a cardiac call-out calling the team in while the patient's still en route so that they can be met. And we assess the patient on arrival for all of those things, particularly pH, pupils, confirmation of history. And we do that before deciding whether or not to proceed with ECMO. There might be some patients that will benefit if they've got reversible etiology and no desaturation before their arrest. If I was going to pick them, maybe a primary arrhythmia. We've seen a couple of patients that have had trauma to the chest that have had commotio cordis, so they've had an arrhythmia that have done very well. They had a period of stunning and then recovered. Myocarditis might recover. Severe hypothermia here, maybe there's an avalanche. We don't see cold patients who survive. The drowning that we had was put on because they were cold, but in Melbourne the temperature of the water just isn't cold enough to have a cold survivor. And selected toxins maybe. But these are really narrow windows, but possible. Who's unlikely to benefit? Most. Most are unlikely, unfortunately, because most are unwitnessed or asphyxial arrests. We include asthma in there. We've had pretty poor outcomes from a few patients in the state that have been cannulated for asthma. While they have cardiac arrest, they often have that arrest while they are severely compromised with poor venous return because they're so hyperinflated. We have cannulated one drowning with prolonged submersion. We wouldn't do that again, I don't think. And Victoria is pretty big. It's not quite as long as Chile is, but it's a long distance to fly to go and retrieve patients. It's a 4-hour flight to get to our furthest point. That's a long time to go and retrieve before cannulating, so those patients are unlikely to benefit. Okay, so where does that leave us? eCPR, there's no doubt, is transformative for paediatric in-hospital arrest, especially with cardiac disease. And a cardiac program will do much better if it's a cardiac program that is able to cannulate a patient who arrests after their surgery. But in out-of-hospital cardiac arrest, the biology, the logistics, the outcomes in paediatrics are just different. We have to rethink. Not abandon, but redefine. eCPR for out-of-hospital cardiac arrest in kids should be a precision tool, reserved for narrow phenotypes, with strict criteria, using integrated systems that deliver cannulation in short time, 45 minutes, less if you can. The challenge is to balance the innovation with humility, because just because we can doesn't always mean that we should. Thank you.
Tenemos unos minutos para hacer preguntas a nuestros expositores. ¿Alguna consulta?
Una pregunta. Cuando tiene un paro y el pH es 6.8, pero la pH2 es 150, o sea, la acidemia está explicada por acidosis respiratoria, ¿es su límite 7.0 o lo cambian?
If we have a patient who is still arrested, then 7.0 is our limit. If we have a patient who's not arrested anymore, some signs of life, that's when we'll vary our indications. It just suggests to us that the period of resuscitation hasn't been great, and the likelihood that we'll have survival is so much smaller.
Yo tengo una pregunta para el segundo expositor. Cuando yo estaba en el Sick Children, allá hacíamos un programa más o menos de 50 pacientes al año, de los cuales 30 eran ICPR. Entonces empezamos a ver la evidencia que tenían ustedes en shock séptico, porque claramente nos pasó que nos llegaron pacientes adolescentes, 130, 140 kilos, que uno iba a tratar de canular los periféricos y no daban los flujos. Entonces vimos esta experiencia del ECMO central y a pesar que ese era un centro que hacían todo en el intensivo, tenían mucho miedo a hacer la esternotomía. ¿Quién canula al paciente? En su centro hay un cirujano 24/7 que arma un pabellón en el intensivo o el paciente va después a pabellón. Y la segunda pregunta es, cuando ustedes hacen ICPR, ¿hacen canulación percutánea o abierto? En el centro que estaba yo, todos se canulaban abierto.
Hopefully you can hear me okay. To the first question, we don't have surgeons in the house. We have the surgeons, if they're operating during the day, then they'll be in Monday to Friday, but Saturday, Sunday, and in the evenings, they're not in. So we call them in. We have a call out. We make a single phone call to our switch that sends out a page, and everyone in the tree receives it, calls back in to confirm, and drives straight in. And that includes a perfusionist, a cardiac surgeon, a cardiac surgical fellow, and theatre nurses, so scrub nurse. There is also our general surgical nurses that get paged at the same time, and they'll come from theatre because we try to make sure that there's redundancy so that there's someone else that can do something. So if a fellow arrives and the cardiac surgeon hasn't arrived yet, the fellow might start assisted by perhaps an intensivist who is retracting something terribly badly, or possibly doing chest compressions, but at least the chest is open, and we sometimes get ROSC, return of spontaneous circulation, doing that. I'm not sure that necessarily answers your question though. The other part of it is that we would usually cannulate those patients in the ICU, not in theatre. So all of our arrested patients who get cannulated, who aren't already in the cardiac theatre, would be cannulated in the paediatric ICU. We convert the room that they're in, their single cubicles, into an operating room. And we do that to open and close chests. We do it to go onto ECMO and come off ECMO. The intensivist, often the registrar, their fellow or more junior, is the anaesthetist. The anaesthetic for these are very, very simple. Big dose fentanyl, kefazole, and heparin at the right time. To the second question, which was about ECPR and cannulation. Oh, how would we cannulate? The fastest way we can. Depends on the surgeon. Yep. So if there's a good indication that they should have central ECMO, they come in, they presented with some sort of sepsis syndrome, we'll go in the chest. Our surgeons are much faster cannulating through the chest than they are doing peripheral cannulation. In smaller kids, they'll cannulate the neck with cut down. In bigger kids, they'll do a cut down and do femoral access, but it's much slower than cracking a chest open. I've seen them open a chest for an anaphylaxis that had been arrested for 60 minutes in our hospital after getting a chemotherapeutic agent that made them very sick. And in fact, they had return of spontaneous circulation at the time that the chest was open, which was fortunate. So they didn't go on to support, but that was just the faster way for them to go on. Time is the issue.
Oh, there it goes.
Can't take you anywhere.
Rodrigo, question for you. We have, in the last number of years, set up a hub and spoke model of care across our state, Australia, our state within Australia. The Alfred is the hub, and the reasons for doing it were to, increase equity, to support, in a timely manner, to standardise care across institutions that were using ECMO. When we started, we had 21 hospitals doing ECMO, and the majority of them putting, as you said, 1 or 2 cases on a year. The politics was tricky, which you've spoken about. With the idea of volume outcome relationships, do your smaller teams, the smaller centres around the country, do they want to keep the patients? Do they want to look after them? Do they want to maintain the care for the full length of an ECMO run? Or are they agreeable to moving patients centrally? And how did you negotiate that sort of politics?
Very interesting question. If we could force them to do that, it would be great. But really, the 21 centers, some of them doing 1 or 2 patients per year, they usually run the whole case. It's very unusual. They move the patient. At least in my case, I have to move my patients if they need a heart transplant right now. So we do that once in a while. And it's kind of hard because culture is difficult to change. And during a time, tertiary ECMO, that means that you're going to have to take decisions on cannulations that maybe you are hosting or final ECMO center won't like or won't feel comfortable, or you just made a mistake because the patient is too ill. At least in adults, that has changed quite a bit. So we move patients in adults. In pediatrics, it's more tricky, and we have some problems with that, but it's normal. But again, our reality is the same than yours. We cannot stop people doing 1 case per year. And I think you cannot do that. They're in the right, but as long as they keep their people trained, I don't mind so much. The problem is when you have the opportunity to transfer the patients and don't do it, you have to be very knowledgeable about what are the consequences of that. I don't think that happens very much. But anyway, thank you for the question, and definitely that's a problem that happens in Germany. Tobias was telling us yesterday. Many centers doing small numbers with old patients, and the outcomes are low. So they do a lot of patients, but the outcomes are not as good as they could have as a nationwide system. Definitely, I think we should move ECMO to the same level of care that LVADs have. Because to put an LVAD, it asks you a lot of things and a lot of certifications. Why not an ECMO? We still don't have that anywhere in the world, as far as I know.
Tenemos otra consulta ahí al medio.
Buenos días. La sepsis es una enfermedad que está matando muchísimas personas. Como dijeron en la charla, la necesidad de aumentar el flujo. ¿Existe alguna investigación, alguna forma de aumentar el flujo en estos pacientes para tratar de tener más indicaciones en shock séptico? ¿Se está trabajando en algo actualmente?
So we go to central ECMO, and that's the way that we get higher flow. At the Alfred, they probably wouldn't cannulate those patients. Feasibly, could you get high flows? At Mayo, maybe they're able to get a cannula perfectly positioned where it's really deep up from the femoral up into the SVC, and maybe they get 6 or 7 litres of flow. With one cannula, or you could have 2 cannulas for access. I think it's mostly access rather than return, but if you've got a really small return cannula, that's problematic. The thing about using central ECMO is that you have cannula sizes that are enormous. They're 23 French, sometimes they're sort of, they can be higher than that for access, return about the same size. The flows that you're able to achieve can be 10, 11, 12 litres potentially with high revs. And it's hard. The question about 130 kilos, we've never cannulated a 130 kilo kid. But we have cannulated kids that are the size of pretty much everyone in this room.
There's one interesting thing, that the pattern of sepsis is different from pediatrics to adults. In adults, when you are thinking on VA ECMO, normal VA ECMO, you have to look at the ventricular function, because it's a paradox, but if the ventricular function is down, you connect the patient to VA ECMO and your expected survival is going to be high. But if the patient has normal ventricular function, you connect to ECMO, to a normal ECMO, and your survival is going to be low. So you have to look at the ventricular function. I'm talking about adults, it's really different. But it was just presented in Journal of Cardiothoracic Vascular Anesthesia and Experience from Colombia, that they would put in a patient who wouldn't fail the ventricle. He had just vasodilatation. The patient that I told you that had low outcome if you put in normal VA ECMO. But they put 2 VA ECMOs in 2 circuits. So, and the name of the article is ECMO is a better pressure. It's a flow pressure. It's just a case report, and the patient survived, but it's just a little light of maybe what is going to be the future in patients that don't have heart failure, but are extremely in shock because of sepsis. But still, until now, what we ask when a patient is in an adult patient who is septic, we ask for ventricular function, and if it's normal, usually we don't get in there, but if it's abnormal, we just cannulate right away.
Damos por finalizada nuestro primer bloque. Thank you so much, Dr. Chers, Dr. Rosen. Muchas gracias, Dr. Pavés, Dr. Díaz. Excelente sus conferencias. Volvemos a las 11:30. Tenemos un coffee ahora.
¿Aló? Les recuerdo también a la hora de almuerzo el box lunch, ya para que no se olviden, están todos invitados.
Disappointed, eating themselves away.
Bueno, vamos ahora con la segunda parte del módulo de la mañana. Modera la doctora Cecilia Romero, parte del equipo de cardiocirugía pediátrica y ECMO pediátrico de la Pontificia Universidad Católica de Chile.
Buenos días a todos, mucho gusto, yo soy Cecilia Romero, soy cirujana cardiovascular de la UC y actualmente formo parte del equipo de ECMO pediátrico también y neonatal de la misma institución. Entonces, ahora vamos a continuar en el segundo módulo con la charla Dispositivo de Asistencia Ventricular Pediátrico, de ECMO a LVAD, Berlin Heart, a Nueva Tecnología. Con ustedes dejo al doctor Matthew de Gisto de la Clínica Mayo, Rochester.
Thank you very much. I'm going to take a nice wide stance in case there's an earthquake. Thank you everyone for coming back. I'm glad that everyone is well caffeinated. This talk is a talk about pediatric ventricular assist devices. So just going through basically what is available for our pediatric patient population. Just to get, I think, a quick idea, how many individuals in the audience are intensivists? Okay, that's a good portion. Anesthesiologists? Okay, smaller. Our perfusionist colleagues? Okay, great. Welcome. Who am I missing? Trainees? How many trainees are here? None? A couple? All right, great. All right. Well, welcome everyone. Yeah, what categories am I missing? Nursing. How many of our wonderful nursing? Oh, wow. Yes, welcome. Thank you for being here. So we're just going to go through a basic overview of pediatric ventricular assist devices, where ECMO falls with our patients who have heart failure. What are our options for our pediatric VADs? A little glimpse into what we use at the Mayo Clinic, as well as what some of the future technologies are. So really, like, what's our primary indication for a ventricular assist device? If you look at any of the large pediatric registries, either from North America or in Europe, it's really as a bridge to transplant. This patient has heart failure, and they need to receive a heart transplant. About 90% of the patients in North America, about 85% or so in Europe, the primary indication for a ventricular assist device is heart transplant. There's some other indications. Some centers do use it as a temporary bridge in the larger pediatric patients. And then there's a small patient population that just really aren't good heart transplant candidates. Some of those patients with muscular dystrophies, some really difficult congenital cardiac patients where they'll use a ventricular assist device as a destination therapy. And so just for life longevity. About a third of pediatric patients who receive a heart transplant in North America are on a ventricular assist device at the time of transplant. And these ventricular assist devices have really revolutionized how well patients are doing while on the wait list. Since they were first introduced and their acceptance has increased, the wait list mortality rate has dropped about 50%. So where does ECMO fall in this? It's your initial therapy in your patient who isn't a known patient with heart failure, who's being managed medically as an outpatient. This is your bridge to recovery or your bridge to a decision. So that's a varied population. Your patient who comes in with their acute viral myocarditis, who's in cardiogenic shock with end organ failure. There's a lot of other options. Sorry for having a chart with small English words for everyone. But it's a graphic that's taken directly out of the ELSO Red Book. And it talks about once your patient's on VA ECMO, as they progress and improve their care, let's assess their cardiac function. If their cardiac function is inadequate, then assess their respiratory function. If their respiratory function is adequate, then that's when you really need to start looking, okay, now is the time we need to start evaluating that patient for a heart transplant, and we need to start thinking about transitioning them to a ventricular assist device and off of VA ECMO. So the options for ventricular assist devices in the pediatric population is varied. And this is kind of like a little flow diagram of how I kind of think about it. You have your pulsatile options as well as your continuous flow options. Your pulsatile is really your paracorporeal, and for continuous flow you have a paracorporeal option as well as a implantable option. I'm really going to focus on the paracorporeal options because that's where kind of we make our hay in the ICU that we'll be managing mostly. It's also the options that the only options for patients that are under 20 kilos. I will touch on the implantable continuous flow devices, just to really talk about where we're at in our state of technology so we understand what technology gap there is for possible future devices. And I'll touch as well on the percutaneous, not so much as a ventricular assist device, but as another option. And then there's also a total artificial heart that can be placed in some pediatric patients with very limited kind of data so far on that, but I'll just briefly touch on it. So the original pediatric, ventricular assist device, the paracorporeal pulsatile option is your Berlin heart. The Berlin X-Core was made in 1989. A pediatric option came out, I think, in 1992, and it was really been the mainstay for, 2 decades of how to manage to provide ventricular assist to pediatric patients. It comes the pumps, the drives themselves come in a number of different sizes. That's what the little circles down at the bottom are really go all the way down to 10 mLs, which would provide a stroke volume of 10 mLs for the smallest patients, under 5 kilos. The patients, for our few trainees or few self-identified trainees, if they haven't seen this before, the 2 individuals in the upper left-hand corner have their X-Core in an LVAD configuration. So there's a drainage cannula that's placed, if I can figure out this, in the apex of the left ventricle that's draining. You have your return that comes back up to the aortic arch. There's valves in here that only have one-way flow. It's pneumatically driven. So this is a real close-up. This is the pneumatic portion here. that's driven by your ICUS. A very large machine that has a battery life of about 30 minutes, making transportation in these patients very difficult for imaging or just rehabilitation. But the pneumatically driven portion of it creates negative and positive pressure. And so you create a negative pressure, and there's this little black membrane that comes down, it draws the blood in, it creates a positive pneumatic pressure and creates this pulsatile beating from the device. So this is really kind of was the mainstay for a long time. If you look at the most recent data, kids under 20 kilos, the majority, it's a little over 50% in North America are still receiving a Berlin heart as part of their ventricular assist device. The other option for pericorporeal is our continuous flow devices. And there's a number of different options. There's in the upper left area is this is the Rotaflow. And then below it is the Abbott, the CentraMag, and the PediaMag. These are continuous flow devices. There are some differences besides the fact that they're continuous flow. They can use a number of different cannulas for actual placement that can aid in more difficult, anatomic cannulations. They have, you can configure them however you'd like in an LVAD or a BiVAD strategy. But in addition to all the different types of cannulas, the Berlin can only use the Berlin cannulas. These continuous flow devices can also use the Berlin cannulas as well. I have a little bit closer up. I walked through our unit just before coming here to see what patients we had. We have one patient who was on a BiVAD setup, but is using the CentraMag option. And so it's kind of hard to see. The patient was sleeping, so I didn't want to move too much. But so these are the drivers. And so you have your inflow and outflow. There's a little rotor inside that connects into this little magnetic driver that magnetically levitates the rotor and then just spins and then creates that continuous flow. We have two of those little drivers here, one here, another here, and you can kind of see I have an iPhone, and so unfortunately you can't see the RPMs. You can see a little bit of the flow, but how we have it set up, and is our most common configuration, particularly for patients, like I said, that are under 20 kilos, well, there's really not a lot of other options. There's the continuous flow implantable options as well. I bring this up just to talk about so the Heartware HVAD was the most commonly placed continuous flow option. That could be placed in a patient that was down to about 20 kilos. If you look through all the Action Network data, 20 was about the lowest that was reported. That being said, it was unfortunately discontinued in 2021 due to some adult problems with the device. And with that, there's really only the HeartMate 2 is available, but the HeartMate 3 is really the other option that you can use in kids. It unfortunately can really only be placed in a patient who's down to about 30 kilos. So again, you still have that gap. So 30 kilos and above, you could place this in for a long-term ventricular assist device while you wait with the patient on their heart transplant wait list. So I bring this up just to talk about that there's this gap then. So anyone under 30 kilos can't have one of these devices placed. Percutaneous, there's actually a lot of percutaneous options. I didn't want to go through every single iteration of all the different percutaneous options, but I did want to just talk about the Impella. The Impella is a great device that's placed intravenously. The device itself actually goes across. It crosses the aortic valve. We'll go back. Sorry. It crosses the aortic valve. It goes down into the left ventricle, and then actually, ejects blood out of the left ventricle. It's a great job as a left ventricular support device. It comes in a number of different sizes. The 2.5 in the CP are the smallest ones. There's also the 5 and the 5.5 that you've probably seen in your adult patients. Those are usually placed femorally. The 2.5 and the CP are good options for, again, smaller kids. They can be placed, they need like a 14 French introducer. They can be placed in the axillary artery. either percutaneously or with a cut down from a surgeon. And they can be beneficial if you have a patient who's on VA ECMO who is starting to have issues with left atrial hypertension. This is a good way to decompress the left side of or is maybe a potential option for your patients that are 25 kilos or greater for decompressing the left-hand side as well. The last thing is the total heart. So this is the total artificial heart. This is from Syncardia. They have two different sizes. They have a 70 ml and a 50 ml option. The 50 ml option is the one that can be used, and that's the stroke volume for the device, and can be taken down to about 30-ish kilos as well. There's very limited pediatric data. There's certain case reports of unique options. The most common one that I actually found was a patient who has received a heart transplant, who has acute graft failure, that this has been used in that scenario. It's been used in that scenario because if you actually remove the graft, then the patient no longer needs to be on immunosuppressive agents. So you can actually start peeling back some of those immunosuppressive agents as well. But again, very, very few cases of this kind of really in the literature. And then as far as future technologies, so as I mentioned, the HeartMate 3 is the only implantable continuous flow device. So knowing that there was this gap in coverage, they started the Pumpkin trial, which was pumps for kids, infants, and neonates. They really just wanted to find a way to create new devices that were made for a child. Most of these other devices were made for adults and have been kind of either made smaller or adjustments are made so they can be used in a pediatric patient. This was a device that was intended to be made for pediatric patients. It's gone through a couple iterations because of some issues that they've had, hemolysis, but this is the most recent iteration. So that's the device up in the upper left-hand corner. So this is an implantable continuous flow device. It's currently in it's a multi-center prospective, it's a single-arm feasibility trial. They've had, I think, 8 to 10 patients already placed with this, and so they're still evaluating it. This little mock-up down here is the device implanted into a mock-up of an 8-kilo child's that has dilated cardiomyopathy. So they want to make sure that it feasibly could fit into a heart that small. And it does a pretty good job. So they're testing all the way down to 8 kilos up to 30 kilos, kind of where the HeartMate 3 would take over. It's an option, it's ongoing. They chose 8 kilos not because they didn't think they could even get it in. I think they have mock-ups even further down than 8 kilos, but the lowest speed that it could reliably go was 1.2 liters per minute. Which equates to about 150 cc's per kilo per minute in an 8-kilo child, and so that's really where they felt like their lower limit might be. And that's really it. Those are kind of the options that we have for ventricular assist devices to help our pediatric patients make it to transplant. So, thank you very much for your attention. I appreciate it.
Muchas gracias, doctor. A continuación, vamos a presentar a la doctora Rebeca Ameduri. Ella es cardióloga pediátrica, especialista en insuficiencia cardíaca e intervencionista cardiovascular, enfocado en cardiopatías congénitas, especialmente en el síndrome de Fontan de la Clínica Mayo. Con la siguiente charla, que es ¿cuál es el futuro de un paciente infantil trasplantado? Vida, esperanza y calidad de vida.
Thank you. I welcome the opportunity to speak with you all today on infant transplantation. Is it just the arrow here to advance, Matt? Yeah, perfect. So our learning objectives for today is just to understand the indications for heart transplant in the infant and pediatric population, analyze post-transplant outcomes and survival, and discuss some longer-term issues with quality of life for the infant transplant recipient. And up here, I was in Valparaiso exploring your beautiful country and saw this amazing street art, and so thought I would just incorporate it. I just happened to wander on the right street to see this beautiful work. So when we think about pediatric cardiac transplantation over the last 40 years, it has evolved from an experimental therapy to an accepted form of therapy for intractable heart failure. However, this is not a cure. There exchanges a fatal cardiac disease for lifelong risks of rejection, lifelong risks associated with immune suppression, with our goal being to give these patients a better quality of life and hopefully a long quantity of life as well. When we look at overall data for pediatric heart transplant, there are about 600 heart transplants performed each year worldwide, which represents about 10% of the total number of heart transplants. And I'll show a lot of data from the ISHLT, the International Society for Heart and Lung Transplant, as that's where we get the majority of our long-term follow-up data. When we look at the age distribution, about a quarter of them are that infant population less than 1 year of age, with the remaining 2/3 being split between children and adolescents. Overall, when we look at heart transplant, we're talking about 600 procedures per year worldwide, and this is looking at the number of centers that do heart transplant. So if we look at the purple, that's the most recent era. There are about 200 centers that perform pediatric heart transplants. So the majority of those centers are going to be small volume centers, so doing between 1 and 4 transplants per year. And there are very few programs that reach kind of a large volume. And when we talk about large volume for pediatric transplant, it's about 10 or more per year. Looking again at the age distribution just graphically to kind of show that that infant population is really around 100 transplants. So out of that 600, about 100 of them pediatric. About 100 of them in that infant age range. And again, looking at this at just the infant numbers, we've had some drop off in the infant numbers in the more recent era. Some of that is related to donor availability. Again, we think about all of the resuscitation efforts that we've been talking about all morning. Some of that leads to fewer brain death situations and fewer donors. So we are really limited in our infant population to the number of infant donors that we have. I'll just mention we can do ABO incompatible, which is one way that we can try to get more infant donors by using ABO incompatible grafts. So what are the indications for heart transplantation overall in pediatrics? We think about if they need ongoing inotrope support or mechanical support. Complex heart disease that's not amenable to repair or palliation, or if that carries a higher risk than transplant. Progressive deterioration of ventricular function or functional status, malignant arrhythmias, or survival after cardiac arrest that's not responsive to treatments. Progressive pulmonary hypertension, so particularly in a restrictive or dilated cardiomyopathy, if they have progressive pulmonary hypertension that may preclude transplant at a later date. Growth failure secondary to severe heart failure, poor quality of life secondary to severe heart failure, and then not relevant to this talk, but I think an upcoming talk talking about failing Fontan physiology, and so some of the specific things that we can see post-Fontan that would be indications for transplant. What about contraindications? Are there any specific patients that we think shouldn't go to transplant? So infectious diseases, so HIV and hepatitis C, in general are considered contraindications, although in the adult population there have been some successful transplants to HIV or hepatitis C positive recipients if they have good viral control. With our antiviral therapies now, I think that has kind of been removed as an absolute contraindication. If they have end organ failure that is not secondary to their heart failure and not likely to get better with their heart failure managed, in select situations and in select centers, you could consider multi-organ transplant, so whether it's heart kidney, heart lung, heart liver, but again, that has to be done at centers that really have experience in multi-organ transplant. If they have other diseases that would limit their quality or quantity of life, and then fixed elevated PVR, so we consider 6 Woods units or a transpulmonary gradient greater than 15. However, there are situations where we can use mechanical support or ventricular assist device support to lower that pulmonary vascular resistance to a point where we are able to then transplant them. Looking at the diagnoses that lead to transplant, so if we look at the infant population on the top left, the majority of the patients are congenital heart disease patients, so 55% of the patients going to transplant in infancy are for congenital heart disease. If we look at the subsequent age groups as we move through kind of older children and then into adolescence, the percentage of myopathies goes up, the percentage of congenital heart disease goes down, but doesn't go away. There are a significant proportion of patients that have been palliated for their congenital heart disease, but then ultimately do need to go on to transplantation. And then also in the red, we see retransplantation. So that's something we'll talk about, that these hearts don't last forever and that there does become a number of these patients that need to go through retransplantation. And I'm not sure in other countries, actually we didn't talk about it at dinner last night with the Australia group, if retransplantation is something they offer. It is offered at a lot of centers in the US, but I think internationally there are a lot of centers that don't consider retransplantation as an option. If we look just at the infant population with congenital heart disease, so this is a lot of the population we're dealing with. As we said, more than 50% of the infant population that goes on to transplantation. And look at the most recent era, almost 80% of these infants have had a prior heart surgery. So many of these we will palliate or do even a palliative operation to get them bridged to transplant. And several of them we will leave on prostaglandins as kind of their bridge therapy. And there are very few of our infant populations that have not had a prior surgery or on PGE. And relevant to kind of our overall talks here, looking at, this is overall for pediatrics, and then I'll break it down for infants after this, but that now we're up to more than 40% of our pediatric population being bridged to transplant with mechanical support. So this is a very large percentage of our patients that we're dealing with, which is why, you know, Matt's talk on new therapies and new devices to support even our smaller patients is really important. And looking at, again, this is just infant population, so not pediatrics overall. In the most recent era, kind of on the right, that 80% of the patients are not on device, but in the infant population, about 20% of the patients are on device as bridge to transplant therapy. The majority of those being ventricular assist devices at this point. There are still some that we bridge with ECMO. Again, this is dependent on kind of their anatomy and kind of, you know, what options we have to support them. The other thing that you'll see is that in the more recent era, the usage of ventilators has gone down, and some of that is that as we've developed more mechanical support expertise, more of these patients are able to be supported on VAD and then be able to come off of ventilatory support while they're waiting. And looking at a breakdown by diagnosis and mechanical support, so if we look at the congenital heart disease population, more of those are going to be ECMO if they are bridged with device, and fewer of those are going to be VAD. And if we look at the dilated cardiomyopathy population, it's going to be more ventricular assist device and less VAD, and that overall in the dilated cardiomyopathies, more of them are supported with device therapy. When we look at transplant, we know that this is not a fix for everything. We're trading one set of problems for another, so trading heart failure versus the complications of being immune suppressed. And as we said earlier, our goal being really to give them a better quality of life. Despite looking at the risk factors of increased sensitization, many of them having prior surgeries, many of them with congenital heart disease, overall our outcomes have improved in the most recent era. So our current overall pediatric one-year survival is 93%, with a 5-year survival of about 83%. This is likely related to lower rates of early rejection and better targeted immune suppression therapies that we have. And this is looking at one-year survival by era, so looking at the most recent kind of 20 years of experience that we really have improved that early 30-day survival, and that long-term, or at 1 year, that survival is now at about 93%. Our survival for the infant population, however, still lags behind with a lower first-year post-transplant survival. It's likely related to kind of the complexity of their anatomy, severity of their illness, difficulty with mechanical support in this age range, the technical factors of doing transplant surgery in this much smaller population. I know some of our smallest infant recipients are probably 2.5 to 3 kilos. And you think about the technical aspects of doing the transplant surgery at that size. And then, as I said, also the limited donor pool for infants. However, we again, at certain centers, we'll do ABO-incompatible transplantation. These infants have not developed the anti-A or anti-B antibodies, and so we can cross those. They will never develop the antibodies against that donor heart. They won't develop those anti-A or anti-B antibodies. And they have a similar long-term survival, whether they had an ABO-compatible or ABO-incompatible graft. One question that we often get from families is, how long is this heart going to last my child? So I like this slide and this data because I think it gives us kind of the best estimates of that. So if we look at the infant population that we're talking about here, that's the purple line there. It has a lower 1-year survival, but long-term, those survival curves cross. And at 25 years, about 50% of those recipients overall are still alive on their initial graft without either death or retransplantation. This is if we look at it with conditional survival. So if we take out those that had an early mortality, they survived the first year. At 25 years, more than 60% of those infants are still alive. And so if we get them through that initial phase, they can do very well in the long term. Again, looking at this at about 20 years, we see that there are about 15% of the recipients that have needed retransplantation. And again, that is something that's offered at select centers. Other factors that affect the outcomes for these recipients, so their diagnosis, again, we talked about congenital heart disease versus dilated cardiomyopathies, use of mechanical support, and then donor factors that affect their outcomes. So ischemic time, ideally we want that to be less than 4 hours. Size matching, again, in the infant population, sometimes we are oversizing these hearts and can have some problems with that. HLA match and sensitization issues, again, many of these have had prior surgeries and may be sensitized. Particular factors related to donor cause of death or the donor heart function. And this is kind of the long-term survival in the more recent era for infant populations broken down by diagnosis. We can see that the dilated cardiomyopathy population fares better than congenital heart disease patients or retransplantation. And again, kind of on the right screen, looking at the current era, the breakdown for ECMO versus VAD or no device. So patients that are supported with ventricular assist device or no mechanical support have similar outcomes. Those that are bridged with ECMO, even not just the risk of ECMO and death on the wait list, but after transplantation have a higher mortality. What about other post-transplant morbidities that we look at? So they have a risk of rejection, and I'll show some data on that. Risks associated with immune suppression, so long-term risk of renal dysfunction, which was higher with use of cyclosporin versus other calcineurin inhibitors, and higher in the infant population. Risks of infections, both community-acquired infections and then also of infections associated with their immunocompromised state. Risks of coronary artery disease, which is higher incidence in those with early rejection. Risk of graft failure, need for retransplantation. And then also just mentioned post-transplant lymphoma, which can happen in some of our patients. So overall, we see that rejection is common. So about 15% of patients will experience rejection within the first year post-heart transplantation. That's lower in the infant population. Again, their immune system is still developing, and so they tend to have more issues with infection and less with rejection. If we break it down by some specific risk factors for rejection in the infant population, so sensitized patients, so those that are not sensitized, so have a low PRA versus those that are highly sensitized. Again, in our infant population, that does not seem to be a significant risk factor. We have kind of more novel therapies in our more recent era to lower the risks of rejection overall. Yes, 5 minutes. Okay, perfect. Breakdown by diagnosis, there's not any difference between the congenital heart population and the dilated cardiomyopathy population in the current era. If we look at a breakdown of talking about quality of life, we think about if these patients are rehospitalized, what are they rehospitalized for? Rejection, the red is rejection and infection, so that's about 25% of our patients within the first year, and that goes down over time. Hospitalized for infection only, hospitalized for rejection, that is a higher percentage, and then if they're hospitalized for other reasons. However, when we look at kind of the yellow, the big yellow graph, the majority of these patients are not back in the hospital within the first year, and definitely by 5 years, we're not seeing them back in the hospital frequently. Coronary artery vasculopathy can be a reason for retransplantation in this population. And for the infant population, at 12 years, about 75% have freedom from coronary vasculopathy. Dialysis is a significant risk factor for mortality after transplantation, whether they had de novo dialysis after transplant or were on dialysis pre-transplant. It's a significant risk. And in the infant population, by almost 20 years, there are about 15 to 20% of the population that will have severe renal dysfunction. Again, we talked about the infant population having a higher incidence of that. Other risk factors for 1-year mortality in our infant population, so ventilator use, MCS use, particularly if they're on ECMO, not on VAD, congenital heart disease, either with or without surgery, and any diagnosis other than dilated cardiomyopathy. So when we think about our pediatric heart transplant population, there are increasing numbers of indications for transplant, which means an increasing number of patients listed. Many of these have had prior cardiac surgeries and may have preformed donor-specific antibodies. There is a limited donor pool and higher waitlist mortality for pediatrics, up to 20% of our patients. This was a great review article just to kind of show you that some of the take-homes from this is that the waiting times are prolonged for infants and highly sensitized recipients, with the infant waitlist mortality up to 25%. The highest risk groups being those that are on ECMO, on a ventilator, congenital heart disease, and our small size patients. The kind of strategies to improve the waitlist survival in these patients: use of ABO-incompatible grafts, use of positive cross-match donors and antibody depletion, increased acceptance of marginal donors, and then also thinking about going to mechanical support early in these patients. Just a quick slide on ABO-compatible versus ABO-incompatible. You can see in the more recent era, we're doing more ABO-incompatible. I think that's as more centers have become comfortable with it. And again, with our limited infant donor pool. And then looking at functional status, that's really what's important, is how is the quality of life for these recipients. So for our infant recipients, kind of the orange is fully active, normal life, the blue, minor restrictions. And so when we look at it at 1, 3, and 5 years, the majority of these infant recipients are going to lead a normal life and not have significant restrictions and have good quality of life. So just to wrap it up and summarize, overall, our survival is excellent in the current era, with long-term outcomes greater than 60% survival at 20 years. The majority have excellent quality of life with minimal limitations, and our risk factors for mortality being congenital heart disease, pre-transplant sensitization, and ECMO. And so that's really where we need to focus our strategies for improving mechanical support for these patients. And with that, I thank you, and I think we'll do questions at the end.
Muchas gracias, doctora. Sin duda un tema muy apasionante. A continuación, con ustedes, la doctora Kaitlyn Krebuchevsky, Fellow de Cardiología Intervencional Pediátrica, enfocado en reparaciones endovasculares complejas de la Clínica Mayo, con su presentación ¿Qué pasa hoy en día con los pacientes con fisiología Fontan?
Okay, good afternoon, everybody. I'm really happy to be here and to be able to share a lot of the work that we're doing at Mayo Clinic with our Fontan patients. And thanks to all the coordinators for inviting me. So we'll get started. So I'm here to talk mostly about Fontan patients and kind of what is happening to them nowadays. I also wanted to include kind of what's changing with them nowadays, because there's a lot of things that we have been doing in the recent era to try to optimize Fontan patients, especially since they're living much longer and we have a much higher population of them. So these are some of the learning objectives. Basically, I want to go through kind of the history of the Fontan operation and kind of how the palliation has evolved in the last few decades. look at the current data on outcomes and long-term survival in these patients. I want to explain to everybody kind of the unique physiology for the Fontan patients and why they are limited, the categories of Fontan failure and kind of how this relates to their outcomes, and then discuss some mechanical support options that we're using for Fontan patients, and then briefly discuss some of the outcomes of transplant. So I have no disclosures. So for those of you who are kind of not as familiar with single ventricle cardiac disease, it's really a spectrum of disease. So it's not one specific diagnosis. In congenital heart disease, we have a lot of different variations. And how we define single ventricle disease is basically based on the adequacy of the single ventricle. So there's multiple operations with variable survival, and typically these patients will undergo a sort of 3-step palliation. I say maybe 4 because, as we've heard, transplant is common in the congenital heart disease population, and so some are calling transplant as kind of the 4th stage in this palliation. So the first stage of palliation, I'll have some pictures on the next slide, is to establish a restricted source of pulmonary blood flow while also making sure there's no obstruction to systemic blood flow. And so you might hear this called the Norwood operation with a SANA or BT shunt. We're doing a lot of hybrid procedures now in the cath lab where we're putting in a PDA stent and then pulmonary artery flow restrictors. The second procedure in the palliation is to unload that systemic ventricle and essentially take all of the blood that's coming from the upper half of the body and send it directly to the pulmonary arteries. And that's called the Glenn palliation. And then the third step in the palliation is rerouting all of the venous return to the pulmonary arteries. And that's the Fontan. So in terms of when do we do these operations, typically the first stage of palliation is about 1 week of age, so a neonatal surgical repair. The Glenn operation, where you're connecting the SVC to the pulmonary arteries, is normally around 3 to 6 months of age. And the Fontan operation, which you're connecting all of the systemic venous return back to the pulmonary arteries and bypassing the heart completely, is around 2 to 4 years of age. And this is kind of institutional dependent based on when exactly the palliations are done, and patient dependent as well. So the Fontan operation was described not super long ago, in the 1970s. And the first patient was a tricuspid atresia patient. And the goal of Fontan and his colleague were to essentially, similar to what we've been talking about, reroute all of the systemic venous return back to the pulmonary arteries and bypass the heart. And so initially how they did this is they made a connection from the right atrial appendage up into the pulmonary arteries. And initially, some of them were also, as you can see in the picture on my left side, with a homograph valve. And essentially, they were trying to use whatever rudimentary RV was there, or kind of the hypertrophied right atrial appendage, to help as that subpulmonary pump when the patient didn't have that. And as you can imagine with this operation, with all the suture lines that occur and kind of how the hemodynamics and the blood flow progresses, you will get arrhythmias and right atrial dilation. And so next up, it was kind of adapted for the lateral tunnel Fontan, and this was described kind of in the late 1980s by Deval and colleagues. And so basically the goal of this operation was to have an end-to-side anastomosis of the SVC to the RPA, and then create kind of a baffle connection of the IVC up to the PAs as well, going through the right atrium. And as you can imagine here, you similarly have a lot of suture lines, and you're kind of in that right atrial space, and that can lead to a lot of arrhythmias as well. So kind of the most recent adoption of the Fontan, and what we use mostly now in the common era, is the extracardiac conduit. And so this can either be used to be mostly a homograph conduit. Now we've kind of transitioned to using more of a Gore-Tex tube. And this is outside of the heart. So a similar operation where you're basically connecting the IVC and the SVC to the PAs. And so as you can imagine, this avoids the atriotomy, reduces suture lines, so you're decreasing the amount of arrhythmias that occur. And you don't have to cross-clamp the aorta. And so it minimizes a lot of those complications that were previously seen. Later on developed was creating a fenestration in the Fontan conduit. And this was initially described to help with kind of prolonged hospital stays following the Fontan operation and to decrease the amount of pleural effusions and kind of, as you would expect, back pressure into that systemic circulation. And so as you can see in the left picture, you basically just create a small hole from the fenestration into the right atrium. Oops. And one of the other benefits of this is that now that you have a single ventricle, this can actually help with increasing the ventricular preload in this situation. As you can also imagine, now you have a right to left shunt, so the patients will be more cyanotic than somebody without a fenestration. And then later on, if it's not needed, it's very easy for these patients to come to the cath lab and just throw a device in the fenestration to close that hole later on. Similarly, they can come, if we feel like they need a fenestration later on, they can come to the cath lab and we can create that hole. So in the more recent era, there has been some attempts to try to create the Fontan in the cath lab using transcatheter approaches with covered stents. And so this has been described in a few case reports and isn't commonly used in practice as of quite yet. So it was first described kind of in the early 2000s, and some of the more recent case reports have used some different techniques, but essentially what you do is you basically just take an RF wire, so a radio frequency ablation catheter, and you can go through the vessels and deploy covered stents and basically create that communication as you would have kind of a conduit surgically done. We're not doing this quite yet at Mayo, but maybe one day we'll get there. So current outcomes and survivals for these patients. So there's large variation in outcomes for many reasons. One, because of the era, and surgeons are getting better, obviously, at doing these procedures and we're more knowledgeable about their kind of later on effects and morbidities. The techniques of the Fontan operation itself. And similarly, as you saw on the first slide, all of these patients have different cardiac anatomies, and so there's a whole host of complications that they can have that are specific to just their anatomy. So there was this paper from 2019 from the American Heart Association that is showing that we actually are getting better. So you can see in years post-Fontan, in the red is the era from 1992 to 1996, and then the green is 2003 to 2009. And so you can see a pretty drastic improvement in mortality in the Fontan patients. And now we're estimating that transplant-free survival is about 95% at 5 years, and about 90% at 10 years. And this is a similar paper looking at the different types of Fontan, which kind of goes along with ERA. And so you can see in the gray line on the top how the extracardiac conduit, these patients just tend to seem to do better compared to the other types of Fontan. So a similar paper looking kind of further out, so 35 years now, we're getting a lot of this data because these patients are living much longer. And so you can still see that, in the early years, from 5 to 20 years or so, we're sitting anywhere between 85 to 97% mortality risk. And then as time goes on, they do tend to have higher chance of mortality. Even with that being said, patients are living longer. And they're estimating, and I have a graph on the next slide, that we're going to have about 80,000 Fontan patients living by 2030. And most of these are adult congenital heart disease now patients. So what happens to these patients over the course of their lifetime following the Fontan operation? So this is just the graph showing basically the estimate of surviving Fontan patients over the course of years. So this graph on top goes from 2010 all the way to 2030, and they estimate that it's going to be anywhere between 60 and 80,000. So what's happening to these patients? What puts them at risk for having kind of worse late survival? And so I kind of listed some of the things here from some of the literature that's out there. So older age at Fontan puts them at higher risk. They probably have developed more morbidities if their Fontan is later on. If they have a right ventricle, that's their dominant ventricle, they tend to have ventricular dysfunction earlier than the left ventricle would, if they're male, sorry, for everybody who's male. If they have common AV valve regurgitation or some issue with their common AV valve. If they develop any late complications, which we'll talk about, so protein-losing enteropathy or plastic bronchitis, prolonged pleural effusions, if they have elevated PA pressures pre and post-transplant, as you could imagine, that would be not amenable to Fontan circulation, and if they have any other concomitant surgery. And unfortunately, still 50% of patients will have a major adverse event prior to even adulthood. And so we can group kind of Fontan failure into two main categories and then further break it down. So you can think about it in terms of them having ventricular failure or actually having Fontan circulatory failure. And this Fontan circulatory failure, as we were discussing, it's all because of the passive venous flow. They no longer have that subpulmonary pump to pump to their pulmonary arteries. And so this is just a schematic looking at the different hemodynamics between a normal patient and a Fontan patient. And so as you can see on the Fontan patient side, again, they don't have that subpulmonary pump of the right ventricle. And so they require chronic elevated central venous pressure in order to push that blood forward. And so that can cause issues in the long term. And additionally, having this diminished ventricular preload and kind of having this elevated chronic central venous pressure, they do have limited cardiac reserve, which is exacerbated with residual cardiac lesions. And so this Fontan failure can really occur at any part of the Fontan pathway if there's obstruction or an abnormality. And so just going further a little bit into it, I mentioned that there's ventricular failure and Fontan failure, but it can be further categorized into kind of 4 different groups that we're using now. So systolic failure in the first group is kind of the first phenotype. So we call that Fontan failure with reduced EF. The second group is Fontan failure with preserved EF, so if they have essentially diastolic failure. The third phenotype is they don't have cardiac failure and their Fontan's okay, but they have other kind of extra cardiac abnormalities. And then Fontan failure with lymphatic abnormalities in the last group is our group that has PLE, plastic bronchitis, and those sorts of complications. And so as you can imagine, those patients that are strictly having systolic or diastolic failure, once they undergo cardiac transplant or put on MCS, they tend to do better than ones that have extra cardiac issues. And so these are just some of the other adverse events that we see in the Fontan population. So arrhythmias are really prominent in this population, Fontan obstruction, pathway obstruction, ventricular dysfunction, AV valve regurgitation, protein-losing enteropathy, thrombotic events, hepatic complications. Their peak VO2 for exercise tolerance is dramatically lower than the normal population, and then a variety of other complications that occur. And so there's been a lot of people trying to promote kind of a multidisciplinary approach to these patients and when to refer them for advanced heart failure consultations. And we're really lucky in that we have a large ACHD group at Mayo, which I understand can be difficult in other institutions. And so just looking at all the different things that can happen to these patients and when they would qualify for having an advanced heart failure consultation is really important. And so this is a good reference to look at to kind of understand when to do that. So all these different things, and it's not meant for you to read the fine print, again, kind of going along that multidisciplinary approach to these Fontan patients. So a whole host of medical therapies that we can use, surgical interventions, cath and EP interventions, mechanical support strategies, and then heart transplantation. And so I'm going to just quickly go over some of these things that we do to help these patients. So at Mayo, we're really aggressive with optimizing the Fontan circulation to try to help these patients not only feel better, but optimize them for transplant. And so more frequently, I think in the common era, rather than surgical interventions, we're doing these catheter-based interventions, and it can be anything from collateral embolization to lymphatic interventions, stenting of the Fontan conduit, and even transcatheter valve replacement therapy. And so this is just showing a paper how many of these Fontan patients are undergoing intervention. So this is a paper from 2017, and they looked at essentially what surgical procedures are the Fontan patients undergoing. And it's mostly pacemaker implantation. And then transcatheter procedures, 50% of the patient population underwent transcatheter procedures. And it's anywhere similar to what I said, to Fontan fenestration closure or Fontan fenestration creation, Fontan stenting, et cetera. And so here are just a few examples from our cath lab. You can see this is a Fontan angiogram with a Fontan stent placed in it. This is a PA stent, so we do a lot of PA stenting procedures to try to minimize obstruction as well. And this is a large VV collateral that we embolized to help with cyanosis in the Fontan patient. And just for this conference purposes, we can do a lot of these procedures through ECMO circuits, so we can essentially cannulate the ECMO cannulas and place sheaths in them. Sorry about that. And perform procedures through the sheaths in the ECMO cannulas, and then essentially clamp and cut the circuit and reconnect them with the wet-to-wet. And so this is an example of a AP collateral embolization with a patient on ECMO. So mechanical support strategies, I think this is a big thing for these Fontan patients. When they have Fontan failure, there's no great mechanical support strategies for these patients. So as we know, a lot of the current technology is better suited for patients with ventricular pump failure. Similarly, we don't have great support for Fontan circulatory failure. We're working on it, we are. I'm going to skip over some of these slides and just in the interest of time. So this was a patient, a 15-year-old HLHS that had Fontan palliation. He had failed Fontan physiology with cirrhosis, elevated Fontan pressure, varices, low cardiac arrest, and low cardiac reserve, and had a cardiac arrest after a plugging event. He had normal ventricular function, and he was initially placed on VA ECMO in kind of an ECPR situation. And then we were able to change the ECMO cannulation strategy to put him more on what we call Fontan pump physiology. And so essentially you can see here, and I'll show it on a few of the next slides, he has a cannula in his PA, that's his return cannula, and his drainage cannula is in the Fontan circuit. And the goal of this is essentially to promote blood flow through the Fontan circulation to try to relieve that congestion. And so this patient was successfully bridged to transplant with this strategy. This is based on some work and research that's been done in this field previously to try to promote the Fontan circulation. None of this stuff is really being used officially yet, but it's kind of in the developmental research phase. And so different VAD technologies to try to promote or support the right-sided circuit. And so there's been a few case reports showing this. The slide's not here. And there is a large multi-center study underway as well to try to look at, can we have sort of a VAD technology to support the right-sided circulation in these patients. And so this is the idea of the Fontan pump. You're essentially trying to create flow through the Fontan circulation with help of the kind of Venturi effect of pushing the flow through the circuit. And so we're kind of studying this now at Mayo to try to develop something like this. Okay. I'll skip over some of this in the interest of time, but essentially just looking at transplant in these patients, in both the pediatric and adult population, we are getting better. So the right-sided graphs are in the current era compared to the left-sided graphs, which are in the earlier eras. And so you can see that in Fontan patients, we are getting better with transplant. And I think it's because we're optimizing them more prior to transplant to try to mitigate some of the effects, post-transplant that they still might be dealing with. I'll end there in the interest of time. This slide was just to show also similar to what we were saying, that those patients that have impaired function compared to preserved function are the ones that tend to do better because they don't have those extra cardiac manifestations. That's it.
Muchas gracias, doctora. Sin duda un tema muy complejo. A continuación vamos a dar paso a un conversatorio, así es que todos los que tengan preguntas, por favor, vamos a estar disponibles para atenderlas. El tema es soporte circulatorio mecánico postcardiotomía en población pediátrica. Consejos: cuándo, cómo, descompresión del ventrículo izquierdo y monitorización. ¿Alguna pregunta del público? Yo les quiero hacer una pregunta. ¿Sí? ¿Me escuchan? Yes. Yeah. Hello. Cuando ustedes saben que van a tener un paciente que va en picada o un paciente de una cirugía muy compleja, un Norwood, por ejemplo, ¿cómo se preparan como equipo para una eventual conexión de urgencia? Me refiero a, ¿tienen un circuito cebado? ¿Los cirujanos dejan las garetitas listas para llegar y canular? ¿El team está avisado? Porque más o menos les pongo el contexto acá en Chile. Nosotros en el horario extra horario de hospital o clínica, por ejemplo, está de llamado la mayoría del equipo y el tiempo de respuesta es 1 hora. Puede ser mucho menos también. Pero ustedes, ¿cómo preparan esto? ¿Cuáles son los tips que nos podrían dar para nosotros aprender de ustedes?
I would say in our congenital heart population, it's a very close communication with our surgical colleagues. If we think they are going to do a congenital heart palliation where there is a high risk of need for mechanical support, we will often talk about what is the best support strategy for that patient going in. If they are able to separate from bypass, but there's still kind of question about that patient, we'll often leave the chest open or even leave cannulas or placeholders in place so that we could quickly go on support if need be. I think in our, if it's another patient coming in from the outside, we definitely are working to have ECMO support strategies that we could do peripherally. And so particularly for me in our heart transplant population, or we've incorporated this in other patients that we think are high risk of a sudden cardiac event, we actually have created an ECMO sheet to have available at the bedside where all of their venous and arterial anatomy is mapped out to say what vessels are open and what would the cannula sizes and support strategy be for those patients. So particularly the transplant patients, but again, other high-risk patients that maybe come in and are sick and will still go on to a palliative surgery, but we think that there is a risk of a sudden cardiac event, we will have those ECMO sheets at the bedside.
Yeah, and just to your question, we always have a circuit that's nearby. And often with our post-surgical patients, it's just like a good team communication. I think we usually have a good anticipation of the patients, what is decompensation going to look like? And so just making sure that everyone who's involved in the care knows what we think is the most likely etiology of an arrest or decompensation, how to check that early, and just really good communication and teamwork.
Thank you. Doctor Contreras, ¿pueden llevar un micrófono, por favor?
Hola, yo tengo 2 preguntas. La primera es, uno ve actualmente que la disponibilidad real en el mundo de dispositivos de asistencia ventricular en pediatría son escasos, ¿cierto? Antiguamente estaba el Berlin Heart, estaba el hardware que salió del mercado, ¿cierto? Y después tenemos el HeartMate 3, ¿cierto? Que es muy grande y en un niño menor de 40 kilos probablemente no entra. La primera pregunta es, ¿cuál es la realidad que están manejando ustedes en los dispositivos de asistencia ventricular? ¿Cuáles son las estrategias? Y la segunda pregunta es, dado que los pacientes con Fontan van a tener una vida muy compleja, con 3 o 4 operaciones, ¿en qué están los centros que están haciendo trasplante primario para estos pacientes?
So first I'll address the VAD question. Yeah, it's unfortunate that we don't have VADs available for our smaller size patients, particularly that they could go home on. Thoratec is developing the PVAD or MVAD that is a smaller version of the HeartMate 3. So it will be more similar profile to the HVAD, where hopefully we can use that down to maybe 20 or 30 kilos and be able to discharge some of those patients to the outpatient setting. Otherwise, we really are stuck in that patient, 50 kilos and under of using, we try to use Berlin Heart cannulas just because of the stability of those cannulas. Even if we don't have pumps or the, driving units available for the Berlin Heart, using the cannulas is a more stable position, and then we might use those with a Centromag pump until we can get the Berlin Heart pumps available. But I don't know here, but in the US even there is a significant shortage of pumps and of the driver units. As far as your second question, I'm going to... Yes. Yes. So I think there are, in the late 80s and early 90s, when the outcomes for the Norwood operation were dismal, everybody shifted to doing primary infant transplant for hypoplastic left heart patients. And then we realized there's not enough infant hearts to go around, and so the mortality on the wait list was incredibly high. We shifted towards kind of a Norwood for everybody, although some of those would not do well. And I think now we're trying to find the balance in between to say which patients are going to be high risk for never making it to a Fontan or a successful Fontan, and determining the appropriate timing for evaluating and listing them for transplant. Things like if they're born with ventricular dysfunction, if they're born with severe AV valve regurgitation, if they have quite small pulmonary arteries, there might be particular anatomies and physiologies where we say they would be better served by primary infant transplant than struggling through single ventricle palliation.
I want to ask a question. In Australia, there's a very long wait for organs in the less than 1-year-olds, and most of our patients will wait for a year on Berlin, at least in the hospital. It's very resource intensive. We don't yet have a paediatric donation after circulatory death program, although there is an adult program that comes out of Sydney. Are you doing donation after circulatory death? Are you doing it with ex vivo perfusion setups, and does that make availability for neonatal-sized patients?
Yeah, so that's a great question. Our infant wait times tend to be shorter than that. Our infants actually, we tend to have a wait time of anywhere from 2 to 4 months, particularly being able to use ABO incompatible. If we get to kind of the toddler age range and above, those kids are the ones that really wait a long time. And then obviously our adolescents have shorter wait times because they can utilize adult hearts. The DCD has been very controversial. There are very few centers who will do DCD. There are many donor centers that say they will do DCD, but they don't allow normothermic regional perfusions. They don't allow NRP. Our current practice in our adult practice is to use NRP for those, and that's what we are established to do in the pediatrics. We have not yet done one, but we have everything in place to be able to do it. I think we were talking about this at dinner last night, that we have considered 3 DCD donors. However, those donation centers would not allow NRP, and so we didn't proceed with those.
Por acá hay otra pregunta, en primera fila.
So with our international and Mayo colleagues up there, I feel a discrepancy between how patients often are put on support. Our practice tends to surgical or interventional cardiology. It's across the hallway from my office, so I see it every day. Versus, I think, in the international practice, is much more cut down, surgical, CV surgery. It'd be nice to just hear you guys discuss, the pros of involving interventional cardiology and what that adds to the practice versus not.
I think in the pediatric population, especially with having our congenital patients, having the interventional team is really great. There's sometimes very difficult anatomy. A lot of these Fontan patients can have just really poor, really small vasculature that just isn't going to provide cannulas. It's going to need the level of support that we need for a lot of these patients. There has been, a lot of, Caitlin, she was showing some of the work that they're doing. The work that some of our interventionalists can do is unbelievable. They've created vessels that weren't there, to put patients to get them onto support. And I think, it's a good conversation. I think it's, teamwork is everything. Chatting with our surgeons, using the interventional team, a lot of these patients as well that are congenital, it's high risk to go into the chest again, to do central ECMO. And so I think it's a good teamwork, and I think especially with our creation of an ECMO sheet that we've noticed, these patients that are high risk or that have been on ECMO previously, after their Norwood operation, they may be missing, the right carotid, the vessels may be ligated, and so it just makes the cannulation really difficult. And so having, I think, really a big team approach to it has been just in our patients' best interest, really.
I would add to that and say, I think even some of those more complex reduced sternotomies, having an approach where even if we say we can get them on partial support to get them stabilized to the OR and be able to go on central ECMO, but I think the work with our interventional colleagues has been incredibly beneficial for those patients that otherwise, if you were in a rest situation, trying to get them reopened and onto ECMO, it would take hours, so.
Our availability of interventional cardiology in Melbourne is very limited. We have a very surgeon-heavy program, and we're behind the times, I think, in that regard, particularly with hybrid interventions. We just don't have the capacity to do it yet. And most of my discussions for extra resources in the cardiac space are around improving our hyperplast outcomes and the things that are needed for that. And I'm always jealous hearing about what North American centres have in terms of not just interventional cardiology, but even diagnostic cardiology, echoes in theatre. We're very heavy on the cardiac surgeon and much lighter on the cardiologist.
I don't want to make it sound like we don't appreciate our surgeons, because we do, and there are many times where we do need them to go on support. But we try, because we have such long wait times to transplant, we try to do as much to be able to get these patients ambulatory afterwards. And so if they are peripherally cannulated or if they're centrally cannulated, there's very specific strategies to secure the cannulas and make sure that we can get the chest closed and get these patients ambulatory, because we know their outcomes are going to be better.
I think also importantly, we're doing a lot more high-risk procedures in our cath labs as well. And so we've kind of adopted the model that if the patient has an ECPR event in the cath lab, the interventionalists are the ones who are there to quickly and efficiently put them on ECMO. And one of the things that I've learned through training, I think, in interventional cardiology training itself, cannulation and kind of ECMO as a whole should be incorporated into training programs. So for anybody who's looking to develop a new training program for interventional cardiology, I think it's an important tool for us to know, and it's all on the basis of things that we're already doing every day, so access and wiring and inserting sheaths, essentially. And just learning those basics and then kind of understanding the development of other aspects of ECMO, I think is an important part of training programs.
Have you got the new portable console for the Berlins?
So the active driver trial was ongoing in the US, but it is currently paused. That's part of the backup of Berlin equipment, is that the Berlin company stopped making the ICUS drivers because they were developing the active driver. And there's something that the FDA paused the trial because of a battery component that they questioned or wasn't part of the original trial. And so unfortunately that has really limited us.
We've got the much smaller modules, which perhaps is what you're talking about. We've had a couple of instances, because patients are much more mobile with it and able to get around, we've had problems with the connection point between the Berlin cannula and the pump itself fracturing, which is catastrophic when it happens.
Yeah, I've had that happen once early in our Berlin experience, and with that we incorporated a specific cable tie to secure that connection, and then also like Q-shift checks on those cable ties to make sure they were more secure, and then also having ECMO clamps available on the driver unit so that if they did have an event, all the nursing staff and staff that works with those patients were taught to immediately clamp the cannulas.
Yes. ¿Tenemos otra pregunta? Ahí van.
Muchas gracias a los presentadores. Quería preguntarle a la doctora Kreuszewski sobre en qué pacientes prefieren hacer un cateterismo a través de las cánulas del ECMO y qué tipo de complicaciones o puntos más críticos tienen en ese tipo de procedimiento.
Yeah, I think, patients, we do a lot of collateral embolization for patients on ECMO. I think especially AP collaterals when we're limited by flows. And, really the technicality of it is pretty simple. We will access through the arterial cannula, place a sheath as if you were to place it in a vessel. Because of the negative pressure from a venous cannula, it's very dangerous to do that for the venous cannula because you can entrain air. But we've done everything from collateral embolization to PA stenting procedures to many other procedures. I would say the biggest risk, to be completely honest with you, would be kind of if you're not experienced doing the type of procedures and disconnecting and reconnecting the ECMO circuits itself. So being knowledgeable about, cutting and clamping and reconnecting with the wet-to-wet is where I think we see the largest set of complications. But other than that, you're limited by the sheath access, like French size that you can put into the cannula as well. So I think we put up to an 11 French sheath inside of an ECMO cannula, and obviously it depends on the size of the ECMO cannulas as well. But
I want to comment that our interventional colleagues are phenomenal. Like some of the creativity that they have to be able to do things when we are on ECMO support. I thought the case that she was going to present, the Fontaine case she was going to present, was one that we just did. Was again a 15-year-old failed Fontaine who was decompensating, and we felt needed to go to ECMO, but he had severe aortic valve regurgitation, and so we felt we couldn't appropriately support him, and so went to the cath lab and had a TAVR valve placed in the neo-aortic position, and then went on peripheral ECMO to support him following that, and then was successfully bridged to transplant a few weeks later. So I think the creativity of our cath colleagues in trying to optimize patients that are on ECMO is really phenomenal.
¿Alguna otra pregunta? Arriba hay otra. La última.
Hola. Hola, buenas tardes. Muchas gracias. Mi nombre es Cristian Ramírez, enfermero, y mi pregunta va dirigida a la asistencia ventricular. ¿Cómo decidir entre prolongar el ECMO versus pasar precozmente a una asistencia ventricular considerando las complicaciones en general relacionadas con la anticoagulación y la logística que lleva esto? Eso, gracias.
Yeah, so some of it depends on their anatomy. Obviously, most of the single ventricle patients will be better supported on ECMO depending on the stage that they're at, but they might have better oxygenation with being on ECMO than trying to do a single ventricle assist device. But in general, if it's, single ventricle heart failure, meaning left ventricle and not right ventricle, and the lungs are relatively healthy, we would try to go to ventricular assist device without the oxygenator. There are occasions where we think that the right ventricle is going to be okay, and then we get in there and we end up needing BiVAD support. But again, if we don't need to use an oxygenator, I think it lowers the risk of their ECMO complications in the long run.
If we have a single ventricle that can't get off ECMO after their first stage palliation, and we've attempted to make sure that we've corrected everything that is correctable, we tend to stop after 14 days because the outcomes are poor after that. And we're looking at that within day 10. Similarly, if we have a patient that comes in with a myocarditis and they end up going on to ECMO, then we would be trying to transition them to either come off within that 14-day period or changing them to an LVAD. Hopefully an LVAD, not a BiVAD.
Muchas gracias por su participación, muchas gracias a todos los expositores por estas grandes charlas.
No se levanten todavía sus asientos, unos segundos solamente. Está acá con nosotros la doctora Carolina Ruiz, presidenta de la Sociedad Chilena de Medicina Intensiva, quien les va a dar algunas palabras.
Bueno, hola, muy buenas tardes a todos y todas. Agradecerles por acompañarnos en este simposio de ECMO. Agradecer muy especialmente al doctor Rodrigo Díaz, director del simposio, al doctor Pablo Afún, quien como nuestro vicepresidente ha estado a cargo de esta actividad por parte de la SOCHIMI. Agradecer a los invitados e invitadas internacionales, ¿cierto?, que han viajado desde Estados Unidos, desde Australia, para compartir su experiencia con nosotros, su casuística con nosotros. Así que estamos muy contentos de tenerlos presentes y quiero invitarlos a nuestra próxima actividad, que es un simposio de la industria auspiciado por el laboratorio Knight sobre el uso de isobucanazol en los pacientes en ECMO. Como sabemos quienes trabajamos en UCI, las infecciones fúngicas en estos pacientes son especialmente desafiantes. Muchas veces tenemos duda de qué pasa, ¿cierto?, con los antifúngicos y la membrana, qué pasa con la farmacocinética, con la farmacodinamia, y es por eso que hoy día el doctor Alex Matus, quien es internista y infectólogo del Instituto Nacional del Tórax, además docente de la Universidad de Chile, nos va a contar al respecto. Alex tiene mucha experiencia al respecto, es joven, pero empezó más joven aún. Sin duda debe ser el infectólogo, ¿cierto?, con más experiencia al respecto en estos pacientes tremendamente desafiantes. Así que es un agrado que nos pueda acompañar hoy día y contarles que al término de esta actividad, el laboratorio Knight va a compartir con nosotros unas cajitas de box lunch que están muy ricas, así que no podemos ingresar comida al teatro, pero al término vamos a poder compartirlas, ¿cierto? Y a quienes quieran hacer otra cosa en la hora de almuerzo, volvemos a las 2 de la tarde, pero los invito a que se queden porque realmente va a ser una excelente presentación y pocas veces uno tiene tiempo, ¿cierto?, de contactar a un experto en este tema. Así que muchas gracias. Y Alex.
Gracias, doctora, por la presentación. Les prometo que no solamente les voy a hablar de isavuconazol para los que se van parando, sino que además les voy a contar lo que nosotros hacemos para diagnosticar y manejar en general las infecciones fúngicas e invasoras en los pacientes con ECMO. Así que esto va mucho más allá del paciente que está con isavuconazol. De hecho, los voy a invitar a que me acompañen un día en una de nuestras 30 camas de la UCI. Tengo un paciente típico en ECMO, tenemos 1 o 2 más o menos por mes. De hecho, tenemos más de 80 pacientes desde el 2022 a la fecha. Y este es un paciente clásico que está con una influenza, con un ECMO venoso y que está evolucionando con un shock de probable etiología séptica, ¿no? Entonces pasa nuestro residente, nuestro R1, nos dice, viejo, tienes que partir antibióticos antifúngicos de manera urgente. Por supuesto que la residente seguida dice, a ver, doctor, ¿es urgente? ¿Qué antifúngico inicio y en cuál dosis? Esas preguntas voy a intentar contestar en la siguiente media hora, si es que me lo permite. Primero, conozcamos por qué se infectan nuestros pacientes en ECMO. Lo más habitual de nuestros pacientes es que se infecten por las IAs habituales. ITS por CBC, neumonía del ventilador, ITUCUB, diarrea por Clostridium, ¿no? Y es excepcional que las infecciones tengan relación con el sistema propio de canulación del ECMO. Mediastinitis cuando son venoarteriales, infecciones del sitio de inserción de las cánulas, o biofilm asociado a bacteriemias o fungemias de también las cánulas, ¿no? Nuestros pacientes se van a infectar la mitad, eso es lo malo. 50% de nuestros pacientes se van a infectar en algún momento por alguna de estas causas. ¿Cuál es el factor principal de riesgo de que se nos infecten? El tiempo. Y aquí viene la máxima que ustedes conocen. Apenas implanto un ECMO, tengo que decir, ok, ¿cuándo lo saco, no? Si se fijan, este es un trabajo clásico de Dr. Gracelli. El día 10, entre un 20 y un 50% de nuestros pacientes ya va a estar infectado. Entonces, primera conclusión, las infecciones en nuestros pacientes en ECMO, por supuesto que tienen una incidencia alta, y la etiología va a ser siempre la más probable, una IAS habitual que ustedes conocen. No piensen en cosas raras, prácticamente nunca lo vemos. Siguiente pregunta, ¿qué patógenos infectan a nuestros pacientes en ECMO? Este es un estudio que está corriendo actualmente, también es de Dr. Gracelli, es multicéntrico internacional. El Instituto Nacional del Tórax participa enviando datos de esto, y a la fecha tenemos que solamente un 9% de nuestros pacientes tienen infecciones fúngicas invasivas, o IFI, y de las cuales están principalmente en pulmón, donde están los filamentosos, aspergilosis principalmente. Mucho menos proporción, sangre, un 8% de las infecciones totales, donde la cándida también tiene un rol. A nivel local también tenemos nuestros números entre el 2022 y el 2024, con lo que decía, más de 80 pacientes. Tenemos que las infecciones por hongos son un 3% apenas. Ojo, aquí estamos sacando los kappa, la aspergilosis en COVID, y los yappa, la aspergilosis en influenza. Este 3% son una cándida y una aspergilosis, nada más que eso. Aspergilosis por lo demás que no era terrus, que son los que nos dan miedo, ¿no? Y 9 kappa tenemos más o menos de aquel entonces hasta la fecha y 4 IAPA. Esa es más o menos nuestra experiencia en infecciones fúngicas en ECMO. Entonces sí, tenemos infecciones fúngicas invasoras, pero bajísima incidencia. Entonces, ¿impacta realmente la mortalidad la infección fúngica invasora? Todos sabemos que nuestros pacientes en ECMO, este es un metaanálisis muy bonito, mezcla un montón de números por varios años, 37% más se va a morir nuestro paciente que está infectado versus el que no está infectado. Y cuando miramos el detalle de qué patógenos influyen más en la mortalidad, si se fijan en la columna del lado derecho y vemos los cuadritos de colores, acá es cuando aparecen los hongos. Si miramos los números absolutos, cuando comienzan a aparecer los hongos en cualquier foco, sangre, pulmón, orina, herida operatoria, esos pacientes sobreviven menos. Y bueno, la ELSO también, con números que son de ellos del 2020 y tanto, 2018, habla de que la mortalidad absoluta en ECMO es de un 48%. Perdón, la sobrevida. Pero si lo comparamos con la sobrevida cuando estamos infectados, ya sea por cándida o por aspergilosis, por supuesto que mi sobrevida cae. O sea, efectivamente, las IFI en ECMO tienen un impacto en la mortalidad de nuestros pacientes. Entonces, ¿cuándo voy a sospechar una infección fúngica en los pacientes que están en ECMO? Lo primero es que los criterios clásicos y habituales de las IAS los tenemos que seguir utilizando acá. Por supuesto que es desafiante, no vamos a tener una radiografía bonita con un foco neumónico, pero tenemos que utilizar los mismos criterios de siempre. Nosotros no lo modificamos. ¿Por qué? Porque la incidencia de las infecciones fúngicas es baja, pero siempre atentos, sobre todo los pacientes en shock. Ahí está el desafío, porque ese es el paciente que se te va a morir si llegaste tarde. Entonces, ¿qué hacemos nosotros? Cada vez que tenemos un paciente infectado en shock, estamos pensando en el hongo, tratando de descartarlo de alguna forma que se las voy a mencionar a continuación. Por supuesto que si el paciente está en shock refractario, estamos con segunda, tercera línea de antibiótico terapia, el paciente no tiene un patógeno identificado o no tiene un foco claro, debo yo pensar en infecciones fúngicas y trabajar con eso. ¿Cómo trabajamos nosotros? Criterios clásicos. Estos son los criterios clásicos validados por un montón de sociedades hace años que no están validados para el ECMO. Eso es lo interesante. Lo que nosotros hacemos es que consideramos efectivamente el ECMO como un factor de riesgo y lo metemos en esta tabla a la fuerza para poder trabajarlo. Esto es conocido, ¿no? Posible, probable, probado de infecciones fúngicas invasoras por Aspergillus. Y nosotros utilizamos los puntos de corte de galactoma-nano, también que son conocidos por todas las sociedades. 1.0, cuando es lavado, utilizamos puntos más bajos cuando tenemos algún galactoma-nano sérico sobre 0.5. Ahí bajamos un poco el corte del galactoma-nano en lavado broncoalveolar. Y por supuesto que partimos terapia empírica si es que estamos en la condición de IFI probable, ¿no? Con respecto a las candidiasis, también utilizamos los clásicos algoritmos europeos, norteamericanos validados, donde, si se fijan acá, sacamos la rama de las sepsis abdominales porque son muy pocas en nuestros pacientes en ECMO. ¿Y qué hacemos? Lo clásico, nos guiamos por la ramita de que no hay sepsis abdominal, por lo tanto lo que vamos a plantear es algún score de probabilidad de infección, el que ustedes conozcan, todos ustedes son intensivistas, así que conocen varios, ¿no? Más que yo probablemente. Candida Score, Score de Sevilla, el Score de portación de Cándida, el que ustedes conozcan, ojalá tengamos más de uno en nuestro conocimiento, por último en el celular, ¿no? Para poder validar la posible infección fúngica. La guía, eso sí, o este algoritmo, introduce que cuando tenemos negativo mi score, debiésemos tomar un beta-glucano. Beta-glucano, la verdad es que para nosotros no es útil, no lo utilizamos. Más de un 40% de nuestros pacientes en ECMO van a tener falsos positivos por simplemente el componente de la membrana semipermeable. Por lo tanto, no es una herramienta válida para nosotros. Entonces, esto es mío, esto no sale en ninguna parte, probablemente estoy equivocado y probablemente los colegas norteamericanos me pueden destruir en este momento, pero esto es lo que nosotros hacemos en el Instituto Nacional del Tórax. Cuando tenemos un paciente en shock, lo primero que hacemos es decir, ok, ¿cuál es mi foco? Si pienso que el foco es pulmonar, difícil de identificar en ECMO, pero me voy a fijar cómo está cualitativamente el esputo, cómo están mis volúmenes tidales, cuánto estoy moviendo de PaO2. Si tengo alteración, obviamente la imagen es mi primera herramienta. Olvídense de TAC, ¿no? El paciente está grave, no lo puedo llevar a TAC. Radiografía, poca evidencia, poca utilidad, porque generalmente los pulmones están muy pelados, difíciles de interpretar, pero si yo encuentro progresión de las imágenes, eso por supuesto que me hace sospechar que estoy bien en lo correcto y que mi foco es pulmonar. Lavado. Nosotros en el tórax tenemos fibrobroncoscopios, podemos hacer lavado broncoalveolares y nosotros le hacemos a todos nuestros pacientes que sospechamos que están en esta rama. Por supuesto solicitamos galactoma-nano, cultivo corriente, cultivo de hongo y nosotros además tenemos acceso a diagnóstico molecular con el FIMARRAY neumonía. Y en cuanto al estudio sérico de estos pacientes, nosotros rara vez utilizamos el galactoma-nano sérico. ¿Por qué? Porque casi siempre tenemos el lavado. En las situaciones excepcionales que no tenemos acceso al lavado, tomamos un galactosérico y hacemos un aspirado a ciegas por el kinesiólogo y tratamos de ver si es que cumple o no cumple criterios según lo que les mencioné recién. Por la otra rama, cuando estamos pensando que no es pulmón, entonces se nos aparecen las candidemias, ¿no? La fungemia. ¿Qué hacemos? Primero cultivos, siempre, esto se los menciono que no todos los centros se hace, 3 sets al menos, ¿no? Del invasivo, de los periféricos, siempre en set. Si el paciente tiene un catéter de diálisis, también le hacemos un set y nosotros tenemos acceso a diagnóstico molecular con FIMARRAY sepsis. Y en esta rama empezamos a pensar en los scores de probabilidad de cándida, los que les mencioné. Si tengo 1, 2 positivos, entonces por supuesto que en esta situación yo voy a partir tratamiento empírico antifúngico. ¿Con qué? Ya se lo voy a mencionar después. Mientras tanto, activamente busco foco, ecocardio y cuando el paciente lo tengo más estable, TAC con contraste. Por el contrario, si el score me da negativo, entonces en este caso, ya les dije, beta-glucano no es una alternativa. Nosotros no tenemos acceso a PCR panfúngica o específicas de cándida y nuestra conducta ha sido siempre permanecer expectantes. Expectantes que es respuesta antibiótica, buscamos otro foco, si a las 72 horas no tenemos respuesta, replanteamos el algoritmo, ¿no? Por lo tanto, por la mortalidad asociada a las IFI en ECMO, siempre debemos tenerlas presentes. Y lo otro importante, siempre debemos conocer al menos los algoritmos que les acabo de mencionar para poder tener en nuestra cabeza o en nuestro celular un score fácil diagnóstico y de aproximación a la aspergilosis y a la candidiasis. Entonces, lo importante, tratamiento. ¿Cómo voy a tratar a estos pacientes? A ver, insisto, esto lo saben ustedes más que yo, ustedes son intensivistas. Es un desafío ya en un paciente de UCI iniciar antifúngico. Los pacientes están con volúmenes de distribución por las nubes, proteínas por el suelo, están, no sé, transfundidos, reanimados con exceso de cristaloide, falla de bomba, no sé. Es un desastre, ¿no? Y además le sumamos que nuestros pacientes en ECMO, ¿no funciona esto? Ahí sí. Nuestros pacientes en ECMO además van a presentar un cierto grado de secuestro del antifúngico. Y ese secuestro está mediado por la membrana y por el material de las cánulas. Y además, esto nos obliga, para poder anticiparnos, a conocer las características farmacocinéticas de nuestro antifúngico, ¿no? ¿Qué tan lipofílico es? ¿Qué tanta unión a proteínas tiene? Mientras mayor sea eso, mayor va a ser mi secuestro. Entonces, bueno, nosotros tenemos ECMO desde el 2010, yo estoy desde el 2017 en el tórax, y siempre fue un problema qué antifúngico iniciamos, cómo lo hacemos. Antes no teníamos farmacólogo clínico, siempre costó, pero nos cayó del cielo esta guía, que es del 2024, es un artículo en realidad de la ITSA, que nos dice, yo les tengo la solución y les tengo una tabla con las dosis más probables que ustedes pueden utilizar en los pacientes con infecciones fúngicas en ECMO. Ahora, por supuesto, nada es maravilloso, ¿no? Todo trae problemas. Los problemas, primero, les puse signo de pregunta ahí, anido de la fungina, ellos dicen dosis estándar. Ellos dicen también problema, voriconazol, dosis estándar, ¿sí o no? Flechas amarillas, anfotericina liposomal, fluconazol y sabuconazol, que es el tema de ahora, dosis mayores. ¿Por qué? Y lo verde, la cafofungina, que en realidad todos ocupamos la dosis estándar porque es bastante hidrofílico y nos defiende, así que le pusimos ticket verde, ¿no? No voy a hablar de micafungina porque no lo tengo disponible en mi hospital, no tengo experiencia, y porque el posaconazol además tampoco lo tenemos disponible para tratamiento, la experiencia que tenemos es solamente con profilaxis, no la voy a mencionar acá. Entonces vamos a hablar del isavuconazol. Generalidades, cuando ustedes se enfrentan a la cajita del isavuconazol, doctor, ¿qué dosis le administro? Partimos con problemas, ¿no? El isavuconazol sulfato, que es la prodroga, tiene 372 miligramos que son equivalentes al isavuconazol de 200, que esa es la dosis, pero la caja viene de 100 con 186. Todo es complejo, apréndanse los 200 miligramos, ¿no? Ahora, la gracia del isavuconazol. Primero, las dosis están demostradas con farmacocinética lineal, o sea, si yo dejo 200 en carga por 6 dosis más 200 al día de mantención, ese paciente debiese alcanzar las concentraciones mínimas esperables. Otra de las gracias, una biodisponibilidad oral maravillosa, es lo mismo que administrar lo intravenoso. Lo otro, que es bueno pero malo para el ECMO, es muy lipofílico, con una alta unión de proteínas. Eso le confiere un volumen de distribución altísimo, o sea, llega incluso al sistema nervioso central. Pero, como ya dijimos, nos va a plantear problemas con el ECMO, ¿no? Espectro de acción, altísimo espectro de acción. Tenemos para, por supuesto, los filamentosos como la aspergilosis, los mucorales, otros filamentosos más atípicos, están bien cubiertos. Lo mismo con las levaduras, cripto, cándida, levaduras atípicas, están todas cubiertas. El isavuconazol en la aspergilosis pulmonar además está validado como primera línea por las principales revistas y sociedades internacionales, americanas y europeas, ¿no? Y no solamente porque tiene un perfil de... ¿Cómo vuelvo? Ahí. No solamente porque tiene un perfil comprobado en sobrevida, que es muy similar cuando trato voriconazol versus isavuconazol, sino que además tiene bajísima toxicidad, por lo tanto es una primera línea, ¿no? Lo mismo pasa con la mucormicosis. Cuando comparamos sobrevida en pacientes con anfotericina versus isavuconazol, vemos que las curvas se comportan prácticamente igual. Y además, si le sumamos que las anfotericinas tienen falla renal altísima asociada a su implementación, se convierte en primera línea cuando el paciente tiene algún grado de alteración renal, que, por supuesto, en nuestros pacientes graves, bordea el 30-40%. Reacciones adversas a fármacos. Isavuconazol tiene muchas menos reacciones adversas que el voriconazol. Y esto se lo marqué yo en experiencia propia. La hepatotoxicidad descrita, la verdad es que yo nunca la he visto en mi hospital, en el tórax, cuando implementamos isavuconazol. Y en cuanto a voriconazol, les dejé en verde lo que sí hemos visto. Hepatotoxicidad, alteraciones visuales, toxicidad neurológica. Hemos tenido pacientes que hemos tenido que rotarnos obligatoriamente a isavuconazol porque la hepatopatía no mejora, porque los pacientes hacen delirium intratable, porque los pacientes con patologías neuropsiquiátricas se descompensan y hemos tenido que volver, o en realidad rotarnos a isavuconazol. Lo que no he visto nunca, fotosensibilidad, periostitis y QT prolongado. La hepatopatía, no solamente el isavuconazol tiene bajísimo impacto en la hepatopatía, sino que además es protector cuando yo tengo una hepatopatía secundaria a algún otro triazol. En el estudio de acá, posaconazol en rojito, van las transaminasas al alza y cuando yo cambio a isavuconazol, me caen las transaminasas. O sea, además, confiere cierto grado de mejora de la hepatopatía cuando está asociada a otros triazoles que no es isavuconazol. ¿Qué más? Reacciones cruzadas, interacción con otros fármacos. Esto es importantísimo para ustedes como intensivistas. Interacciona prácticamente con todo el voriconazol, ¿no? Fentanilo, midazolam, metadona, antiinflamatorios, corticoides, inmunosupresión, quimioterapia de los pacientes hematológicos, tenemos altísimo grado de interacción. Y este grado de interacción, lo que me importa a mí como infectólogo, es que además me va a alterar mis niveles plasmáticos de voriconazol. ¿Por qué? Porque el voriconazol requiere al menos de 3 citocromos en lo que está trabajando y es un inhibidor potente además de estos. No así el isavuconazol, que trabaja en un solo citocromo y tiene una inhibición moderada. ¿Tiene interacciones? Por supuesto que sí, pero son mucho más evidentes en el voriconazol, donde los niveles plasmáticos nos cuestan un montón de conseguirlo. Y en mi experiencia con trasplantados de órganos sólidos, tacrolimus, everolimus, se comportan absolutamente erráticos cuando tengo tratamiento conjunto con voriconazol. Farmacocinética es lineal, lo que les decía al principio, del isavuco, así que podemos perfectamente esperar un comportamiento lineal sin necesidad de niveles, no así el voriconazol, donde además hay polimorfismos intrapacientes, o sea, el chileno, 1,65 m, blanco, delgado como yo, no se va a comportar a otro tipo igual que yo, porque pueden haber polimorfismos entre las mismas tipos de pacientes. Así que el nivel es obligatorio. Ya, pero doctor, es muy caro el isavuconazol comparado con el bórico. Hay estudios de costo-efectividad, que dicen que yo me puedo ahorrar $7.400 porque el voriconazol, primero, puede tener más RAM, va a darme más días de cama, e incluso hay asociación mayor con mortalidad. Entonces, ¿qué pasa con el isavuco en los pacientes que están graves en UPC con altos volúmenes de distribución? Este trabajo nos indica que en los pacientes graves, 40 y tantos pacientes, todos con IFI, estos son todos aspergilares, hay hasta un 20% de los casos en los que no alcanzo concentraciones mínimas. Lo bueno es que tampoco alcanzo concentraciones máximas tóxicas, o sea, tiene buen perfil de seguridad, pero hay un margen de pacientes que no logran las concentraciones mínimas. ¿Cuáles? Este trabajo dice que está principalmente asociado con índices de masa corporal sobre 25 y los más graves, SOFA mayor a 12. Entonces, ¿qué pasa con los ECMO? Si en los pacientes graves se nos distribuye y a veces no llegamos a los niveles. Este estudio es bonito porque comparó la dosificación habitual que les mencioné versus dosificaciones más altas. Y en ambos grupos, este es un grupo con terapia de reemplazo, grupo sin terapia de reemplazo, y acá entre estos dos están mezclados los ECMO, y no está muy claro, para hay un ECMO en cada grupo. La gracia que tiene este trabajo es que dejaron cargas de por lo menos 800 miligramos día por 3 días y no 600 por 2. Y dejaron mantención de 400 al día y no 200 al día. Y lograron, en este caso, concentraciones mínimas dentro de lo que buscamos, sobre 2, ¿no? Y nunca tóxicas, que es lo otro importante. En cambio, en la rama con terapia de reemplazo renal, igual hay un margen que nos falta. Es un margen mínimo, no supera el 7%, pero aún así esto nos llama la atención. Entonces hay secuestro y el comportamiento del isavuconazol es errático en los pacientes con volumen de distribución alta y necesitamos entonces dosificación más alta. Y esto muestra en estos trabajos. En flecha roja, círculo rojo, dosis habitual. En ECMO no se logra la concentración mínima de 2. Pero cuando duplicamos la dosis en verde, en ambos sí se logra la concentración mínima mayor que 2. Por lo tanto, la dosis doble parece que es lo que necesitamos, ¿no? Trabajos que no muestran lo mismo. Fracasamos con bórico, fracasamos con isavuco en dosis habituales, duplicamos la dosis y por fin tenemos concentraciones mínimas dentro de lo que esperamos. Otro trabajo, este bonito en realidad lo puse porque es nuevo del 2025, 5 perfiles de paciente, pero creo que se fijan en el 5, claro, porque este paciente tiene un IMC sobre 36. Se utilizaron dosis estándar. Estos son pacientes todos con IFI por aspergillus graves en UPC, y todos con ECMO además. Y si se fijan, la curva, el steady state, no supera la concentración mínima de 2. Por lo tanto, también nos hablan. Necesitamos entonces dosis máximas o dosis mayores en los pacientes que están con ECMO o que están graves en UPC. Otros fármacos, voriconazol, este es más conocido por ustedes, es bien lipofílico, también tiene alto unión a proteínas, por lo tanto esperamos que se secuestre moderado a alto. Ahora la gracia es que el espectro no cubre mucor, a diferencia de el isavuconazol. Trabajos en ECMO, donde estamos tomando niveles post 4 tipos diferentes de ECMO, y en estos casos mostramos que hay un secuestro del sistema que es mayor al 75%. Otros trabajos de lo mismo. Empezamos a dar dosificación, que son 4 miligramos por kilo de voriconazol, ¿cierto? Nuestra dosis de mantención, y fuimos tomando niveles. Y vemos que Con dosis altísimas, 11 miligramos por kilo dosis, recién alcanzamos niveles terapéuticos. Por lo tanto, voriconazol parece que también necesita dosis más alta. Y este es el trabajo en el que se basa el artículo, donde es un estudio ex vivo. Toman sangre, la hacen ciclar por un ECMO, y en el otro circuito sin ECMO, y toman niveles en diferentes puntos. ¿Qué concluyen ellos? Que los niveles de voriconazol en pacientes con ECMO y sin ECMO se comportan igual, pero este es un trabajo ex vivo, por eso genera las dudas, ¿no? Fluconazol, pocas palabras del fluconazol, el espectro solamente para las levaduras, es muy hidrofílico, tiene baja unión a proteínas, por lo tanto se espera que no se secuestre en el ECMO, pero es muy lábil a los altos volúmenes de distribución, por lo tanto es necesario aumentar las dosis. Equinocandinas, ánido fungina, lipofílico, alta unión a proteínas, el secuestro esperado es alto, ¿no? El espectro de acción, levaduras no criptococo y tiene cierta acción fungiestática en los aspergillus, en ciertos aspergillus, no alterrius. Y este artículo, el que les mencioné, dice con solamente un trabajo que el comportamiento es lineal con ECMO y sin ECMO, y ellos dicen, deja dosis habituales. Eso nos genera dudas, ¿no? Otra equinocandina, caspofungina, mucho más hidrofílica, alta en una proteínas, pero se espera un secuestro mucho menor, porque no es lipofílica, ¿no? El espectro es el mismo de las equinocandinas y los trabajos son todos más o menos similares a este. Fuimos tomando niveles en distintos puntos y lo comparamos con los valores de referencia. No hubo alteración. Por lo tanto, parece adecuado y correcto que mantengamos dosis habituales en el paciente con y sin ECMO. Polienos, anfotericinas, anfotericina liposomal. Su nombre lo dice, ¿no? Altamente lipofílica, alta unión a proteínas además. Por lo tanto, el secuestro que yo espero de mi circuito de ECMO es altísimo. El espectro es amplio, levaduras, por supuesto, todo tipo de levaduras, todo tipo de filamentosos, excepto el terrius, que nosotros, gracias a Dios, no tenemos tanto. Y los trabajos son más o menos como este, todos los que mencioné en el artículo, donde utilizamos y medimos, en este caso, concentraciones máximas con 10 miligramos por kilo en ECMO y 5 miligramos por kilo sin ECMO. Y el comportamiento de la Cmax fue similar. O sea, claramente tenemos que duplicar la dosis en ECMO para poder alcanzar las Cmax que se alcanzan en un paciente sin ECMO. Otro de estos son los trabajos, los artículos, del artículo que recomienda las dosis. Un solo paciente en ECMO que ocupamos 4 miligramos por kilo de mantención y por supuesto que no se alcanzaron las concentraciones máximas. Ahora, ellos haciéndose cargo de los trabajos previos dicen, no será el material de mis cánulas, antiguamente era silicona, ahora son poliméricos, así que probablemente también tiene un rol, ¿no? Deoxicolato. La deoxicolato es lipofílica pero muy débil, con una alta unión de proteínas, por lo tanto el secuestro esperado en ECMO es bajo a moderado. El espectro es el mismo de la liposomal, de hecho los estudios hablan de que se pueden utilizar indistintamente, pero nosotros sabemos que la liposomal tiene mucha mejor llegada a las infecciones pulmonares y por eso la preferimos. Los estudios son como este, donde te miden niveles en distintos puntos del paciente, pero aquí miden después del oxigenador y encontramos que las concentraciones son las mismas. O sea, deoxicolato lo podemos utilizar en las mismas dosis. Entonces, después de todo este speech, ¿qué es lo que nosotros hacemos en la práctica clínica en el Hospital del Tórax? Aquí, insisto, los colegas norteamericanos nos pueden destruir si quieren. ¿Qué hacemos? Primero, cuando nos enfrentamos a un paciente con una ifia espergilar, paciente no grave, sin shock, utilizamos monoterapia. Puede ser voriconazol, pero en dosis altas. Nosotros nunca utilizamos los 6 miligramos por kilo que dice este artículo. Utilizamos 6 a 8, un poquito pasado. Y de mantención tampoco ocupamos los 4, un poquito más, 4 a 6. Y aún así nos quedamos muchas veces con los niveles plasmáticos cortos. Obviamente necesito, si ustedes van a implementar bori con un ECMO, necesito niveles plasmáticos seriados. No saco nada con dejar. Esto recuerden que no es lineal. Por lo tanto, si no tengo acceso a niveles plasmáticos, no puedo utilizar voriconazol porque muy probablemente te va a ir mal y recuerden que la mortalidad es altísima. Por el contrario, isavuconazol, en dosis altas, tiene perfil lineal, es más seguro, tiene evidencia, nosotros lo preferimos, ¿no? Dosis alta que nosotros ocupamos en cargas, pero no de 2 días 600 miligramos, ocupamos 3 días 600 miligramos, y el artículo dice que se pueden ocupar hasta 800. En nuestra realidad no lo hemos ocupado nunca en 800, pero está descrito, ¿no? Dosis altas. Y la mantención, el doble, no 200, sino que 400 al día, sobre todo si mi paciente además está con terapia de reemplazo renal. Cuando hablamos y cuando tengo el paciente grave, en shock, en ese caso no podemos apostar. Así que iniciamos un triazol, el que ustedes quieran, el que ustedes decidan, nosotros elegimos isavuconazol, y lo asociamos siempre. La evidencia te dice, asocia un triazol a una equinocandina, pero como nosotros la equinocandina la miramos de reojo porque hay un solo estudio que lo valida, preferimos muchas veces ocupar la anfotericina liposomal en dosis estándar a altas, 5 a 10. Y si no, caspofungina, que es una maravilla, pero que yo no la tengo disponible, por eso no la ocupo. Y anidolafungina, y en esta dosis alta que les digo yo, que lo que hacemos es una carga mayor. La dosis de anidolafungina es 200 miligramos día 1 y después 100 de mantención. 200-100, como dice el meme chileno por ahí. Lo que nosotros hacemos es que dejamos la carga de 200 por al menos 3 a 5 días y después dejamos la mantención. Si es que el paciente anda estable, por supuesto. En el caso de la mucormicosis, tampoco podemos apostar. Anfotericina, dosis estándar a altas, siempre asociado a un triazol, y nosotros preferimos el isavuconazol. En el caso de las IFI por cándidas, con o sin fungemia, porque a veces puedo detectar la fungemia con mis medidas diagnósticas, pero otras veces solamente estoy tratando un shock séptico sin patógeno con un cándida score elevado. Ambas situaciones las manejamos iguales. Si el paciente no tiene shock, como les dije, caspofungina, excelente fármaco, no dispongo siempre de él, así que no es mi primera alternativa. Pero si tengo anidolafungina, que lo ocupo, como les acabo de mencionar, en dosis de carga extendida. Off-label absoluto, pero lo utilizamos así. Y si no, podemos utilizar anfotericina, deoxicolato o liposomal. Recuerden que el liposomal tiene que ser dosis estándar a alta y que la falla renal aumenta cuando yo ocupo estas dosis. Por lo tanto, sabiendo que la cándida en pulmón tiene muy poco rol, de hecho no tiene rol, nosotros muchas veces optamos por utilizar deoxicolato, con dosis estándar además. Ahora, si el paciente está grave, y esto es off-label también, nosotros no utilizamos monoterapia. Lo que nosotros utilizamos generalmente es terapia asociada. Anfotericina, liposomal en este caso, o deoxicolato, dosis altas, asociado ojalá a una quinocandina, ojalá tenga caspofungina, si no, anidolafungina, y si no, un triazol, en nuestra experiencia, preferimos el isavuconazol. Ahora, insisto, esto es off-label. Hace poco, este año de hecho, en el ESCMID, los europeos, cuando hablaron de infecciones fúngicas en ECMO, ellos dijeron anfotericina como monoterapia. De hecho, hubo una pregunta, ¿cómo trato la candidemia, doctor, en ECMO? Ellos dijeron anfotericina en monoterapia. Y perfecto, el artículo también te lo dice así. Pero en nuestra experiencia, con las mortalidades que tenemos, con los fármacos no originales, para no decir otra cosa, nosotros siempre preferimos asociar hasta que no exista una evidencia que soporte nuestro uso como monoterapia de estos fármacos. Ahora, esta foto es real y es la misma paciente que vieron acostada todo el rato. Esto es de la foto del miércoles, este es un paciente de este mes. Este paciente, esa fiebre que tuvo, fue una fiebre sin foco, fiebre sin patógeno, dejamos solamente meropenem, nada antifúngico, sino que estaba choqueada, pero cándida score bajo. ¿Qué hicimos? 3 a 5 días le dejaron, ni me acuerdo, como 4 días parece que le dejamos de meropenem. Paciente bien, impecable, en condiciones de alta. Eso, gracias.
Gracias, doctor Matus, por la excelente presentación. ¿Hay alguna pregunta del público para el doctor Matus? Si no hay pregunta del público, pueden pasar a disfrutar del box lunch afuera. Está en el mismo sector donde está la acreditación y nos vemos acá de vuelta a las 2 de la tarde. Bien, los invito a tomar asiento. Vamos a continuar con el módulo de la tarde. Después de toda la jornada matutina que fue más que nada enfocado al paciente pediátrico, continuamos con el módulo de shock cardiogénico y soporte circulatorio mecánico. Ya tengo el agrado de presentar al doctor Juan Contreras. Él es cirujano cardíaco tanto de adultos como niños. Es jefe de la UCI cardiovascular del Hospital Regional de Temuco y fue fellow en el Sick Children del Hospital de Toronto en Canadá. Así que les pido un fuerte aplauso para presentar al doctor Contreras.
Primero que todo, agradecer a la organización por regalarnos esta oportunidad de tener tremendos speakers y aprender mucho de ECMO y falla cardíaca y trasplante. Vamos a hacer el módulo de shock cardiogénico y soporte circulatorio y para esto nuestra primera speaker será doctora Brooke Riley de Alfred Health Australia y ella hablará ECPR, estado del arte.
All right, we'll get underway. So just a little bit of background about the Alfred and Victoria, Australia itself. We're one of the smallest states in Australia by landmass, but the population of Victoria is about 7 million people. And Melbourne itself, which is where we work, is 5.5 million people. The Alfred Hospital, we have 700 beds. We're a 68-bed ICU. And we see probably 3,800 patients a year through our ICU. We're the biggest ICU in Australia with the largest ECMO service, heart and lung transplant services, burns and trauma. But we're also the state service for hyperbaric medicine, HIV, pulmonary hypertension, bone marrow transplant, CAR T therapy as well. We work within a coordinated state-based ECMO service called VECMOS, which you will probably hear through some of the other Alfred speakers as the symposium goes on. And within that service, we're the comprehensive site. We do just over 100 ECMO runs a year, and probably 30 to 40 of those are ECPR. And we run a single caregiver model. So our nursing staff are sort of trained ECMO specialists at the bedside, and we probably have 250 trained specialists with a in-house ECMO accredited intensivist 24 hours a day, 7 days a week. We're the only platinum level ELSO Centre of Excellence in Australia, and we run an ELSO endorsed ECMO course. So let's go on to talk about ECPR. In the US alone, there's more than 6 million cardiac arrests a year. 2/3 of those are out-of-hospital cardiac arrests, where the survival to hospital discharge is less than 10%. We know that prolonged resuscitation efforts are associated with increased mortality, and we're all striving for survival with favourable neurological outcomes. But once we get to 30 minutes, the survival is less than 5%. The chain of survival is key to improving our outcomes, but in refractory cardiac arrest, where people are in arrest for more than 20 minutes, the survivors are elusive, despite all of the links in the chain being present. So what do? We add VA ECMO to it, where conventional cardiopulmonary resuscitation has been unsuccessful in achieving ROSC, and we're aiming to try and restore coronary perfusion, cerebral perfusion, organ perfusion to try and prevent that irreversible brain damage and organ damage to try and help improve our outcomes. And it allows us time for the causes to be addressed. But the outcomes for ECPR are really influenced from the time of commencement of CPR to the establishment of ECMO flow. And we're hoping for this to be less than 30 minutes, although probably our best survivors are in, less than 60 minutes, but probably our best survivors are in the less than 30-minute time frame. And we know that for out-of-hospital cardiac arrest, there's some factors that make this really challenging. But for in-hospital cardiac arrest, there's some systems in place to try and limit the delays to the chain of survival, to try and improve the outcomes. And that's probably what we see reflected as well. From the ELSO data, we know that the numbers of ECPR cases are increasing. In 2009, there was less than 100 cases reported. To date, there's 22,000 reported. So it's a big difference over that time.
Over the past 3 years in the Victorian ECMO service, we've done 177 cases of ECPR with about 41% survival rate. And over the long period of time of the ELSO database, it's sitting at around 31% survival. So what do we know from the evidence? We know that in the ARREST trial, there was a sort of single-centre trial. They had quite a short time to transport, but they had great outcomes. From the Prague trial, we know that, again, single-centre, but included all rhythms, including asystole. It didn't show a statistical significance of neurological improvement, but there was probably still some difference in whether it was conventional CPR or eCPR in terms of the rates of survival. Then, finally, in SEPTION, we know that there was no statistical significance in the terms of favourable neurological survival when they had a low flow time of around 74 minutes. But quite a mixed bunch of centres in terms of high volume and low volume. So really what we know is that there's quite a few factors that are external to just this that drive the outcomes for our patients. And that is that it's a really complex system. And so we learn a lot from these trials. We learn how patients access eCPR. We learn that it's important how we select the patients for eCPR. And it's important how we train for eCPR too. It's not a replacement for good quality CPR. It's just a tool for refractory cardiac arrest. We then look at the guidelines. What do the guidelines say? So it says that eCPR can be considered as a rescue therapy for both out-of-hospital cardiac arrest and in-hospital cardiac arrest. Let's think about in-hospital cardiac arrest for a while. In-hospital cardiac arrest has a survival probably around 40 to 45%. And it's probably due to the shorter low flow times. They're often witnessed arrest. They have trained bystander CPR. The etiology is often clear of why they've arrested. We know underlying disease of these patients. But a lot of the research is skewed to be out-of-hospital cardiac arrest research. But in a hospital system that's structured, we really have the ability that is to reduce those low flow times. So one of the big things that does that is rapid response systems. And so rapid response systems are used worldwide to try and identify and manage deteriorating patients on the ward. And their implementation has really been associated with reduction in in-hospital cardiac arrest and all-cause mortality because of that. Australia has a very widespread use of rapid response systems, and they're usually staffed by the intensive care. And although in-hospital cardiac arrests have decreased in numbers, there's still about 3,000 in-hospital cardiac arrests per year in Australia. And so extrapolating from the data that we do know, how can we improve, and what have we done locally at our service as well? So we know that eCPR programs are complex, they're resource intensive, they require hours of training and considered implementation, but patient selection is really key to achieving good outcomes. This outlines our general inclusion criteria. We use it for both in-hospital and out-of-hospital cardiac arrest. And there will be some variation for in-hospital cardiac arrests that occur in the coronary angiogram suites. But what we have found is that with our local data, looking at out-of-hospital cardiac arrest, it's strongly associated with fulfilling this criteria. You can see that with all criteria met, the survival is sitting around the 46% mark. Whereas if you start to just lose one of those criteria, the survival drastically drops down to 12%. So the compliance to a selection process is really crucial. But we understand that there may be circumstances where you push the barrier for a particular reason, or that the information becomes more apparent down the line. The next thing is that high-performing teams succeed when everyone knows their role, tasks are clearly tracked, and there's micro-teams that collaborate effectively under strong leadership. With this system, we use role cards quite heavily, and they become like team playing cards. Everyone knows what their role is in the game, and they know how to pass the ball to the other person. And these are our role cards that we use for eCPR. The next thing is that you need to train as you would fight. And so we need to train in realistic conditions. We need to adapt from what we learn within those training scenarios to be able to deliver safe care and consistent practices. It should mirror the real world as closely as possible so that we almost build muscle memory and reflexes as a team so that when the real situation happens, it becomes much more responsive. Workflows might need to be optimised. So this is our eCPR equipment trolley. It's had several iterations over the year, but it's been modified through feedback from real cases and simulation. It's designed with human factors principles in mind so that it's intuitive. It flows from top to bottom, left to right, in an order that makes sense to everybody. It has everything that you need in it. You shouldn't need anything that is not in the trolley. And it's clearly labelled and has cognitive aids with it that when you're in a high-stress environment, you don't need to be thinking about what needs to be done. The equipment can be wheeled to whichever location in the hospital we plan to put someone on ECMO. All right, so then we look at the out-of-hospital cardiac arrest and have a little think about that and where things have changed and what's coming up. So if we look at the probability of survival graphs, we've probably all seen these over time. VFVT at 10 minutes, we probably have 70% survival. At 20 minutes, it drops to 37%. At 30 minutes, dropping to 12%, and at 40 minutes, less than 5%. So what's the perfect scenario? The perfect scenario is that someone would have a witnessed arrest in front of someone who can perform ALS and has an AED. But that doesn't often happen at all. We know that AEDs have really good outcomes for many patients in that less than sort of 10-minute category. That paramedics then arrive and they still have some good outcomes in that early stage. But once the patient's arriving to the emergency department, we really are in the survival rates of less than 10%. And the chance of neurologically intact survival after that time are rapidly diminishing. So ideally, what we'd want to happen is that the patients get to the emergency department at about 30 minutes. And there's many systems in place now that transport patients for consideration of eCPR in the emergency department, or scoop and run, or whatever we would call it. But for us, that system doesn't quite work. And so from the Melbourne data, what we know is that our response time for emergency services activation to the first paramedic on scene is about 8 minutes. The time that the paramedics then spend on scene is 40 minutes. 20 minutes of that is active resuscitation, and another 20 minutes is extrication from the scene with mechanical CPR in place. It then takes about 15 minutes to load the patient into the ambulance and to transport them into hospital. And so we're now at 63 minutes before the average eCPR case can even be considered. But we're saying that we need to be considering eCPR at 45 minutes, maximum 60 minutes. And so it doesn't really add up. So then you're going to say to me, why don't you just package the patient up sooner and transport them to hospital? Because they'd then get to us sooner. But the argument is that Ambulance Victoria, which is our paramedic service within the state of Victoria and Australia, has survival for out-of-hospital cardiac arrest with standard ALS that's world-leading. And so if we don't have a broken system in this sense, we shouldn't try to fix it if we're already sitting here. So then if they can't come to us sooner, can we go to them sooner? And so by moving ECMO clinicians to the community, we could potentially reduce the low flow times and hopefully improve neurological survival. And so in 2020, that's really when the Tier 3 feasibility trial started, and I'll chat a little bit about what we've done with that. So our pre-hospital ECMO team consists of 2 intensivists with ECMO credentialing and a critical care paramedic who has ECMO training. We undertook a lot of simulation training before going live, and it graded from immersive in ICU setting, to on the floor, to external environments. We allowed the intensivists who were going to be participating in the trial, who had no pre-hospital experience, to do ride-alongs with the paramedics to get some of that exposure. It was pretty simple mannequin training, but also training with the pre-hospital teams that, as intensivists in the hospital, we'd never trained with before. Our team is alerted to all cardiac arrests within Melbourne via a sort of computer dispatch system, and the paramedic often declines most of those dispatches. We respond to everyone with an age less than 70 who has a witnessed cardiac arrest. Once we get to the scene, we form a full eligibility screen and aim to commence cannulation at around 30 minutes with a maximum time limit for 45 minutes. We instruct the on-scene paramedics to intubate the patient and to apply the mechanical CPR device if they haven't already done so. Very importantly, we have predefined inclusion and exclusion criteria. They're slightly modified from our in-hospital and standard out-of-hospital criteria, but these have been reviewed and refined over time. And so you can see on the right-hand side our roll cards, which it keeps it pretty simple, of age less than 65, witnessed arrest, someone started immediate CPR, and it's less than 45 minutes from the time of the call. That it's a VF, VT, or a PEA arrest, and hopefully there's no signs of sort of chronic end organ dysfunction, like an AV fistula or something else. Our cannulator 1 is the lead clinician who performs the procedure. Cannulator 2 sets up the equipment and helps, and the ECMO support paramedic sets up our ultrasound, checks the equipment, and is our console operator. But they also liaise with the crew on the scene. Once the patient's on ECMO, somewhere between 7 to 12 minutes, we will transport them back to the hospital. But all this training that we've gone through has really meant that in the 34 cases that we've done, we've only had one failed cannulation. So if we have a look at the data from February of 2020 to 2025, we initially started as a 2-day-a-week service, and then we had a lot of shutdown due to COVID. But we now run a 4-day-a-week service. And over that time, we've been alerted to 2,671 cardiac arrests. A large proportion of those are excluded because they're not actually in cardiac arrest when ambulance arrive on scene. And then further excluded mostly because of age or due to not actually, or that it's an unwitnessed arrest. So it brought us down to, in that period of time, about 28 patients that went on to support, one of which was unable to be cannulated and 2 that were unable to be transported to hospital as they died prior to that. So this map just shows an outline of the eCPR centres in Melbourne and the location of our 34 cases to date. Looking at the data that we have, our average age of patient is 51, the majority of them are male. Our response time from time of 000 call to arrival is 31 minutes. And previously that was 64 minutes of when the patient was getting to hospital. Our time to support is 55 minutes, and it was previously 82 minutes when the patient needed to come to hospital. Although it's a feasibility study, we do still track mortality, which is sitting at around 26%, but all of the survivors are neurologically intact, and most have gone back to work and to their daily lives with their kids and everybody else. We have, importantly as well, had 3 of our patients that have gone on to be organ donors, that would not have been possible if this service wasn't in place either. So let's look to the future. We have a therapy that we believe could provide benefit to some people. It may improve outcomes, but it needs to be a really well-selected population. And so what actually is the number of salvageable patients that there are? The denominator is really low. But this treatment is really heavily resource intensive, it's quite time critical, and it needs to be accessible by everybody. And so how do we balance all of those things? In the last few slides, I'm just going to put to you some ideas and areas that we're beginning to see some innovation. So our neurological outcomes are linked to low flow times. How can we try and address that? Well, we need to consider what's on the market. There's wearable devices. Are they able to pick up more rhythms outside AF? Are they able to alert to the time of arrest? And if people are alerted to the time of arrest, what can be done about that outside of education about the chain of survival and CPR? In Australia, we use often is used the Good Sam app to alert sort of willing and trained bystanders to respond to assist with CPR and defibrillation. But what about drone-based delivery systems, delivering mechanical CPR devices, delivering defibs to people? But then we need to look at what actually is the model of our eCPR service. Is it a hospital-based service where we work with the paramedics, or is it a pre-hospital-based service where the primary responders are actually the people who are instituting this therapy? Is it a retrieval-based service? Do we do this via road, fixed wing, rotary? Is it drones? What are we going to see in the future? We've already seen some studies showing that there are automated cannulation devices that can needle and wire vessels. And so how could this advance in the future? Would it be that this could actually be delivered to patients to begin the process to try and reduce those times? We know that equity can be a problem, and it is a problem. There's regional disparities in eCPR access, and it requires inter-hospital coordination to try and improve the reach of this, looking at hub and spoke models. But then I guess we argue what then happens with volume of practice and your credentialing. We need to know when these services are available. Is it only during business hours? Is it not on the weekends? How do we build on that, and how do we make it open to people? And how do we balance the resource demands that we know that come with eCPR to try and balance that with the moral burden that is also there as well? And is this all cost effective for us? Looking at the technology that's changing, there's smaller mobile devices, there's robotic devices coming out. What about neurological protection? Do we need to look again at early rapid cooling to try to provide some protection to the brain? Are there other co-therapies that could try and help that? And really, the other thing is, we need to look back and learn from what we've already had, and that may involve machine learning and prediction models as well. But just a little bit of food for thought for you. Thank you.
Thank you very much, Dr. Brock. Nuestro siguiente speaker es el doctor Ata Befa. Él es miembro de Mayo Roster Clinic en Estados Unidos y nos va a hablar sobre la actualizaciones sobre ECMO en shock cardiogénico y cómo ventilar a los pacientes.
Hola. Estoy muy feliz de estar aquí con ustedes. But I'm going to speak English now. I was very happy to see that there's such a diversity of talent in the audience, and this talk will be really a review of, at least in the United States, how we try to approach cardiogenic shock. And in that light, you'll see several technologies that pair really beautifully with ECMO as venting strategies. Intermixed in here will be a lot of physiology. So, sorry about that. These are my disclosures. So what we're going to do is really look at hemodynamics in the setting of ECMO. So we'll look at these technologies as venting strategies, but we'll also look at them as standalone mechanical support tools and really explore how each of these influence both the right and the left side of the heart. So as we've heard this morning, someone comes in cardiogenic shock or in a code, and you have a potpourri of devices and tools and different stakeholders. You have the intensivists, you have the interventionalists, you have the surgeons all sort of wanting to manage these patients differently. And I think at Mayo, and you heard from our pediatric colleagues this earlier, we've really, I think over time, have developed a team-based approach to try to get these patients into the right direction. So just as a review, let's look at what goes wrong with the heart from a physiological perspective. So if you guys remember your physiology classes, you'll remember this pressure-volume loop, right? Volume's on the bottom, pressure's on top. This is a product of how well the heart contracts. The steeper it is, the more contraction. The flatter, less contraction. This is preload here, and this is afterload, which means the pressure the heart has to pump against. So what happens in heart failure? Well, in heart failure, the heart has to get big. Well, you think, oh, well, there's so much more volume, but actually the contractility is lost, right? So the heart gets big to compensate for a lack of contractility in order for the patient to stay alive. So stroke volume gets shifted over to the left, and this is why you saw those chest x-rays where there's fluid everywhere. It's because the heart is full like a balloon, right? Like a filled balloon that's about to explode. Everything we're doing is trying to compensate for this behavior by the heart. So typically this is just regular heart failure that we manage on the floor or in the ICU with medicines. And typically with medicines, all we do is give some inotropes, restore the contractility, stroke volume is bigger, the patient pees, they feel better, we send them out, and they live their lives. But in severe settings, this doesn't work anymore, right? This is lost. And so now we're contemplating something, let's say, VA ECMO. The trouble with VA ECMO is that it is the worst thing for heart failure because you're dramatically increasing afterload, right? You have a brand new arterial flow device, and you're actually dropping preload. You're sucking venous blood away from the heart. And so what happens is preload comes in, afterload goes up, you barely have any stroke volume now, and you go into pulmonary edema. Right? That's why the heart can't tolerate VA ECMO when it's in failure. So you got to come up with a way to fix this, right? And in some cases, you know, we sit there in the ICU looking at the arterial tracing, and we're like, oh, there's pulsatility. It means the heart's still ejecting a little. It's somehow fighting against the ECMO. Maybe it has life in it. Let's try inotropes, right? Try to push contractility and see if that's enough for there to be forward flow and avoid pulmonary edema. That's the cheapest, easiest, least difficult, least pathologic, approach to take. Doesn't work very often, but at least it's there. Next is actually our forgotten friend, the intra-aortic balloon pump. What does intra-aortic balloon pump do? It drops afterload. It counterpulses against the heart in diastole. It pushes blood away during diastole, right? So when the heart is ready to push again, there's less blood to push against. Afterload is dropped. If you drop afterload, you increase stroke volume, and it helps with forward flow. The institution to the north of Mayo Clinic, the University of Minnesota, almost exclusively uses balloon pumps to vent their patients. They have a giant ECMO practice, so don't discount this. Very cheap, 8-9 French sheath, very doable. Just to double click on this, let's look at a patient. So this is a guy that I did a procedure on a couple of years ago now. This is a pre-transplant patient. And we have certain listing criteria. So if a patient meets a certain threshold of sickness, in the cath lab, we can put them on mechanical support. The easiest, cheapest mechanical support is balloon pump, right? So they get status 2 with that. And so when we saw that, you know, their wedge pressure is already 20, their cardiac index is only 1.6, their aortic pressure was less than 90, we knew that they would meet status 2 criteria. I could put a balloon pump in. You don't want these people laying flat in bed, and I don't want to cut down under their clavicle to put this balloon pump in. So we came up with this percutaneous approach where we use the third portion of the axillary artery in the left arm, put it in. Remember, this artery spares the carotid on this side, so there's less stroke risk. And we've done around 200 patients using this technique now. It looks like that. The patients get bandaged up like this. And we have a whole x-ray routine to follow them, make sure the balloon doesn't migrate. Is it great? No. But is it good enough? Absolutely, right? Cardiac index improves by enough to keep most of these people walking around the ICU while they're waiting for transplant. So in the sick enough for transplant, but not sick enough for something more, this is a wonderful option with very low morbidity. Unfortunately, we still have complications. So if we're going to put this patient or these types of people on support, we really need to get them transplanted in the first 20, 30 days. Otherwise, you start running into complications. Often, we have to either put them on Impella or put them on ECMO, but we do have more severe complications with this approach. For the patient I told you about, remember I said balloon pumps drop afterload? Well, he went to the ICU, and they decided to drop afterload even more, and he coded. And so Mauricio isn't here yet, right? So Dr. Villavicencio and I actually ended up putting this guy on ECMO. You can see the VA ECMO cannula, but you still see the balloon pump here. Just left the balloon pump in. And the guy was sitting in bed right after we put this in, like, hey, what's going on? Like, doing great. 5 days later, we transplanted him. Another thing that we often have in our practice is a STEMI presentation, whether it's out of hospital arrest or they come in and they're in acute cardiogenic shock from a STEMI. And often these people, as we're starting to intervene and trying to open, in this case, the LAD, we start seeing, you can even see it on fluoroscopy, that this patient went into heart block, and then he's not squeezing anymore, right? It was actually a sheet. So now you see a wire in the LV. That's because we're getting ready to put an Impella CP in. That's done through the femoral artery. And by the time we have the CP in, the patient is in fib, right? Or in an unorganized ventricular rhythm there. And so we ended up having to now put this patient on ECMO, VA ECMO. And so this is the ECPella approach. We also do 5-5 for these patients. That's a surgical cut down under typically the right clavicle, and those patients are supported. So for venting, these are the 3 approaches that can be used. Just regular inotropes, rare, balloon pump, afterload reduction, or Impella, where we just suck the blood right out of the heart. Right? There are things to know about Impella that are important. I think first thing is familiarity with the console is very important. The console will tell you position. It'll also give you flow and speed. So in this case, the device is out of the left ventricle. It's very dangerous. In this one, the whole thing is in the ventricle. And ideally, you should have the red signal arterial and the gray signal being the other. In order to study this, we create porcine models of acute myocardial infarction, and then put, this is, we use a 26 French sheath to put the Impella 5.5 directly into the aorta. We have 2 pressure volume loop catheters in, and this is essentially the model that we have. And what we see in this model is actually, this is baseline before we cause a heart attack. Obviously, the heart tolerates really well Impella flows. We can ramp them up quite easily. But in the setting of infarct, the RV becomes quite dependent on the LV, and the septal infarcts actually influence RV function. So you can't fill the left ventricle adequately. And so by P7, which is not full speed, you get LV suck down. Doesn't work anymore. And so what we'll talk about a little bit tomorrow is some of the new ways that we're working with Johnson & Johnson to change this device to get them to work. The RV, as it turns out, is one of the biggest problems in a sick left ventricle if you want good mechanical support. And in the LVAD setting, this is actually something we really perseverate over. These criteria like PAPI and other criteria where we're looking to make sure the RV can keep up. I don't know if Matt reads in the audience or not, but this is a patient I shared with him just a couple of days ago. This is a patient, LVAD patient, we admitted to his unit who just was sick and not doing well. And what we found out when we went in and did a left and right heart cath was that this is the gray is LV pressure, the green is pulmonary artery pressure, and this is aortic pressure. The LV was essentially being suctioned by the left ventricular assist device. So we ended up putting an RVAD in this patient. So gray, RV is green, and gray is LV. We ended up switching our gauges here, so sorry about that. Green ends up being RA, blue is RV, and gray is still LV. But by P7, you can see now that the LV is fully loaded and is now performing well. And so this is sort of the setup that the patient, this is just a chest x-ray from the unit I grabbed. But so this is a HeartMate 3 device. Here's the Impella RP Flex. And so this patient needed essentially bi-V support to get out of the woods. We actually did PV loop studies on this patient while we were ramping him, just for funsies. And so you can see here that the blue line is essentially no filling of the left ventricle. And as we get to the brown circle here, you can see the stroke volume of the left ventricle is dramatically improved, while the RV, blue being again at no flow on the RVAD, is now being decompressed. So there's almost like a cross, you look at this figure, between what happens to the RV and the LV in terms of support. So what we've realized, and this is a publication we had a little while back, is that although in the left ventricle we're always talking about afterload reduction, in the setting of left ventricular assist devices with the influence and interdependence of the left ventricle and the RV, what you actually get is, yes, you can flow these VADs faster to get afterload reduction, but you dramatically compromise contractility in the right ventricle. And when you compromise the contractility, you essentially get this suck down effect. And if you put a echo, like an intracardiac echo device, so a device that, so these images are directly from the right ventricle looking at the left ventricle, you can see that the septum here is being literally sucked into the cannula itself. And so we have to be very mindful and often have to go into the ventricle to measure these pressures and really understand what is going on with these patients. And so this is a different patient where the same sort of phenomenon was reported in the literature. RV support, as it turns out, is very important. RP Flex is the new Impella device that does that. During COVID, we used a bunch of the Protect Duos for VPA support. It's extremely expensive. Not a fan because of how much it costs. So Jason Anderson and I actually, and this isn't advancing, but if you could advance to the next slide for me. Or just cancel my talk. Well, anyways, so Jason Anderson and I think you showed one of the slides of what he's done on the Fontan. Essentially developed this 2 cannula approach to replace that Protect Duo. Jason ended up using it for the Fontan patients where he evacuates venous blood. Let's see if we can advance. There we go. So this is a 2 cannula system. You saw this used in the Fontan. It creates more of an L shape in the Fontan, whereas in anatomically normal patients, essentially we go up into the PA. It's a RVAD. We ended up leveraging that capability to actually vent the left ventricle by reversing the flow on that PA cannula in something we actually, Suraj made up the name, and he was really a big part of doing both LAVA and PAVA all during COVID, and then we continue to use PAVA now in our practice. But essentially, we have reverse flow of both the PA cannula and the venous cannula, and then just put an arterial cannula in. And what that does is essentially completely eliminate flow into the left heart. It's a great way to vent. It's a lot less morbid because you have one arterial access, and we've tracked these patients out to 40 days in a publication that Sarah Inglis wrote, and they do quite well, and you do get pretty dramatic flows from this type of an approach. So, in summary, remember that there are numerous percutaneous approaches that can be leveraged for mechanical support. I would say even, I think Dr. Villavicencio will talk about this more tomorrow, that our even surgical practice has primarily now gone to a percutaneous approach for mechanical support, even in the setting of transplant, lung or heart transplant. And that these venting approaches are all developed enough where they can be used as standalone devices. And if we rationally design how we do it, we can go from a PAVA approach to an RVAD approach with Impella 5.5 to weaning the RVAD and leaving a patient, let's say, on an Impella 5.5. So there's a lot of nice developments that have occurred over the years. So thank you so much.
Bueno, y para terminar la tercera jornada de la tarde, hablaremos de cuándo y cómo pasar de mecanismos de soporte circulatorio de moderada duración a larga duración. Esta charla será hecha por el doctor Arndale from Alfred Health Care en Australia.
Hola, es maravilloso estar aquí con vosotros en Santiago. Muchas gracias a Rodrigo, Suraj, a Julia, Brooke, and Stefan. This is where about my Spanish ends. But, no, it's not good enough to do the talk, so you don't want to listen to me and speak in Spanish about medical things. Thanks for giving me this difficult topic, when and how to move to an LVAD from mechanical support. I'm sure we could all have long discussions about that and how to go about it. I will do it in a case-based format, and I hope I'll get a little bit of your participation in that. Of no disclosures. In LVAD, for those who don't know, there's an inflow cannula placed in the left ventricle. There's a graft onto the aorta. You're dependent on a functional right ventricle and a competent aortic valve for that to work. And this is the X-ray that you already saw, and you saw some pictures from after before. The inflow cannula here is nicely placed, and then the graft goes onto here and around and onto the aorta. Okay, so here's our first case. This is a 55-year-old male that Brooke rescued with ECPR 10 days ago. He arrested actually in the emergency department. Upon arrival, had a proximal LAD that was stented. He appears neurologically intact, however, he's still intubated. He has acute renal failure and renal replacement therapy and has no other past history. His echo on day 10 looks something like that. So a typical LAD lesion was an anteroseptal wall that's akinetic, the apex is akinetic, and non-LAD territory that still works. And he clearly fails his weaning study. He's still on a lot of vasopressor support, and he doesn't really recruit, as you can imagine, because he only has that bit of wall that works. So where do you go from here? It's day 10. This is fairly simple. When we look at our database, pretty much no one weans after day 10, day 14. Maybe you have a small window. So you need to know what your local context is. Up until recently in Australia, there was no destination therapy within LVAD, so it means that everyone would need to be assessed for heart transplantation, or really it's viewed as a bridge to a heart transplantation. I know that's fundamentally different from our colleagues in the States. Despite that, the destination therapy is now on the cards. It will be limited by funding, so it will essentially remain the same. You may have the occasional patient as a bridge to candidacy. For example, we just a few months ago, we had a young woman in her 20s after an osteosarcoma treatment, and she had anthracycline-related cardiomyopathy. She received an LVAD, but she needs to stay cancer-free for 5 years before she would qualify for heart transplant. So what are the key criteria that we would have? Well, we want multi-organ failure ideally to be resolved. We want to have an idea about the chronic disease burden. Neurologically, there needs to be literally no disability to operate the device. Easy to do a CT scan, contrast scan to exclude any obvious malignancy. Psychosocial assessment, very important. How much support do they have? Call their GP and all of these sorts of things. And then, of course, the consent process. So what does that mean in our men? Well, we have limited time. It's already day 10. We still need to extubate him. We want to be sure that his neurology is okay. And we want to speak to him. So in acute cases, this is a big thing. You're well, you rest, and you walk out of the hospital with a cable out of your chest. All right? So you do want to speak to the family, to the patient, whether that's actually acceptable. And we have increasingly become a little bit more relaxed about the acute renal failure and reasonably confident that that could still be managed later, even though intermittent hemodialysis for a few months on a durable VAD is not ideal due to the fluid shifts. So to put this a little bit in a bigger picture, this is how you could conceptualize the whole process. So you have a patient with a condition that may be acute, may even be uncertain, or a chronic condition, and you have your ultimate outcomes over here that patient weans, they die, may become an organ donor, or you need to bridge them, get them somewhere here to a durable VAD or even a BiVAD, and ultimately heart transplantation. The direct pathway to heart transplantation has been very rare for us. But, so this is really what we're talking about, is this middle bit here, and there's a great deal of uncertainty which ones are the best pathways. So we just had a patient which probably had a favorable diagnosis. The suitability is often more challenging because there's often organ failure, just an outpatient organ failure involved. You need the consent process and all of. You know less about the patient, so that makes it often a lot more challenging to get them somewhere over here. The EV ECMO part is easy. Could we have put an impeller in to get a little bit more time in our patient? That would have been an option, for example. But then, luckily, he went straight to there in 14 days and is on a safe pathway to then hopefully, most of these patients get actually reasonably quickly transplanted later on. And then you have the terminology down here where you say, you know, what kind of bridge it is to a decision or recovery to that or transplant candidacy, and well, hopefully you're not doing it to land nowhere where you don't want to face the reality, and it might be time to say that you don't even want to embark on it. So, case 2. Is it time for a durable LVAD? This is also a patient from just a few weeks ago in the unit. So this man was 62, has a non-ischemic cardiomyopathy, very poor LV function. He actually came from the clinic, so he was clearly a late referral, got admitted in the hospital a couple of weeks, comes to ICU. He's on, 0.25 mics per kilo per minute of milrinone. He was quite a reasonably sizable man. His creatinine was sitting at around 250, that's micromoles per liter for over the last 6 months. But there were no other red flags to sort of get him on the transplant pathway. He was on quite a bit of oxygen and felt sort of cool around the edges. And you can probably see on the x-ray that there was quite a bit of pulmonary edema on that side that we didn't like. When you look at his bloods, well, his lactate was hovering sort of between 2 and 3. His bilirubin had gone up to 60, so that's 3-4 milligrams per deciliter. His creatinine has been fairly static, but also gone up, so his urea, and he was on a furosemide infusion to keep his fluid balance just at bay. So I give you a few moments to think about what you want to do with this patient. Well, you want to increase the inotropes, or you want to put the patient on ECMO, you want to put an impeller in. You convince the surgeon that they should go to theatre in 1 hour and put the durable LVAD in, or you say, well, I don't know enough. I want to see whether he's a transplant candidate at all. All right. Let's do a show of hands. So who wants to wait and increase the inotropes and see whether he has been stable for some weeks? So why not a few more weeks? Anyone? No one. Okay. Who wants to put him on VA ECMO? He has favorable vessels. There are no problems. Anyone? No one. Gosh. Okay. Who wants to put an impeller in? All right, 5, 6 hands, 7, 8, okay. Who wants to put a VAD in directly? Yeah, a few hands as well for that option. Who's going for E? A few hands there as well. I certainly would accelerate that process. Okay, maybe I should ask you again. Of course, we do this in parallel. There were no barriers. He got a CT scan. There was a renal cyst, and he got a contrast scan. Everyone was happy, etc. But yes, he would be a transplant candidate. So Well, we also thought that the impeller in this case would actually have been a good idea, because primarily we thought the main barrier for him to going to theatre was, well, his bilirubin was already quite high. That worried us. Wet lungs don't really go well with direct to LVAD. In our experience, you might run into trouble later ventilating the patient, and it just easily gets a little bit messy. So we thought he would be a good way to support. Unfortunately, there was no surgical availability to put the 5.5 in, and then he gradually became unuric, so we just put him on VA ECMO, and he did very well. His lungs cleared up, and 7 days later he had his VAD in and was extubated the next day and did quite well. All right, so these patients, they're generally, this is a very successful pathway. I think the jury is still out. There are a few papers out there that try to compare that. It's really very early on. What's the best? Surely it's also, there are a lot of system questions around what is better in this situation, and also individual patient, what actually their problem is. Is it more pulmonary edema? This man obviously had a very good pumping right ventricle because there was differential function. That's how he got the pulmonary edema. That's not the case for all of these. It might be more renal failure, where both ventricles are poor. It might be a very different situation. But it's generally a very successful pathway to get these patients, if they're well known and everything is worked up from here to over here. A little bit of background to the HeartMate 3. I think thanks to Matt and others presenting all the devices. So the big change from HeartMate 2 to 3 is really, as you can see, it's mortality. So this trial compared the previous device, which was an axial flow pump, to the centrifugal pump. It improved mortality, but more importantly, what's more relevant for us, really the event rate with strokes and device thrombosis that really significantly went down here in this 5-year follow-up, is 4% versus 11%. And that manifests also clinically that we have become much more confident and also relaxed if there are any bleeding problems to just leave the heparin out and the device just runs and there is generally no problem. Okay, one more case. Case 3. This is a 50-year-old male with a familial dilated cardiomyopathy. He was admitted to ICU, plus some VT on the ward. He was sort of in the assessment phase for an LVAD as a bridge to transplant. And then he got further VT. Also, his cardiac output was quite poor. So he was placed on VA ECMO sort of emergently with terrible cardiac indices. So there was also, given the urgency in our system, not much discussion about an impeller. Also his right ventricle was very borderline. This was his LV, as you can see there. And speaking of the right ventricle, he pretty much had all these risk factors. In each category, he had risk factors, physiological parameters from the echo, from liver enzymes, and he was now on mechanical support. All factors that would suggest that putting an LVAD in, and of course the echo pictures, that his right ventricle might struggle. So he did get his VAD placed a few days later, and as you can see, was a temporary RVAD, and so a nice extracannular multi-stage across the right atrium, and the return is generally grafted by the surgeons onto the pulmonary artery. So although I very much like your percutaneous approach there, but if they come from theatre, that's usually what the surgeons do directly. Unfortunately, we couldn't wean him despite all efforts of his temporary RVAD support. And as you can see, he then received what we call a BIVAT. He actually used the exact same device, the HeartMate 3, and put it on the right side, so it then goes into the right atrium, and the outflow is grafted onto the pulmonary artery. Now, that is a problem, though, because the device is not designed for it at all. You see how the space is really small. The inflow cannula is actually too big. So there needs to be an extra suture ring to make it shorter. And then you suddenly have a relatively heavy device sitting in a thin-walled right atrium that frequently causes this problem. What you see here is sort of intermittent, sort of almost suck-down events, which is not ideal. And then you're running it, you're diverting flow from the right ventricle with potential low flow in the right ventricle, and you're also running lower flows on the RVAD. You can see this was running at 2.8 liters, which is quite low for the device. And you're also filling up the chest with another device, which can be, depending on your size, also be an issue. It doesn't stop there. Then I think, I don't remember how many days later it was, the device showed, the RVAD device showed that there was 7 liters of flow. On the left side, we had 4.5 liters of flow, and you're scratching your head what's going on there. Of course, you want to check with an echo that there's no recirculation on the right side, that you don't have regurgitation through the pulmonary and tricuspid valve. You could potentially have circulation there. Or all of this wasn't the case, but what explains this is actually a nice paper from just May this year, that particularly in these low RPM ranges, there's actually and for the same, measured, so here they measured the actual flow that goes through the device versus the estimate, and the estimate and the ratio is purely based on the current that goes through the device. And you see when you're sitting here, somewhere here, for example, which this patient was sitting, that you have ambiguous actual measured flows to the same current that goes through the device. So it's essentially just a false reading that comes from it. And that is particularly true if you use it on the right side, because there must be some algorithm where it computes more numbers that are more likely on the left side. Another few days later, this happened, and I took the worst photo in the world, because the red bit that you want to see here that has the reflection. But you see the red alarm down here, it showed 0 flow. Absolutely no flow. Of course, we put an echo down, we turned down his LVAD a bit, although it's not, we turned it down later. There was still some flow going into the inflow cannula. We could also, in the pulmonary artery, show the outflow cannula. But clearly there was something wrong. We had a lot of discussion. The patient went to theatre for an explant of his RVAD, and it turned out that it was actually thrombosed in the inflow and probably also had sucked in some clot from the right side from exactly this problem that I was demonstrating to you later. So a BIVAD and a durable RVAD on the right side is not complication-free. So we followed this pathway in this case. We went here we had a temporary RVAD. Then plus a durable LVAD, a durable RVAD, and another durable RVAD. It's getting expensive, you notice that. But hopefully this man also gets a heart transplant. A potential solution to that, and I think someone showed before some total artificial hearts that are out there. This is a trial that we are involved with the Vivacor device, which has inflow from your right atrium into the device, then an outflow onto the pulmonary artery. You don't see the inflow back into the left atrium and out the aorta. It's a clever device because it has sort of a rotor that can shift and switch the loading from the right and left side, pretty much like a septum. But I can't tell you anything about that yet. In summary, I think you definitely you need to start early in your ECMO run to think about if the patient doesn't wean, and think about some other strategy of bridging or whether you can get them to that. In a chronic heart failure patient, ideally you clarify all of this from the start to just bridge them, or you start thinking about it on day one. I think there's still a great deal of uncertainty about the pathways, and I'm sure there will be a lot more literature coming out, and total artificial heart still carries some attraction in those patients with biventricular failure. And this is my excitement to share with you. So we're actually sharing some latitude, and this is Tasmania down here, and it offers equally exciting nature to go hiking. So that's it from me. Thank you.
Muchas gracias a los tres participantes, excelente charla. Con esto comenzamos la serie de preguntas. No sé si alguien tiene alguna pregunta en el auditorium.
Primero agradecer a los colegas que vinieron a presentarnos toda su experiencia. Y mi pregunta va relacionada más a algo más grande o menos clínico, en verdad. Yo estoy muy metida en todo lo que es sostenibilidad en salud y he encontrado muy poco información en relación a cuál es el impacto ambiental que tienen este tipo de prácticas. Entonces quería saber su experiencia. Sé que en Australia tienen harto movimiento en relación a la sostenibilidad en UCI en específico. Y que les quería preguntar si conocen del tema, si han trabajado en eso, cómo van sus países al respecto. Me refiero a sostenibilidad ambiental, por ejemplo, el impacto ambiental del ECMO en relación a la basura, a huella de CO2, etc.
Okay, I'm happy to answer that. I think it's a total disaster. There's nothing on the horizon. I think there would be a lot of other ways where we could start. For example, we have a recycling program in our unit for also other consumables, plastic. We could think about it at least when we buy things that we use, whether they're alternative reusable devices. But no, I think we are way behind.
Just to put it into perspective, though, the incidence of plastic usage for critical care, forget ECMO, just all of medicine compared to human usage of plastics is infinitely smaller. So I think systematically governments and societies working to reduce plastic consumption, oceanic waste versus like worrying about like this tiny microcosm, I think there's a much bigger problem to solve. I think in this context, we're trying to save a life. And so like, I think eventually, as you've seen today, it's not perfect yet. It's far from perfect, and we're losing a lot of people. And so I think first we need to innovate to save lives. And once we've perfected those innovations, I think then we need to systematically figure out how to optimize cost and waste and things like that. But in society, that's a big challenge that should be solved separately.
I think it's a fair question, though, to be honest. It's 20% of the economy is healthcare in the United States, maybe a little bit less in other countries, but it's a fair question, I think. It needs voices like yours. Bring it up.
Mientras tanto, yo quería preguntar, la estrategia preferida para ustedes en un paciente que tiene una descompensación aguda es conectarlo en ECMO y trasplantarlo, o en general prefieren conectarlo a ECMO, poner un sistema de más larga duración, rehabilitarlo y trasplantarlo. ¿Qué prefieren en general en sus centros?
I think it depends on the patient. When he was showing his cases, what we were chatting about is, well, I'd need right heart cath numbers. I need like these additional pieces of information to decide the next step. Sometimes you don't need anything but more milrinone. Sometimes a balloon pump will suffice. Sometimes you can go direct to Impella 5.5. And sometimes you need to go directly to ECMO and then decide how to vent. And you can choose which vent to utilize depending on the clinical scenario. But I think your destination and defining the destination as you go on support, is this patient transplant eligible? Are we thinking LVAD? Is going to be predicated on each region, time to transplant, what are the listing criteria. For example, for us, in the patient you showed, we would probably, the one that had good RV function, we would probably put on an Impella 5.5. If they were listable, we'd list for transplant. But after 3 weeks, we can't justify keeping the Impella and keeping status 2. So they would have to get an LVAD and become status 4 and wait for transplant. So I think each scenario is going to be custom.
Yeah, making a lot of great points. In Australia, you don't ship. You have a device in, so that doesn't work as a strategy. I think you're right. There are lots of other useful information, but it heavily depends as well where you are. We have a very echo-heavy unit, so echo parameters a lot. Of course, we get a right heart catheter. If we think it's useful, we either do it ourselves or often the heart failure patients come with it. Generally come together. For the chronic patients, with the heart transplant consultants that are in our unit, also the heart failure consultants, and you have a discussion together what you think is best for the individual patient. That's why I didn't show you any of the analyses comparing fellows and ECMO bridges, because it is really so individual, and throwing them all together in retrospective analysis will already advise us what devices they preferred. I found this very difficult.
One. That cause less suffering. Another question for. So the Good Time app, I think, was actually developed in an athlete.
fib is nearby, so that you can bring that to somebody and assist. Yeah. Our head of ambulance, our medical lead of Ambulance Victoria seems to be nearby a lot of them all the time.
I think I'll pass the second question to you. Arta, you're the surgeon here.
Well, I do intervention.
Okay.
Anatomically, it doesn't work. The accordion, the RV, and the cocaine goes in the other. So they essentially sacrifice the tricuspid valve. It's not long. It's not big enough.
And it sits anterior. There's also no space really
So
where to put it. So I think sure there are people out there working on other forms of right ventricular. It's a little bit like the pediatric dilemma that you described before. Nice out there.
For like 3 liters, 3.5 liters, RP-Flex is
Bueno, con esta última pregunta cerramos este bloque. Tenemos 15 minutos para un descanso, para un café, y después continuamos con la segunda parte del módulo de shock cardiogénico y dispositivos.
Hey, thanks, mate.
This is fun.
Yeah, this is fun. So you're cardiologist?
Yeah.
Yeah.
I do transplant and I do transplant.
Yeah.
Not only that, like even the local culture, department. Yeah, but remember, complications there are like we said, all comers.
3, 1, 2, 3. 1, 2, 3, sí, aló, sí. Sí, aló, sí. 1, 2, 3, 1, 2, 3. Aló, sí. 1, 2. 1, 2, 3, sí, aló, sí. 1, 2, 1, 2, 1, 2. 1, 2, 3, sí, aló, sí. 1, 2, 3, 3, sí, aló, sí. 1, 2, 3, 3, 3. No le he cambiado señal, no le he cambiado nada, así que sigue igual. ¿Ah? ¿Es la misma señal? ¿O lo cambio de señal? ¿Pero te suena, te escucháis? ¿Se escucha bien ahora? Se corta un poco. 1, 2, 3, 1, 2, 3. Voy a mover un poquito la caja por si de pronto moví la caja. Fuera. 1, 2, 3, sí, aló. 2, 1, 2. Se corta. 3, sí, aló, sí. 1, 2, 3, 3, 3. Ok. Pa. Sí. ¿Se corta o no? Ya. ¿Ah? Ahí me escucháis. Pa. 1, 2, 3, 3, sí. Aló, sí. 1, 2, 3, 3, 3, sí. Pa. ¿Pero qué hacemos? ¿Lo dejamos fuera este entonces? Ya. Ya, está dando... ¿Probemos la Valier? Pa. 1, 2, 3. ¿La Valier? 1, 2, 3, sí, aló, sí. 1, 2, 3, sí, aló, sí. 1, 2, 3, 3, 3, 3, sí, aló. 1, 2, 3, 3, sí, aló, sí. Ni un problema. Ya, todo bien. Pa. 1, 2, 3, sí, aló, sí. 1, 2, 3, 3, 3, sí. Ahí está.
Aló, aló, sí, 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 sí. Sí, 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 sí. Aló, 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 aló. Aló, aló. Aló, aló, aló. Aló, aló. Aló. Sí. Aló, 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 aló. Aló. Sí, sí. 1, 2, 1, 2. Aló, 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 aló.
Bien, buenas tardes. Los invitamos a tomar asiento para continuar con el módulo de shock cardiogénico y soporte circulatorio mecánico. A continuación, el moderador del módulo será el doctor César Paulsen, él es cirujano cardiovascular, parte del equipo de trasplante también del Instituto Nacional del Tórax, que va a presentar las siguientes 4 charlas del módulo para finalizar el día de hoy.
Buenas tardes, ¿se escucha bien? ¿Sí? Tomando asiento, por favor. El próximo speaker del último módulo de la tarde es el doctor Omar El Madoun. Viene de la Clínica Mayo, Rochester, Minnesota. Y el tema a presentar de él es el enfoque del TEP masivo, el enfoque del siglo XXI. Adelante, doctor Omar. Disappear. No. Para la gente de la multimedia hay un cambio. Esta es la última charla. Él parte con la última charla del bloque, por favor. That one.
There you go. All right, we're in business. Hello, everyone. Thank you so much for having me. My name is Omar Al-Madhoun, and today I was given the task to talk to you about how to manage massive PE in the 21st century. So let's get to it. Here's my agenda. I know it looks busy, but I promise we'll get through it. You know, even though PE is an ancient diagnosis, we have decades and decades of research on PE, we still basically have unresolved questions and evidence gaps in almost every aspect of PE management, whether it comes to good old anticoagulation, thrombolytics, percutaneous interventions, ECMO, etc. Of course, this is an ECMO conference, so I'm going to spend more time on ECMO, but I cannot give you the full picture of treating PE in the 21st century without talking about percutaneous interventions. So let's talk about it. So, you know, these catheter-directed interventions are not as new as we think. You know, we started experimenting with the idea back in the 1990s, experimenting using mechanical fragmentation versus local delivery of fluidics to try to minimize systemic side effects. Devices were being developed in the 2000s, and initially we used them for high-risk PE that had contraindication for thrombolytics. However, as we become more familiar with these devices, we start to use them for intermediate high-risk patients as well as those who failed traditional approach. You know, we made a lot of progress in these devices that now they appear in the AHA, American Heart Association 2019 recommendation. And there are many devices, as I will show you in the next slide, but we can simplify it by, again, thinking about it as 2 separate categories. One category going in the PA to try to mechanically suck the clot and take care of the obstruction right away, versus leaving a catheter in the PA to transfuse or to give thrombolytics. There are a lot of literature out there. Keep in mind there's also a lot of industry bias, so we have to take those results with a grain of salt, but we'll see what we have. Again, we have a lot of devices, as you see here. They come in different sizes. There are different RCTs that look into them. But why are we talking about them today in an ECMO conference? Because you're going to see more and more of them in the future. So this is a study that looked at all PE patients in the US from 2018 to 2023, and you see the trend in using these devices. You see a sharp increase in using catheter-based interventions, a sharp increase in catheter-directed mechanical thrombectomy, and going away from systemic thrombolysis, going away even from catheter-directed thrombolysis. So you'll see more of them in your practice, And they work perfectly, especially when you combine them with other strategies that we'll be talking about. So this is your very brief background on these devices. Let's talk about why we're here about ECMO. So, I don't have to bore you with the pathophysiology of PE, but it all revolves around the RV. You have a clot, you have RV dilatation, increased wall tension, ischemic insult, decrease in RV output, decrease in systemic output, obstructive shock, and death. This is what we call the spiral of death. And, we talk about ECMO and all these interventions because we try to reverse the spiral of death and stop it. Because once we advance too much into the spiral, it becomes hard to reverse, it becomes irreversible, especially if you get into the obstructive shock and the hemodynamic collapse. So, if we know the pathophysiology, then the use of ECMO makes perfect sense, right? Because ECMO is our fastest way to offload the RV, to restore hemodynamic stability, to restore end-organ perfusion, and have time for venous decongestion. In the ECPR situation, it also buys us time for neurological outcome determination, especially as we talk about other therapies, evaluate for chronic diseases, and in hospitals where we have a PE response team, it gives them time to meet and talk about next steps. So it makes sense to use ECMO for PE, especially in the massive PE. And again, even though we talk about it today, it's not a new modality for PE. Actually, the first case for ECMO for PE happened in 1995, and then that period up until 2000 was exploring the feasibility of using it more and more. The same thing in 2006, 2017, trying to expand the use of ECMO, but the prime time for ECMO for PE was around COVID time. One, because we had more hypercoagulable patients, more PE, and we also became more familiar with ECMO as a therapy as we had more ARDS cases. So that was the prime time, and then from 2023 to present, we start integrate them more and more in their formal recommendation. So speaking of recommendations, where does ECMO for PE stand? This is the 2019 European Society of Cardiology recommendations, and it tells you that ECMO may be considered in combination with surgical embolectomy or catheter-directed treatment in patients with PE, with collapse or cardiac arrest. Granted, it's only class 2B with level C evidence, but I'm assuming the newer recommendations that are due very soon will have probably stronger recommendation for the use of ECMO in PE. So, again, why do we need to familiarize ourselves with ECMO for PE? Because you see the trend. This paper that was published just a few months ago looked at the global trend in talking about ECMO for this disease process, and you see the number of publications talking about ECMO for this disease process that is just in a sharp increase over the past few years. You also see that most of these papers come from the US, and what's interesting here, this frequency density plot, you see that the most co-occurring terms nowadays in PE literature is ECMO. So you're going to see more of it in the future, and we need to talk about it. Now, when it comes to ECMO for PE, I think there are three main questions we have to ask. Should we do it proactively versus reactively? Should we just wait until the patient gets into the shock state and the ECPR to do it, to try to minimize the side effect associated with a long ECMO run, or should do it more proactively? So, before we talk about this, is there a golden hour? Is there a time where we should start ECMO for PE? Unfortunately, we don't have one, but we do know one thing, that the mortality of PE is a slow rise up until you get into the shock state. Once you get into the shock state, once the lactates start going up, once you start adding more and more inotropic support, then once you get in the cardiac arrest situation, you're talking about 70% and higher. So this is why we should not be waiting to get the patient to the cardiac arrest and this ECPR situation, and think about cannulating these patients early when they get into the shock state, when you start increasing your inotropic support. Because also it's very important to realize that 70% of mortality related to PE happens within hours. So when these patients go down, they go down quickly and you don't have much of time to intervene. So that's why we like to do it early. So that's the first question when it comes to ECMO. The second question is, what are the different goals of ECMO for PE? Should we do it as a standalone therapy, basically waiting for the intrinsic fibrotic pathways to kick in and take care of the clot? Granted, if you do that, you'll have higher ECMO or longer ECMO run, more complications. So should you do it as a bridge to therapy, or should you do it post-treatment for end organ recovery time? So I'll show you what we have in terms of the data. So this meta-analysis was a group of 39 studies looking at more than 6,500 patients and compare the different strategies of the use of ECMO for PE. The one thing they showed that ECMO actually works for PE, especially in the cardiac arrest situation, but what's the different strategies? So you see that they were able to show that the best outcomes and the lowest mortality was when you combine ECMO with catheter-directed intervention, especially mechanical thrombectomy. With surgical embolectomy, it still works, but the worst outcomes were when you combine ECMO with systemic TPA. You give TPA on someone already on ECMO. So that was the highest because of bleeding complications. ECMO as a standalone was not recommended, and it had higher mortality rates. So the conclusion of this meta-analysis was ECMO works for PE, but do it with other interventions. Don't do it alone. This is another study, another retrospective that looked at almost 3,000 patients and categorized patients into both the high-risk PE and the cardiac arrest PE. So the high-risk PE, what they were able to show that ECMO plus thrombolysis-based reperfusion had the best outcomes. Those with mechanical reperfusion, not really significant improvement, and ECMO as a standalone was a bad strategy. In the cardiac arrest situation, ECMO as a standalone, even that works. But the best outcomes, again, were ECMO plus thrombolysis-based reperfusion, and ECMO plus mechanical reperfusion showed a trend towards improvement, but was not significant. So the conclusion of this paper was ECMO may be a valuable supportive treatment in conjunction with reperfusion therapies for PE. I know, we met some of you last year in New Zealand, so I also want to catch you up with the new literature since we last met. And here's a number of studies since last December. Most of these were smaller studies, but I think it's worth noting. The first one on the left here, it's a Chinese paper that looked at only 11 patients. But what was impressive about this paper that all the 11 patients actually had cardiac arrest, and they had ECMO after cardiac arrest. All of them survived to decannulation, and the 90-day mortality was in the 27%, which is impressive in this patient population when they combined ECMO with mechanical thrombectomy afterwards. You see also significant improvement in the RV to LV ratio during on-table in the procedure, as well as significant improvement in the PA pressure. There's another paper coming from Texas, again, only 19 patients, but more than half of them had cardiac arrest, and almost half of them were on 3 inotropic support. So very sick patients, and 15 of them survived to hospital discharge. Again, smaller studies, but shows you that ECMO works, and do it when you combine it with other treatments. So far we know that do it early, and do it with other reperfusion therapies. The question is, when to decannulate? I have no really answer for you, as all we know from the literature, do it as soon as the patient allows you. Do not wait for a pristine picture, and once you have the congestion start to calm down, the end organ perfusion indices are favorable, it's time to do it. Because again, you try to balance the risks of a long ECMO run versus trying to wait for a pristine picture. And from the studies, from the studies that I showed you earlier, the average duration for ECMO run for PE was around 4.4 days. The length of stay in the ICU was around 12.6 days. Again, you try to minimize the complications, which are frequent, right? So this is looking at more than 2,000 patients, and the rate of complications in this patient population was up to 36%, whether it is bioinjury, whether coagulation dysfunction, limb injury, renal injury, and pulmonary injury. So decannulate as soon as the patient allows you. Now I want to spend a little more time on thrombolytics, because we always get the question from the ED that, my patient coded, by the time you guys got here, we had to do something, we had to push TPA. Is that a contraindication for ECMO, or is it late to do ECMO for PE in this case? So this is a paper coming from LabTA from Paris, basically looked at 90-day outcomes in patients who received TPA prior to cannulation for PE versus those who were just cannulated with no TPA, and there was no difference in terms of significant difference in terms of 90-day mortality. So the conclusion for this was TPA is not a contraindication for ECMO for pulmonary embolism. And there's another paper that, even though I'm not a big fan of this strategy, but this is another Chinese paper that looked at 13 patients who received TPA on ECMO, and most of them survived. 75% were discharged from the hospital. Of course, it's a high risk, but when you do it right, it works. And this is the same paper that I showed you earlier, the ECMO plus thrombolytic base reperfusion, it can still work. So TPA is not a contraindication, and you can still do it. So far, I limited it to the massive patients, right? Those patients in a shock state, those on inotropic support. But keep in mind that PE patients do not follow boxes. It's a continuum of deterioration, right? So keep in mind that some patients can deteriorate quickly, and we know some phenotypes of these patients. And I'm going to talk about the next slide. But once your PE patients start becoming in a normotensive shock state, you get an echo, you see the cardiac index to be suboptimal. Once they become a little hypotensive, and even though they look stable, but you're adding slowly inotropic support, maybe you should pay attention to these patients. And we have very low threshold to have prophylactic sheath placements, especially when they go to the cath lab, because at that point, they can deteriorate, and we have a faster way to cannulate when we can. But who are the patients that do worse in the submassive group? So we know that, again, patients in the normotensive shock patients, so those when you get an echo and you have suboptimal cardiac index, those with clot in transit, those with saddle PE with proximal DVT, they can mobilize and they shower more clot and they get a complete obstruction and they collapse, and those with high lactate. So if these patients go to the cath lab for a procedure or to radiology, keep a close eye on them and have very low threshold to put prophylactic sheath in place. So what about future directions? Again, we have a lot of unresolved questions in PE. So we're still working on the timing of initiation, patient selections, and what are the best co-interventions. So some of my conclusions, PE is a dynamic disease that requires a nuanced approach. PE intervention is rapidly developing, and you'll see more of them in the future. ECMO does address the pathophysiology of PE and can help cool things down. Do not wait for the ECPR situation. When you do it early. And when you do ECMO, combine it with other reperfusion strategies, and always try to balance the benefits and the potential complications. And with that, I'm going to end, and we can talk about questions after. Thanks.
Muchas gracias, doctor Omar. Para seguir con este bloque, el siguiente tema va a ser presentado por el doctor, lo tengo acá, disculpen, Paul Nixon. Él viene de Australia, del Albert Health, from Australia, y él va a presentar la importancia de un equipo de corazón y un equipo de shock en el manejo de shock cardiogénico. Doctor Paul Nixon.
Okay. Thank you for the introduction. Thank you very much for the organising team for inviting us over here to participate in this great symposium that you're running today. I'd also like to thank Professor Dion Stubb, who lent me some of his slides that I'll show here and some of his research that he's done over a number of years. I was asked to talk about cardiogenic shock. You've heard different people talk today about, teams discussing cases and working through plans and individual care for patients. So when you think about this is a very obvious sort of concept to get people together to talk about the best plan for a patient. But fascinatingly, this has only really been researched in the last decade or so. So I don't have any conflicts to declare. But we're going to start with just a case, and I think this is just a nice way to get the story going. So, a 62-year-old female presents to a regional centre about 6 hours from Melbourne with a STEMI, a large anterior STEMI presented to the hospital in pulmonary edema, in cardiogenic shock. Blood pressure was in the 90s, in the 80s. No cath lab in this regional centre, so the patient was thrombolised, but essentially a failed thrombolysis. So was intubated and transferred to our care. On arrival, in cardiogenic shock, on a moderate dose of adrenaline, noradrenaline, MAPS maintaining in the 60s, ongoing ST elevation on the ECG, this is a number of hours later. On a ventilator, bit of pulmonary edema, FiO2s in the 50s, troponins 44,000, lactates 3, and has really only made sort of 15 mils of urine an hour during the transfer. So not surprisingly, transfers to the cath lab at this point, and this is what the cardiologists find. So for those that don't do interventional cardiology, this is reasonably nasty, triple vessel disease. So what do we do at this point? They're jumping forward on their own, I apologise. So diffuse disease, non-amenable to PCI. Discuss with the surgeons. Unfortunately, they're in theatre at the moment, doing another case, not available, and the decision's made that we are not going to have the ability to do this, so we're going to put this off for at least 24 hours. Sorry, they're jumping forward on their own, I apologise. So a balloons pump is put in place, and then the patient is transferred to the ICU for stabilisation, in inverted commas. What happens? 24 hours later, we've still got ongoing signs of ischemia. We've got the troponin that's going up. We're now at sort of 85,000. What is the plan at this point? Well, we push our surgeons to come back in to do a case in the middle of the night on a Sunday. Spends 11 days in the intensive care, but survives to home discharge. So on reflection, and this case is from a number of years ago, multiple phone calls were required. Identification of triggers to get the cardiologist involved and the cardiothoracic surgeons and the intensive care team. It wasn't coordinated very well. Was it the correct choice of support, a balloon pump without the ability to go to theatre straight away? It was probably an ultimate delay in the definitive treatment. Could we do this better? So that's the question. So, cardiogenic shock. We've spoken about this a little bit already over the last couple of talks. Very high mortality, reported up to 50% in some series. Why does it happen? This is the spiral of death that we just heard about. Low cardiac output state, end organ perfusion problems, coronary perfusion gets further deteriorated. We then get whole body ischemia, end organ dysfunction, multi-system organ failure, worsening cardiogenic shock, and eventually the patient dies. So we're really trying to get in before this spiral gets too far down to intervene and work out what the best choice and the best option for our patients is. There's a fair bit of work that's been done to try and categorise patients with the Society of Cardiovascular Angiography and Interventions scaling system here from an A to E system. And this is really useful in terms of it's a scoring system, if you haven't used it, that looks at physiological, biochemical, hematological changes. Is there a way to stop the slides from automatically going forward? I apologise. Otherwise I'll have to keep clicking back. And each of those levels, A through to E, there's a mortality that's associated with a patient getting to those points. C is the period where you're starting to use some inotropes for these patients. D is where we're really, what we would consider the time frame where you'd be thinking to use mechanical supports. This is patients that are on moderate to high dose inotropes, ongoing cardiogenic shock, end organ perfusion problems, lactate that's starting to rise. And then E are the patients that are either in arrest or peri-arrest scenarios. The causes of shock can be a whole lot of things. In the adult population, predominantly LV dysfunction, but we can have RV dysfunction, we can have ventricular ruptures, we can have tamponade, and understanding what the cause of the shock is required before you can really work out what the intervention requirement would be. And sometimes there's a lot of overlap, particularly with patients like this one we just presented, where there's sort of severe triple vessel disease. So what can we do about this? We've known for many years, these studies are from the end of the 90s, that interventional cardiology saves lives. So getting these patients to the cath lab. We know that the early shock trials showed that patients going directly to the cath lab, early revascularization saved a lot of lives. What else can we use though? What other devices are there out there? We've heard a little bit about the balloon pump already today. I'm assuming it's used here in Chile like it is around the world. There's not great evidence for it though, to be honest. So the big studies that have been done, 600 or so patients randomised, looked at the difference of mortality at 30 days. These were followed up for another 6 years. These studies didn't really show any significant difference in mortality around the 30-day mark, but maybe there was a role for some of these patients going directly to cath lab with a balloon pump in. We've got ECMO. That's what we're all here for, talk about ECMO. There's been a couple of reasonable-sized studies that have looked at using ECMO acutely in cardiogenic shock. So this is the ECMO cardiogenic shock study. Looked at about 120 patients randomised to receive ECMO either pre-cath or immediately following a cath. The composite outcome was looking at mortality or the requirement to go on to further sort of durable support. And at 30 days, again, there was no significant difference. One of the problems with this study was that there was a significant amount of crossover, so around 40% of patients who were in the non-treatment arm ended up getting ECMO, and maybe that made a difference to the results. Another decent-sized ECMO study was the ECLS shock study that was published in 2023. This time we've got about 420 patients randomised. Again, there was a fair amount of crossover, about 12 or 13%. And again, this study at 30 days didn't show a clinically significant or statistically significant difference in mortality. A lot more complications in the ECLS group. And one of the criticisms of this study is that almost 50% of the patients that were put on in this study were in that SCAI category of C. So the patients where most of us would probably just continue on with our inotropic support and not consider early mechanical support at that point. What else is there? What else do we have? There's been a recent study just published a couple of years ago from a Japanese group looking at VA ECMO early in cardiogenic shock, but with early use of a balloon pump as well. This was a retrospective data analysis from their registry data, about almost 4,000 patients that they looked at. And this is probably the first paper that we've seen that did have a statistical difference between the 30-day mortality for shock patients with the use of an unloading device, which we heard a little bit about before as well. And then, of course, the Impeller trial came out recently, and this really is probably the first study in sort of 20 years that has shown that there is an intervention that we can use in acute severe cardiogenic shock that probably does have a degree of survival benefit or mortality benefit. So this was used in stem-related cardiogenic shock. About 360 patients, was a 180-day review, for outcomes. And at 180 days, it was about a 46% survival versus a 60% survival. So around a 15% improvement. Interestingly, at 30 days, there wasn't a statistical difference, which is what all the other previous large-ish cardiogenic shock trials had stopped looking at. So you do have to wonder if they extended out to 180 days, maybe there would have been a difference there as well. But we don't have that evidence. So, cardiogenic shock teams, what are they? So generally speaking, they are protocolized approaches to improve the care of patients who present in cardiogenic shock and need decisions made relatively quickly. Who do they consist of? They consist of heart failure specialists, obviously interventional cardiologists, cardiac surgeons and intensive care specialists. The plan is that you have a rapid identification of the shock, the kind of shock that the patient might have, early resuscitation, consideration of early use of mechanical support devices. But the key is here that we've got a multidisciplinary management team making decisions rapidly, not sequentially, so that the right decisions can be tailored to the right patient's care. Where did this come from? The Detroit Cardiogenic Shock Initiative, wow, keeps flying through, was not a big study. It was sort of 41 patients that were, the plan was for early intervention with mechanical support, again in cardiogenic shock patients. A lot of them had it was quite a sick cohort, so a lot of patients had cardiac arrest. Somewhere around sort of 40% of patients at some point had a cardiac arrest before the cath. And what they found was that 85% of patients survived to explant of the device, 76% made it home, and they looked at sort of a historical control group, and that compared to sort of 50%, so 76 to 50%. But it sparked a lot of interest and a lot of thought, and these were sort of some of the conclusions and the commentary that went along with this initiative. So, you know, early identification, down titration of inotropes if they're not required, looking at the LV with echo and in the cath lab, determining whether it needed support, looking at the RV, determining whether it needed support, and they strongly encourage the use of right heart catheter to help with the management of the patient, fluids, inotropes, etc. So this has now been researched over the last 10 years, as I said, with quite a few studies. I'm going to go through a few of them briefly now. So this was a study from 2018. All of the ones that I'm going to go through are based in North America. It's where most of this literature has come from, with reasonable quality studies. So the InnovaShock team again looked at early activation, rapid mechanical supports, hemodynamically guided management and strict protocols. They introduced these cardiogenic shock team into their services, and they compared data from 2016 compared to after the introduction of the shock teams 1 year and 2 years after, and you can see here that they had significantly improved outcomes following the introduction of the shock teams. The next one, a Utah group, again, similar kind of setup. So their shock team, they have a paging system with a cardiologist, surgeon, interventional cardiologist, and the ICU attendings. So they got this group together, they determined whether there was STEMI or no STEMIs, whether they'd put in hemodynamic monitoring devices and then mechanical devices if required. And again, we found that pre and post there was improvement in outcomes, both to discharge from the ICU and also to survival out to 30 days. Next one, we look at the Ottawa team. Similar kind of thing, so the introduction of shock teams, smallish study. They didn't, again, find at 30 days that there was a significant difference, but when they extended that out to 180 days, there was a survival advantage. I better move on because we're getting short of time. The Critical Care Cardiology Trials Network is between the USA and Canada. They looked at 24 centres, 1,240 patients with the introduction of cardiogenic shock teams, and found that, go down to the next one, there it is there. So again, the introduction of the shock teams with the same kind of plan, so rapid multidisciplinary evaluation, invasive hemodynamics monitoring, looking for additional diagnoses. What they found when they compared the centres that had a cardiogenic shock team to those that didn't, they had a lot more use of pulmonary artery catheters to guide therapy. They actually had less mechanical support devices used, and that was predominantly less balloon pumps being used, but more advanced therapies, and that was the tandem heart, impeller, and ECMO use. And again, survival was statistically and clinically significant for intensive care mortality. And then the last one I'm going to go through is the NCSI results. So this is published in 2023. North American looked at 80 hospitals, both academic and community centres, the use of MCS as part of their shock protocols, team-based compared to historical controls. And again, they found that a significant increase in survival from around the 50 to the 70% mark with the use of the shock teams. So it seems that the evidence is all pointing towards a reasonable result from having a team that you can put together rapidly to determine the cause of shock and then the interventions that are required. But not all shock is cardiogenic. One of Dion's studies was to look at about 3 million emergency calls to our emergency services in Victoria, and then to follow as many of those patients up that they could to their discharge and their diagnosis that they had at the time of presentation to ED. And it turned out that about 25% of the patients were cardiogenic shock. Another quarter or so were septic shock, hypovolemic shock, and then others such as PEs, obstructive shock, or toxidromes. What they found was that, consistent with other literature, cardiogenic shock was the worst category to present in, with the highest mortality compared to the other causes of shock within the emergency department. So up to 40% mortality out of those patients. So what have we done in our department? We've created a system where we can, with 3 clicks of the button, we've got an app on our phone. We can conference call the important people required for the management of these patients. So a little bit of IT genius. We pull online rosters between our cardiologists, surgeons, intensive care physicians into an app that we can press one button and be able to have a conference call about a patient. So a nice rapid way to be able to get the people that are required to the bedside or on the phone just to discuss through the findings and really to talk through what the plan is for the patient. What are we going to try first? If that doesn't work, what's the next step? If that doesn't work, what's our plan C for this patient? So in summary, shock teams are an increasingly important, seem to have an increasingly important role and are now being rolled out all around the world. They're a system within a big functioning system. The keys are to identify the etiology of the shock, to resuscitate early, to appropriate timing of coronary angiogram, to go hard early before we start that spiral, which often, but not always, will involve mechanical support. To think about invasive hemodynamic monitoring to help guide therapy. So this is, there's a lot of reports about the right heart cath still being underutilised, and I would agree with that in the Australian system for sure. And then obviously to identify LV distension or pressurisation and have strategies to think about unloading it. And I'm going to finish there. Thank you.
Thank you, Dr. Nixon, for your stunning presentation. And the next presentation, el siguiente speaker nos hablará de 3 escenarios complejos en ECMO, acerca de ECMO en trauma, obstetricia, sepsis. El Dr. Matthew Reed from Rochester, Minnesota.
Thank you for the invitation to be here. So we are going to have a crash course on 3 different patient populations that ECMO has been used for. And make sure our clicker works here. And all 3 of these patient populations, they're a minority of what we see as far as patients who go on ECMO. And oftentimes they're pretty high emotion situations and patients that are in shock of various states. And without having enough time to talk about each one of these in detail, we're just going to show some of the outcome data that's out there for these patients and discuss a little bit of the physiology and maybe some practical applications for each of them. So we're going to start with trauma. So who here sees trauma in their ICUs? So a fair amount. And so why would trauma patients need ECMO? So most commonly, about half of the trauma patients that you would see on ECMO, it's because of ARDS. And it could be from infectious etiologies, it could be from transfusion-related acute lung injury, circulatory overload, and we've certainly learned over the last many years that there's this systemic inflammatory response syndrome that occurs in trauma that itself can lead to ARDS. And so if we think about some of the worst injuries that we see, traumatic injuries, both penetrating, blunt trauma, et cetera, looking at this large population, we see that a lot of our trauma patients end up on ventilators and that there's a significant incidence of ARDS. And when ARDS develops, that does increase mortality. And then when we look at transfusion-related ARDS, we also know that the more blood products someone receives, the more crystalloids someone receives, that increases their risk of ARDS. And again, we have increased mortality with that. So it's not, while it's a not as common population to be on ECMO. What did I do there? Well, we're all done. While it's not a common population to be on ECMO, hopefully somebody's going to fix this for me, or did I do something? The incidence of ARDS is real in these patients, and ECMO can be useful. The next several slides we have, there we go. Let's go back here. Okay. So looking at one of only a few studies that have actually looked at the ELSO registry and looked at the indications for trauma patients going on ECMO. Now this one is 8 years old, and the other data we have is about 2 years old, but this is the first one that looked at it, and you can see it's a very small population, percentage of the population that is on ECMO because of trauma. But we know that has grown as an indication, just as the indications for ECMO has grown for all the other populations. So with a range of indexed injuries, you can see that about half of the patients were put on for ARDS or lung failure. Others would be coexisting infection, burns, as well as cardiogenic shock, hemorrhagic shock, spinal cord shock, hypothermia associated, et cetera. And if we look at the survival data out of this, we see very comparable survival percentage to the other populations that we commonly see put on ECMO for run-of-the-mill respiratory and cardiogenic failure. Especially with VV ECMO and with VA ECMO, it's just a little bit lower than some of the specific cardiogenic shock states. And if we look at the most recent data that there is looking at what is in the literature as far as the number of patients with trauma that have been put on ECMO, this is about 30 studies or so that they did a meta-analysis on, so about 1,800 patients. And again, we see that we have pretty good survival, especially with VV in the setting of ARDS, with a list of associated complications. One of the traumatic injuries that people get very worried about in the setting of ECMO is traumatic brain injury. And we get worried about intracranial hemorrhage with all of our patients on ECMO. But this collection of patients here showed that, sorry for the blurriness of the table here, but despite intraparenchymal hemorrhage, axonal injury, subarachnoid, subdural, et cetera, that there's still a significant number of these patients which are being put on ECMO with a pretty decent neuro-intact survival, above 50%. And they found these predictors of survival, so young age, absence of pulmonary injury with their trauma, and then the ability to anticoagulate these patients. And again, sorry for the blurriness here, but these patients also underwent intracranial operations, whether it was EVDs, placed ICP monitors, or craniotomies, and still able to manage these patients on ECMO with pretty decent survival. The last thing that I want to talk about with trauma is this myth of being unable to use anticoagulation is a contraindication to ECMO. So we have all probably seen several patients where we've managed them without anticoagulation because of bleeding, either from post-surgery or from cannulation site injuries or DIC or other bleeding states. This study looked at 200 patients where they did not receive, and they looked at the time period where they did not receive anticoagulation, and it was a mean of 4.75 days, and one of the patients up to 130 days. And they showed that the justification here, what I think is most interesting is that at the top there, nearly 25% of them, it was at an institution where their protocol is not to run anticoagulation routinely. So centers are doing this. They're recognizing that it's not an absolute necessity and that it comes with its own risks as well as the known benefits. And they cited the thrombus complication rate at about 10% for these patients not on anticoagulation, and circuit thrombus at about 13%. So just a quick summary for the trauma. So ARDS is very common. The survival rates are very comparable, and anticoagulation is not absolutely necessary. So we're going to shift to obstetrics. So who takes care of obstetric patients? One or two people. So certainly this is one of the least common populations that we see put on ECMO, but it's a very high emotionally charged state when you have a new mother, young mother, new baby, and in extremis, and ECMO is a growing, or pregnancy is in peripartum period is a growing reason for being put on ECMO. So this data here is a meta-analysis looking at several papers where they had almost 1,500 patients, and they show that they had a survival of 83% on VV and over 60% on VA with a fetal survival of 73%. And if we compare that to our data in our typical patient populations, this is much better. And this paper on the bottom here specifically commented on some complications that occurred during the peripartum period on ECMO, and hemorrhage certainly is one of the big ones, but also thrombus because of the hypercoagulable state that the pregnant mothers are in. This is a nice review paper that was just recently put out, and it goes through some of the indications and the physiologic changes during pregnancy and some of the things that you need to think about when you put your peripartum patients on ECMO. So the classic indications apply to the peripartum patients just as they would anyone else, but specific to the pregnant patients, amniotic fluid embolism leading to cardiac arrest and multisystem organ failure, massive PE, peripartum cardiomyopathy, and then pre-existing pulmonary hypertension and RV failure. So many of these patients, are identified through maternal fetal medicine clinics as having some of these disease states or being at increased risk, and so having the ECMO team involved early in discussions on management of how to deliver, being available for delivery in case of backup needs is a very important thing to consider. Some of the physiologic changes that occur in the peripartum period, so the increased blood volume, increased cardiac output. So this becomes important when you're thinking about the ECMO circuit flow to patient cardiac output, especially in VV ECMO. When you have a higher cardiac output state, and you may not be able to capture all of that on VV ECMO, and trying to ensure that you have adequate oxygen delivery to not only the mother, but the fetus. And the same concerns about hypercoagulability, not just in the peri-delivery time period, but leading up to and then after delivery as well. And then the aortocaval compression that occurs that can cause some problems with cannula positioning, ECMO cannulation initiation, as well as drainage. Some practical tips for your obstetric patients when they're on ECMO. So making sure that while they're in the left tilt positioning, to make sure that they're having appropriate cardiac output and blood flow to the uterus. This can cause problems with your initiation as well as drainage. And then because of the increased cardiac output, they have the higher flow demands, and you may need larger cannulas in place to accommodate that. Pharmacologic management of these patients gets very tricky because of fetal transfer as well as transfer to breast milk, so those are things that you need to consider. And then the balance of the hypercoagulable state and the need for anticoagulation versus the risk of bleeding during vaginal delivery or cesarean. So this can be very tricky to manage and just requires a multidisciplinary discussion to make decisions and be prepared to deal with the consequences. And then the use of fetal monitoring is very important, especially when we're talking about ensuring that the fetus has enough oxygen delivery. And then there's obviously ethical dilemmas that can come about in these situations where you may have maternal non-survivability, but a viable fetus in which you're keeping the mother alive to get the baby to viability and delivery. And I'm sure that there's plenty of other situations where ethics can come into play with the mother and an unborn child. So some quick summary on obstetrics and ECMO. So, the big thing being survivability. Rates are reportedly higher than most of our other patient populations, and that we need to take into account the physiologic changes that occur and have those multidisciplinary discussions to make appropriate decisions for the patient. Sepsis. So all of us see sepsis. So this is something that you're going to see more commonly, and many people have talked about it already, about ECMO and sepsis and this differentiation between high cardiac output and low cardiac output sepsis and the appropriate use of ECMO. So the first thing we'll talk about is VV. And so this study looked at COVID patients and had 278 of them across several institutions. And they came up with a matched cohort of patients that also had COVID that were not put on ECMO. And they saw that the use of ECMO in their cohort compared to the matched cohort led to a decrease of mortality from 60% down to 40%. And this is thought to be because of many different reasons. So decreasing the ventilator-associated lung injury, that can lead to the increased mortality. as well as the decreased need for inotrope and pressor, which we'll talk about here in just a minute, and then decreased RV impairment. So while VV ECMO does not directly support the right ventricle, it does certainly play a role. VV ECMO can play a role in helping the RV manage these situations better. So if we look at the hemodynamics of patients who are on VV ECMO, once in a high cardiac output septic shock, and once they're put on ECMO, we see that even within 2 hours, that the decrease in the inotropic and the vasoactive support necessary to maintain these patients decreases dramatically. And we see that continue throughout the first several days after initiation. So this is probably likely to a few things, but certainly the dynamics that come into play with the intrathoracic pressures and airway dynamics that occur with patients who have ARDS before they're put on lung rest settings, and the increased oxygen and carbon dioxide gas exchange that occurs, leading to the decreased need for these vasopressors. So this is just one example of the indirect circulatory effects that can occur for patients that are put on VV ECMO for ARDS and sepsis. And if we look specifically at the RV, this study looked at 20 patients, and they randomly targeted blood flows to achieve these SVO2 goals to then look and see what happened to the RV dynamics. And so what they saw was that as they targeted a higher delivery of oxygenation with increasing their flows, they had decreased in their pulmonary artery pressures, increased compliance, the PVR obviously going down, but they also showed that the RV stroke work index decreased as you delivered more oxygen. And this makes sense based on everything that we understand about pulmonary physiology and the changes that occur in the pulmonary arteries and the work that that's going to put on the right ventricle. So switching to VA ECMO. So if you look at this study just looked at all ECMO, septic patients, and VA ECMO did not differentiate between high cardiac output and low cardiac output states. They showed a very low survival. And when they matched this with a cohort of patients that had cardiogenic shock, you can see the discrepancy in the survival for patients with cardiogenic shock that had a 45% survival versus those with sepsis with only a 15. So if we look at the patients that have septic shock that could benefit from VA ECMO, and those patients in this study was defined with an LVEF less than 35% and an index less than 3, we saw that those patients here in red that were put on ECMO had a 51% survival versus those patients who did not have this low cardiac or that had this, all these patients had the low cardiac output state. The patients in red were put on ECMO had an increased survival based on increased survival of 51% versus the patients that were not put on ECMO in this same state with a survival of 14%. And this is really the best paper that shows us that there's benefit to this low cardiac output septic shock state for these patients being put on VA ECMO. I think the last study then that I want to talk about is looking at the differentiation between severe cardiogenic shock in the setting of sepsis versus less severe. And this had about 500 patients, overall survival of 36%. So all of these patients, the majority of these patients had low cardiac output state, but they showed that as your EF decreases, your survival on VA ECMO actually improves. So just a quick summary for the patients on sepsis. So with cardiomyopathy, VA ECMO is certainly indicated with ARDS, VV, and did not touch about, but it makes sense that if both of these coexist, that VA ECMO would be appropriate. And there's just a quick summary of all three, and I'm sorry for the quick rush through all three of those, but we got 20 minutes, so that's what we get.
Thank you very much. And la última charla del día de hoy es acerca de, es un enfoque rápido de un caso de ECMO ECPR shock cardiogénico por el Dr. Stefan Biff from Elios Kliniken from Germany.
No, and I'm not talking about PE. It's the other way around. I can just give that talk again. That's probably. In the meantime, I might break protocol. Matt, I can't believe how you can present the obstetric data with like 75% survival in the mother, 75% in the kids, and not point out that you got 150% survival rate in that study. It's like pretty impressive. Let's talk PE again. We can do that. Certainly more refreshing than talking about ethics after 9 hours in a dark room.
¿Podemos poner la primera presentación del bloque, por favor? En el programa está la primera.
Perfect, yeah. So yeah, it's a most refreshing topic after 9 hours in such a room and looking at how the banks are getting a bit more empty. I can see you're seeing it the same way. I'm trying to keep you awake by just keeping up the pace, and so buckle up. We've got a 20-minute crash course where we basically talk about ethics, what it is, if we should use it actually in medicine at all, especially in ECMO scenarios. And obviously there are a couple of questions that came up the last couple of days. I try to fit in these 20 minutes as well about equity resource management, which is obviously quite important. And maybe we got some time for some fancy ethic nerd stuff as well. So let's start. What is ethics? And it sounds like a banal question, but it is actually not so easy. And if you ask people what is ethics, and it's a study from the 60s from Baumhart, who was a business professor, business ethics professor in Chicago, and he asked like businessmen what they understood what ethics is. And if I ask usually in the public, you get something like these kind of answers, which is just like, yeah, it's something about good or bad, but no one really can know what it is. And what people sometimes know is that there's been this famous trolley problem that's sometimes mentioned and been developed also in the 60s by Judy Jarvis Thompson, which basically now people know a little bit as representing the doctrine double effect. It's just like that. Sometimes it's acceptable to have a bit of collateral damage, and that might be ethical, permissible. It still doesn't tell us much about ethics. It's what I find quite funny, and I have the same disclosure as previously. I use a little bit of AI, and it's quite reassuring when I ask AI to produce a video about the trolley problem that AI doesn't really get what it's about. It looks more like a K-pop music video, what we get there. So the trolley problem, I think most of people heard about that. What a lot of people know, but maybe not so many know, is that there's a bit of a variation of the trolley problem, which is much more interesting. Like instead of like having to pull a lever to change the direction of the trolley, what would happen if you're standing on the bridge and there's a very fat man standing in front of you of the bridge just above the track, and the only thing you have to do is push this guy onto the track and you make the trolley stop. Would you do that? And funny enough, the answers change quite dramatically if you have to push a lever or if you have to push a man off the bridge. But if you consciously break it down, it's actually there's the same problem. You just sacrifice one person to save some other people, which then again just raise up more questions. So what are we talking about if we have the same problem but it's two different answers to the same problem? And if we do studies about that, it actually shows that that is really a different problem depending on how you describe it. The perspective matters a lot. So if you do MRI studies and ask people about these two scenarios, If you ask a classic trolley phenomenon, it is much more the dorsolateral frontal cortex that's been used for that. It's more like really this conscious, rational processing of data. Whilst if you have the fat man problem, it's really called the fat man problem, that it's more the amygdala, like more like really the emotional part of our brain that's lighting up in these scenarios. So it is really different depending on how you phrase the question, and even though it is kind of the same problem, which confuses us even more. And if you think about it, it's just what we always do. It's a massive simplification of complex problems. And if you have the trolley problem in a pandemic, suddenly there are so many other aspects that play a role. And we spoke about resource allocation, and if this one man is much richer than the others, how does that affect things? So it is not as easy as these simplified problems would want to make us believe. And we know that from every field of medicine, and that's why we don't have positive trials, because we're just trying to simplify a lot of things. Most people just mix up ethic with moral, and that's a fundamental mistake that we are making, because it is something different. There is an overlap between ethics and moral, but it is just more. It is just like a bit of a step back, looking more rational really at things, trying to implement sociological factors, society, legal factors play a role, faith plays a role, economic factors play a role as well, and just trying to get a more secular view of these kinds of things, secular assessment, and you can come from to a completely different point of view, whether you look morally at something or ethically at something, because what I said, ethically pushing the guy from the bridge is the same thing, but morally we feel just much more against it. Mainly in ethics, it's like there are two different principles that play against each other. So one is what we are always trying to do, because we know it is great utilitarianism, trying to really do what's best for most. But then we also, and that's what this example also shows so well, there is some intrinsic value in the intrinsic action that we're doing, and this is called deontology. And these two fight against each other, and it's quite good timing, because I just heard that these two teams are playing tomorrow, I think, in the final or something like that. It's like, yeah. So that's what happens. Is ethics useful in intensive care? I could just claim, yeah, there's a lot of data, there's like studies that gives like good satisfaction, reducing like aggressive therapies, reducing costs. Unfortunately, these are all retrospective studies. And also, I mean, this should say, like, we should all just do ethics. But, I mean, who of you ever has done an ethics consultation? Who has ever had any experience? So I could ask you right now how it feels to have an ethics consultation, but most people give me that kind of answer. It just feels like, yeah, you ask them something, and then people, old guys going into a room, and some smoke is coming out, and in the end there's someone coming and it's just like, yeah, just do whatever. That's the common reputation that most clinicians have, actually. Again, a disclosure, I do most of my work in ethics, so I studied my master's in the US and did some work in New Zealand and Germany, and at least that's what we see in these countries. Specifically in the US, there's a very good reason for that, and that's because of how bioethics evolved in the US. And that's a very famous case, it's Quinlan. This was a very unfortunate teenager who had an overdose, ended up in a persistent vegetative state in the 70s, and the parents wanted to withdraw life-sustaining treatments, and it was just not possible to withdraw life-sustaining treatments in the 50s. They went to court, lost first instance, then they won in the end, and the court judgment from the Supreme Court said at that point that physicians should just consult a medical ethics committee, and if that agrees to withdraw life-sustaining treatment, then it is actually permissible legally, which kind of is common sense, but actually you should not even need that. Well, anyways, that happened, but it was a Supreme Court judge who said that, and that led in the 1980s, when about 1% of US hospitals had an ethics committees, that suddenly everyone wanted one, and 4 years later, 50% of all US hospitals had ethics committees. And what that means, all the people who went onto these committees, they were not trained ethicists. They were people who think, I got a good sense of moral. What I said before, moral and ethics is not the same. And just looking morally at these things, it's just not really helpful. And why it's not helpful is because ethics is not always intuitive. If you're faced with ethical questions, it's not always like what you think is right. Like Roger Fisher made a good example. He was a master in negotiation. He founded the Harvard negotiation program like try to negotiate peace in the Middle East. So you could say like, okay, maybe he's not that brilliant when you look at the outcome. But what he did for the Pentagon, a lot of work, and they asked him like, okay, how can we make our use of a nuclear arsenal a bit more safe? And he proclaimed, yeah, okay, what you should do, you should just look for a volunteer. He swallows a capsule, or you implement a capsule in his belly with a launch code, and the US president just has to carry a big knife with him, and when he wants to launch a nuclear strike, he just has to say, hey, sorry, Gary, it's for good of all mankind, stab him in the stomach and get the capsule out before he can launch the nuclear strike. And the response from the Pentagon was that it's horrible. That would clearly just not, it would affect his judgment in this situation. It's like, okay, he's killing one person to kill millions. So it is not intuitive if we're trying to make ethical decisions, and that's why it's so important to have like really a bit of proper training in that. The other thing is, what you should know, that if anyone doesn't know Daniel Kahneman, I can really recommend these books. It's like the best description about like our biases and noise that we can make. But there is a difference between good judgment and accurate judgment, and judgment is not thinking. That's completely different. There are different parts of our brain and different things that we process when we try to judge or when we try to think. It's a lot of things we're just doing intuitive, and always when we do intuitive judgment, we're using heuristics. We're trying to simplify problems, and we're not really thinking about these problems, and that's really a problem. So I say like, okay, you just need trained ethicists. Unfortunately, I have to say that's not entirely true. If there's one study, it's quite old, but they actually looked at really good trained ethicists. They had like a master's and PhD degree in bioethics, and looked like if you would give every ICU patient an ethics checkup, then it wouldn't change anything on outcomes, but it also doesn't change anything on costs. All the things the retrospective studies for said it costs exactly the same. You would say she gets the same amount of ventilation days, artificial nutrition, and if you ask like how happy are you with the treatment, basically in the intervention and control arm, there were actually a couple of patient families who are more happy without an ethics consultation than the ones that received an ethics consultation. It's single center, but it actually just shows like you certainly should not give every single patient an ethics committee. So I still think it makes some sense in ECMO, in the context of ECMO, because what we do in ECMO, we are sometimes really facing very complex problems, and the easy solution is just to put the patient on ECMO. And that's kind of something that just got trained into it. That's how the system looks like. That's how the system is set up. It's just because the system looks more into the technologies. What can the technology do? And not what can proper thinking about an intervention do. And that's because it's easy to assess like really the need, the cost and the benefit of a technology, but you cannot really assess the cost or the benefit of like proper thinking about something like that. And that's one of the things that led to this massive increase of use of ECMO, and the sometimes really unusual use of ECMO. And ECMO is complex. I stole this slide from Andrew Stevens, who's unfortunately not here today. He was one of the inventors of ECMO-PAL. To those who don't know it, it's like an AI or a program to predict mortality in VA and now in VV. ECMO as well outperforms every old prediction models that we had before. It's trained on the whole ELSO database. So when he trained his programs, this is usually how we assess problems. We just get like a little bit of like some variables, some data, and then we've got good outcomes and bad outcomes, and we see a correlation. That's how we do that. And then he fed it like with the ELSO database and looked at outcomes for ECMO patients, and that's kind of how the outcomes for ECMO patients look like. And for a human being to make any kind of sense out of that is just not really easy. You don't really see a clear correlation. And that's what we do, unfortunately, in all research a little bit, simplifying problems. We have to get a little bit away from that. But that makes it just so challenging and increases like insecurity, and increases uncertainty. And that's why we need to just not, without thinking, use these technologies, but have a little bit more availability to think about that. That's why I think it is quite important to have some ethics input in a lot of ECMO patients, because they are quite extreme. In the context of eCPR, I think it's a little bit easier because it is so fast that you have to make these decisions that you really have to simplify, and everyone does that. Everyone uses now some kind of inclusion-exclusion criteria for ECPR. You have to make a decision on the spot. I'll take that out. But even ECPR, if you look at our data in our institution, I don't know any public available data of that. Actually, when we retrospectively look in our ECPR candidates, almost all of them, we are just like, maybe we have like a bit too generous on this one. So we should think about this as well. So we're setting up the strict criteria, and it looks like you and the Alfred are doing much better than we do. So it's probably not a universal problem, but just ours. But the worst thing that I heard was just like, say, we had this patient who actually fulfilled all criteria, and I came back, then this patient had not been put on ECMO, and I was like, why hasn't been put on ECMO? It was a 57-year-old who had an in-hospital cardiac arrest, was brought down immediately. ABGs looked good, and the consultant who was on just said, like, well, yeah, he had a high nail score. It's like he came from like a very horrible home, like very poor hygiene, and his nails looked horrible, so he said, like, because of that, he probably had a poor outcome. So that's how we divert from our scoring system based on our intuition in this situation. That's probably not the best way of doing that. For the patients that we put on normal ECMO, I would say, there are other systems, and we got a bit more time to think about that. I stole this from Julia. She gave the talk about like how you should maybe decide who should go on ECMO or not. It's a little bit more complex because you have some time to think about that. She stole that a bit from the hot, crazy chick diagram that's been popular in social media for some time. There are some attempts to bring some considerations, like in these difficult cases, whom we should put on and should not put on. Graham McLaren brought some recommendations, like how you should assess, like really availability in your center, resources that you should have, trying to make it as objective as possible. And that is exactly where I feel like ethics is probably needed a little bit more, because yes, I cannot disagree with any of the things that he's saying there, but there's an important thing that is missing, and that's some work we have done about like a possible decision tool. It's first of all, our scoring systems, we can't give them a definite number. It's usually a gray zone. So we like to work a bit more in colors and put it a little bit more on the left, a bit more on the right, because an accurate judgment we cannot make in these situations. But the important thing is what we put on is like a criteria for exceptional circumstances. And it's just to raise awareness that most patients put on ECMO, there are some exceptional circumstances. And that can be a lot of things. That can be, oh, we had just like 3 patients with a similar situation and they all died on ECMO. Yes, it's a classic indication, but we just, for the team moral, cannot do that again because the next ECMO patient needs to be a survivor for our team, which would never fall into any of the other categories, but it is an important thing to consider and just to be aware of. And just by being aware of, you maybe just simply, okay, this should not be a reason, but it needs to be addressed, it needs to be communicated with the team, and the team needs to be told about that. And if you look at the classical factors that we implement in bioethics, like the medical factors, patient preferences, quality of life, and then external considerations, and also bioethics, deontology, that kind of gets all of these factors in there. And so we were planning to use this and did some study on really if it improves some markers, especially on satisfaction from staff and patients and families, because it kind of ticks most of the boxes that you should tick when you put patients on ECMO. I didn't plan to talk on that, but there have been so many questions about like resource allocation. And obviously resource allocation is in every of these scoring systems. It's something you need to consider, and it's something you need to consider of why you want to do it, why you don't want to do it. In the US, ECMO use has been gone up like dramatically since it became a billable code. It's like, okay, that's not really the indication. Just being aware of that might help maybe for that. So I think every society on its own needs to think about whether or not ECMO and for which patients ECMO and what kind of outcomes are reasonable from a healthcare economic perspective to accept. I'm very COVID fatigued. I don't like talking about COVID, but the one thing that came good out of COVID is that actually exactly that question came a bit in the public eye and people were talking about this topic a bit. And there has been like a lot of agreement, basically worldwide, that there are some fundamental values that you should consider but there's horrible disagreement on how to implement that. And that makes sense because societies are different, values are different in different societies, the religious impact, the faith impact is different, and the resources are different in different societies. So you have to really have some regional assessment of that, ideally with someone who is trained in bioethics to look into these questions really and make some local policies, and you cannot just copy policies from other centers on the other side of the world because the situation is just different there. And just to really point that out, like everyone says, like ECMO really kicked off after the CSER trial, but even the CSER trial, when they did it with the intention to launch an ECMO program. It was really clear. So in the CSER trial, they have a cost analysis that looked at quality or cost per quality for that. Otherwise, the UK would have never been able to launch the ECMO program. And actually, what actually launched the ECMO program in the UK was that there was a very young and popular, like a girl from a very famous and well-connected society that got severely unwell, had ARDS, and there was no ECMO in the UK, so she got flown to Scandinavia to get ECMO there, and then there was a newspaper report of that, and questions were asked, and then they got funding for the CSER trial. So one of the solutions for that I found that I found quite good is really going back to where I spent the last 7 years was in New Zealand. We all think of ourselves like we use the Declaration of Geneva. We are looking after our patients. In the Good Medical Practice guidelines from New Zealand, they phrase that a little bit different. They say we should strive to use resources efficiently, consistent with good evidence-based patient care, and balance the duty of care to each patient with a duty of care for the community and wider populations, which I find is a really nice and honest description of what we actually do. We are not just responsible for the patient, we're responsible for the resources we use, for the damage we use to the environment. I don't know who asked these questions. All these things, they should actually be implemented in our decision-making. And it doesn't stop there. If you look at ethics and ECMO, it goes on and on. I mean, it's quite interesting because whenever I go to the US, it's like they're blown away that we don't even have a DCD program in Germany. We don't do DCD at all. We just do donation after brain death. And if you then start talking about the ethics of normothermic regional perfusion, that's a really good topic where you can spend another 5 hours talking about in the relation of ECMO. So I think bioethics in ECMO is like an absolute mandatory important topic. And I hope you guys got a little bit of a take-home message. It's mainly just that you should be aware of your own biases. We all have biases. We are horrible statisticians. We are all led to heuristics. That is just something we need to be aware of, and just step back and be aware of our biases, and sometimes just be aware that there is some uncertainty and embrace this uncertainty and include that in decision making, and please don't use a nail score when you're deciding whom to put on ECMO. Thank you.
Thank you very much. En honor al tiempo, se abre la sesión de preguntas. Tenemos 5 minutos para preguntas de la audiencia. ¿Hay una? Ahí hay otra. Y otra allá al fondo.
Hi. Con respecto al shock séptico, no sé si alguno tiene alguna información con respecto al ECMO versus hemofiltración, si es que uno es mejor que otro o tienen que usarse en conjunto.
Is there any evidence of using ECMO versus hemophilia or sepsis?
So I'm not aware of any studies that look at one versus the other, and somebody can correct me if I'm wrong, but certainly there's plenty of anecdotal evidence of us using hemofiltration with ECMO to improve the septic situation, whether most of the time vasoplegia. But yeah, I'm not aware of any head-to-head studies or anyone that's looked at matched cohorts or anything like that.
Gracias. Rodrigo. ¿El micrófono acá?
Una pregunta, cuando hablan de ECMO, VA y trombolítico o trombolisis simultánea, ¿se refiere a que uno instala el ECMO VA e inmediatamente le da alteplasa? ¿O cuál es la estrategia que tienen ustedes hoy para enfrentar un PI masivo? Instalar el ECMO, por ejemplo, un paciente que hizo un paro y está en choque cardiogénico, y usted sabe que no va a tolerar lo que venga sin ECMO. ¿Cómo usa usted el trombolítico? ¿O va a trombolisis mecánica? Ese es el punto que quería.
Sure. So for PE management, for the massive PE management, so what we start with nowadays, if you have high risk on a high inotropic support, elevated lactate, if we're able to take him to the cath lab and they're still in a stable state that we can rush into the cath lab and quickly, or the radiology to do mechanical thrombectomy, that would be our preferred. But if we do and there are ECMO candidates, we have to have our cardiac anesthesiologists available, ready to go in case we have to crash them on ECMO in the procedure. So that's one way of doing it. If the procedure is not available and we need to still stabilize them, we do ECMO, send them to the procedure suite, do the procedure, and then take them to the ICU. And once things calm down, we talk about decannulation. TPA on ECMO, as I mentioned, it is done. It's being done elsewhere. I don't think it's the safest way, and we rarely do it. So, in these studies, we stabilize the patient on ECMO and waited for a few days, but if still the shock state is not improving, that's kind of the cheapest way, especially in centers when they're not available to have the procedure list, when they don't have these procedures, to give TPA. But, as I showed in the graph, we're moving away from all of this and just fixating either on the mechanical thrombectomy, because we show the data that those are pretty safe procedures. You have immediate improvement in the PE pressure on table. You have immediate improvement in the hemodynamics. And even if you don't put the patient in ECMO, we alert the ECMO team, we alert the cardiac anesthesiologist in case we crash on ECMO.
Gracias.
¿Arriba?
¿Aló? Tengo una pregunta del punto de vista práctico. Porque al final, si uno escoge una estrategia en tromboembolismo pulmonar, ECMO más trombectomía, suena como bien genérico, pero a la hora de conectar a un paciente con las cánulas venosas, cánula arterial, ¿cómo se solventa también poner, particularmente la trombectomía mecánica, por ejemplo, el Inari, que tiene una tremenda cánula, cómo sortean el tema de la interacción entre las cánulas o una cánula tan grande pasando también con otra cánula en la vena cava inferior? ¿Y existe algún riesgo o algún procedimiento en relación al manejo del perfusionista, por ejemplo, en el caso de que uno logre sacar un trombo y que no se pueda pasar hacia la cánula de extracción del ECMO? ¿Cómo se solventa eso desde el punto de vista técnico? ¿Cómo lo han hecho ustedes? Eso quería...
So from a technical standpoint, to remove the clot, I would defer that to the interventionalist. As an intensivist, things we look at, it's done, and you can go on the other side in terms of where to access. And the one thing we kind of look at when we do these procedures is just being careful, because one risk of doing mechanical thrombectomy on ECMO is air. So we just have to be careful kind of when they're ready to suck the clot, we reduce the flow, have them do it, and then go back up. But in terms of the technicality and how to suck the clot, and I would defer to Dr. Bafar and his... you just basically suck it. Yeah, 12 French. And also, more importantly, this is one way. I mean, as I show in the slide, there are different devices. We use Inari, and that's just suction device. But there are other devices that use ultrasound waves to try to fragment the clot and, increase the surface area for which the medication can work. But that's not very common at Mayo, at least.
mientras llega el micrófono a la otra esquina del auditorio, una pregunta como cirujano. ¿Existe algún escenario clínico en que ustedes crean que la trombectomía mecánica percutánea no tiene un rol y hay que definitivamente hacer una trombectomía quirúrgica, llamar al cirujano, abrir el tórax y sacar trombos?
Yeah, so there's definitely still a role for surgical embolectomy. So specific examples for that would be anyone with, even though we've done it, but maybe on the higher risk, anyone with clot in transit, is if there's any component of acute on chronic clot, then to try to do it percutaneously, you can cause more trauma and more injury. So I would say that the two examples and just in the past couple of months, literally 2 months, I had 2 cases that I had to send them to the surgeons in the OR because of clot in transit and because of acute on chronic situation.
Thank you.
I just want to add to that additional, especially when it comes to surgical thrombectomy, there's a huge difference depending on the experience of the center. That is, it is a quite advanced skill, and you see massive difference in outcome depending on how often the center is performing that. And I think that's also something you need to take into consideration there.
Thank you. ¿Micrófono llegó? Sí.
Hola, quisiera hacer una pregunta respecto al uso de ECMO en escenarios específicos. Me refiero si tienen experiencia o conocen casos de uso de ECMO en pacientes grandes quemados, respecto a preocupaciones como, por ejemplo, inserción de las cánulas en sitios quemados, las infecciones y la necesidad de múltiples pabellones en estos pacientes.
Yeah, so my experience with burn patients in ECMO is at a large burn center where, ARDS is a very frequent complication after burns because of the SIRS response, the volume resuscitation necessary, and the associated infections. So with these patients, I think some of the things that you run into are management of your cannulation sites. So oftentimes these are being put through, debrided tissue. And, just as they're prone to infection everywhere that they have wounds, you still have that, increased risk with your lines being there. There have been times where these patients have needed their cannulas moved because of infection in that area. The other thing that can be very complicating is when you're doing this amidst their resuscitation and still needing more volume, and all the third spacing that occurs. And so you can have difficulty with managing your flows and maintaining high enough flows. And also, depending on, the state that they're in, days after their burn, they're still, very high cardiac output state. You can start to have issues where you may think you're not delivering enough oxygen. I'm going to talk about that tomorrow, high cardiac output states in VV ECMO. But it certainly can be complicating to manage these patients. I don't recall the data right offhand, but it certainly burn patients, there are plenty of burn patients who survive after ECMO, but their mortality is pretty high compared with some of the other patient populations.
Bueno, creo que es suficiente por hoy. Ya son las 5 y algo de la tarde. La organización me pide que por favor los cite o les diga recuerde amablemente que mañana a las 9 de la mañana parte en punto la siguiente sesión. Que tengan buena tarde. Thank you very much for everyone.